फिर ले लेंगे फिर।
इसी में ले लेंगे मैडम। सर वो बैकग्राउंड का
छोड़ दो, जान दो,
नहीं होना
हाँ
चाहिए।
छोड़ दो, छोड़ दो।
मीटिंग आईडी नहीं डालेंगे इसमें, डाले ना वो ये मीटिंग आईडी, और अलग से डाल दूं क्या?
पासपोर्ट मांग रहे लोग, पासपोर्ट।
हाँ पासपोर्ट भी है ना नीचे। हाँ अलग से डालो, एक मिनट, अलग से लिंक है।
लिंक और पासपोर्ट डालो सिर्फ।
हाँ हाँ।
और अब जो आ रहा ना, उनको ज्वाइन करो, आपका वीडियो डिस्प्ले डिसेबल कर दो, शेयर स्क्रीन में जाके इमेज पे लगा दो लगता।
और पीसी से कर रहे हो, वो लिंक मीटिंग आईडी मांग रहा ना। पहले ये है, और ये पासपोर्ट है, मैं डिलीट ग्रुप में शेयर करता हूँ।
दोनों ईडी और वो दोनों कर दो।
ओके ओके।
आगे। ये बाबू जी इस पे ज्वाइन नहीं कर रहे हैं, क्या करें? मेरा हाँ। कौन चला रहा है?
ज्वाइन की जरूरत है, आप वेटिंग में है ना, अभी सबको एक साथ है, सबको एक साथ है। एडमिट आ रवि, नहीं नहीं, एक एक को एडमिट नहीं हो रहा, नहीं।
नहीं, वो ले गया उस आपके इसमें है ना, वो मैडम का मैंने व्हाट्सएप पे भेजा,
हाँ
और कर लो, और पढ़ यहीं से कर ली मैंने।
हाँ, ये लॉगिन कर लो तुम उसके ऊपर व्हाट्सएप। हाँ ओपन ओपन कर दिया व्हाट्सएप।
लाइट्स पूरे होने के आपको लाइट होना चाहिए ये
और नहीं दिखा इसमें।
बटन सब ऑन डाउनलोड करके ओपन करके
डाउनलोड करके ही रखा मैंने, ये पीपीटीज में रखा था मैंने।
ये अभी मैंने व्हाट्सएप पे भेजा। हाँ वो मतलब है धीरे।
दो चेयर मंगाए।
हाँ चेयर उसको बोलने का था, एक टेबल और चेयर पर बोलता था कि तो कैंटीन में से आप बता दो सर करता हूँ मैं, नहीं बोला आपको। अच्छा सुनो मैं क्या बोल रहा हूँ, जब आप शुरू करेंगे तो अभी क्या करो, पहले आप ईमेल डिस्प्ले कर दो शेयर स्क्रीन में, ठीक है, और स्टार्ट हम करेंगे, उसके बाद फिर हम आपका करेंगे।
हाँ मैं इंट्रोडक्शन में क्या आपको कॉल करता ना,
हाँ
मैं फॉर द वेलकम नोट बोल के,
ठीक है वैसे तो।
हाँ
हाँ
है ना,
हाँ
फॉर वेलकम नोट बोलता।
हाँ फिर बाद में मैं बैठ के शुरू
फिर
करता
आप बैठिए, आप स्टार्ट करिए,
ठीक।
उसके बाद में चाहे तो सुबह मैडम को आप भी कॉल कर सकते हैं, चाहे तो मैं भी कॉल, ऐसा आप
नहीं मैं हैंड ओवर कर दूंगा,
हाँ
वेलकम करके सब
जी जी
फिर हैंड ओवर कर दूंगा।
जी जी।
अच्छा आपने वीडियो का स्टेटस क्या है उसमें, लाइट थोड़ा डिम लग रहा है।
नहीं सर ठीक है, अच्छा है, नहीं कोई प्रॉब्लम नहीं,
ठीक है ना,
अच्छा है, मतलब वो अच्छा एलिगेंट लग रहा था थोड़ा।
ठीक। हाँ वो उसमें भी लगेगा, वो भी कुछ यूट्यूब लग रहा है। आपको इससे स्टार्ट कर दूंगा तुम्हारा बिजनेस।
टोटल 45 लोग आए सर।
अभी तक है,
हाँ वेटिंग हो गया।
ठीक है।
पहले ज्वाइनिंग में ले लो स्क्रीनशॉट, उस मेरी स्क्रीन कहाँ पर? हाँ हाँ लाइव
हाँ जी
आता है। Hello? Yeah. Just send me hi on the WhatsApp. I will give the link.
तो ऐड कर लो, ग्रुप में ऐड कर लो,
हेलो,
ग्रुप में ऐड कर लो।
इलाइट CME एकेडमी जहाँ पे आप ये नंबर पे कीजिए व्हाट्सएप पर।
ओके,
वो ग्रुप में लीजिए सर, क्योंकि अपने को इंस्ट्रक्शंस
हाँ
ठीक है ग्रुप
इंस्ट्रक्शन
में।
देना है अपना, ये सबको ग्रुप में
एवरीवन प्लीज ज्वाइन, वी आर टेकिंग
मैं उनको
स्क्रीनशॉट,
व्हाट्सएप लिंक भी भेज रहा हूँ।
वी आर टेकिंग स्क्रीनशॉट फॉर अटेंडेंस।
उनको ऑब्जर्वर को भी ऐड कर दिया आपने ग्रुप में? हाँ हाँ, इसलिए उन्होंने फॉर्म भरे।
अच्छा,
तो मैंने कर दिया, चलो उनको मालूम होगा कितने लोग होते हैं।
अपने दोस्त के नाम पे
तो बस है। उसका कोई भी
सर, सर 2 मिनट से स्टार्ट करेंगे, अब यार 2 मिनट। और देखिए सर, आई विल गिव दीज हेडफोन्स, ये हेडफोन्स मैं आपको दूंगा, तो एज में नीचे से पकड़ना है सर, ऊपर से टच करेंगे तो पॉज हो जाएगा।
अरे ठीक है,
हाँ, नहीं तो आप बैठ जाइए, मैं कनेक्ट करूंगा। एक भी लग गया आपको तो ओके,
हाँ चलता ना।
या फिर एक 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 अभी ही लगा लीजिए।
आवाज में जा रही है?
हाँ
इसमें जा रही है,
हाँ
ठीक है। हाँ, ये ऊपर टच नहीं करनी।
हाँ,
कर दिया ना?
चलिए बैकग्राउंड तुम्हारा है ना। हाँ, मेरे इधर पीछे कोई भी आओगा था, ठीक है ना सर।
वो बैग
थोड़ा सा ऐसा पीछे हट जाता, जिसमें कि
निकलने बैठने के लिए आसान हो जाता है।
क्या,
नहीं वो बैग वैग भी नीचे है, वो
हाँ
क्लियर कर दो। इसकी लाइट है। अभी ये लो ना हमको अंदर, क्या रुक के ले लो ना।
चलिए सर, एडमिट कर रहा है, एडमिट ऑल, म्यूट ऑल करते हैं।
Assalamualaikum.
Yogesh sir,
Yes,
am
sir.
I
Am I
audible to
audible
you?
to
You
you?
can
You
just
can
put
just
this
put this
hand up,
hand up.
I can
I
see you
can
on
see
my
you on my
screen.
screen.
Yes,
Yes.
okay sir,
Okay,
thank
sir.
you sir.
Thank you, sir.
Push your side. So good morning
Good morning,
everyone.
everyone.
As per the
As per
scheduled
the
time,
scheduled time,
we'll start
we'll
with our
start with
sessions.
our sessions.
I welcome you
I
all
welcome you
for
all
navigating
for navigating
complexities and
complexities
understanding the
and
management of
understanding the
hypertension and
management
its
of hypertension and its
complications. The
complications.
webinar
The webinar
by Elite Academy
by Elite
in
Academy
association with
in
IIMSR.
association with IIMSR.
I now call upon
I now call upon
Dr. Shafi sir for
Dr.
his
Shafi sir
welcome note.
for his welcome note.
Good morning, one and all, and welcome to our fourth CME and first CME online, that is CME on hypertension or webinar on hypertension. First of all, I thank Almighty that He has given power and strength to us to organize such academic activity. I am also thankful to our founder chairman of our college, that is JIIIU's Indian Institute of Medical Science and Research, Badlapur, Jalna, Maulana Ghulam Mohammad Bastami Sahab, his son, our current chairman, Maulana Huzaifa Bastami Sahab, our CEO, Dr. Ilyas Muhammad Sir, and our dynamic and young dean, Dr. Azhar Ahmed Siddiqui, and my team of Elite Academy, Dr. Zubair, Dr. Jawad Hashmi, that they are always a constant support, and in a coordinated way, we organize CMEs. Elite CME Academy was founded in March 2023 with the aim of organizing accredited CME so that our practitioners who go for renewal of Maharashtra Medical Council for renewal of their registration, they need credit points. So our aim was to start CMEs. First three CME we started we have done offline in Aurangabad itself, and we have got a very good response for that. And we were getting messages from whole Maharashtra that why you don't go for online. So this time we have decided to go for first webinar from Elite CME Academy. Inshallah, in the future, we are planning for conferences, seminars, and such accredited webinars and CMEs. So thank you very much, all of you, for registering with us, and I welcome you all to this CME on hypertension. I hope that you all will enjoy this academic piece and you will be with us for whole day. I am very thankful to our speakers that just by one WhatsApp message they agreed to present and take part in this CME. So I am very thankful for them. Two of my batchmates, Dr. Praveen Pant and Dr. Moini Apte from my UG days, they also joined for this speaker panel. I am also thankful to our community medicine people, Dr. Abhay Mane, Dr. Priya Deshpande Madam, Dr. Manasi Madam, then our well-known neurologist, Dr. Abdul Majid Sahab from Aurangabad for accepting as a chief guest, and he is also presenting on topic on stroke. Then Dr. Yogesh Lakkar sir, very young and dynamic ICU head of our college, always ready to present. Dr. Ehsan Sheikh, senior diabetologist, Dr. Rizwan Deshmukh, cardiologist, Dr. Praveen Pant. So all these speakers they have agreed and they have cooperated with me. So today we'll listen to them and we'll make this CME or webinar successful. Thank you very much. Once again, I request all of you, please share the flyer and Google form with your friends. If they want to register, they can also get benefited from this CME. So thank you very much. Now I request our young and dynamic anchor of our Elite CME Academy, Dr. Zubair Khazi, to continue the program. Thank you once again.
Thank you very much, sir. So just to recheck, am I audible to all of you? Yes. Thank you. Thank you very much. So I will be sharing the screen and will introduce our speaker, madam. So our next speaker is Professor and Head from Department of Pathology, JUS IMSR, Dr. Tuba Fatima. Madam has done her MBBS from NKP Salve Institute of Medical Science, Nagpur in 1999. Her MD Pathology from Indira Gandhi Medical College, Nagpur in 2003. Madam has worked as Assistant and Associate Professor in CAIMS Karimnagar College. Professor and Head in JUS Indian Institute of Medical Science and Research since 2013. Madam is an accredited speaker, brilliant pathologist, and have various publications in her name. I call upon Madam to kindly continue with our session.
Good morning,
Hello,
everybody.
everybody.
Hopefully, I'm
Hopefully, I'm
finding
finding
everybody in
everybody
good
in
health
good health
and
and
uh,
uh,
in good
in
mood
good mood
today.
today.
This
This
presentation of
presentation of
mine
mine
on
on
the
the
pathophysiology of
pathophysiology of
hypertension will
hypertension
be
will
a
be a
base
base
for you all
for
to
you all to
understand the
understand the
subsequent
subsequent more
difficult
difficult
topics on
topics on
hypertension.
hypertension.
So,
So,
everybody
everybody
knows that
knows that
clinically
clinically
we
we
define
define
hypertension
hypertension
or
or
classify
classify
hypertension as
hypertension as
benign
benign
and
and
malignant
malignant
hypertension.
hypertension.
Benign
Benign
hypertension being the
hypertension being the
most
most
common
common
in 90
in
to
90 to
95% of the
95% of the
patients.
patients,
We find
we
benign
find benign
hypertension.
hypertension.
And we all
And we
know
all
what
know
is
what is
the levels
levels
of
of
diastolic pressure
diastolic
as well
pressure
as
as well as
systolic blood
systolic blood
pressure
pressure
in benign
in benign
hypertension.
hypertension. Nowadays,
Nowadays,
it
it has
has
been
been
revised
revised
also,
also, these
these
particular
pressure
pressure
values.
values.
Uh,
Uh,
in case of
in case of
accelerated or
accelerated or
malignant
malignant
hypertension, which is
hypertension, which is
very
very
less
less
common,
common,
we know
we
that
know
the
that the
diastolic pressure
diastolic
should be
pressure
more
should be
than
more than
120 millimeters
120
of Hg
millimeters of
and
Hg
systolic
and
pressure or
or
systolic pressure
systolic
more
pressure
than
more than
200
200
millimeters of
millimeters
Hg,
of Hg,
along with
along with
renal
renal
failure or
failure or
tunnel
tunnel
hemorrhages.
hemorrhages.
And
And
if
if
this
this
particular
particular
malignant
malignant
hypertension
hypertension
remains
remains
untreated, then
untreated,
the
then the
patient
patient
may
probably
dies in
dies
1 to
in
2
1 to
years.
2 years.
As far
As far
as
as
the
the
etiological
etiological
classification of
classification of
hypertension is
hypertension is
concerned, we
concerned, we
divide
divide
hypertension into
hypertension
two
into two
types. The
types.
first
The first,
most
most
common,
common,
which is seen
which
in
is seen
about
in about
85 to
85 to
90% of the
90% of the
cases, is
cases, is
essential
essential
hypertension,
hypertension,
also called
also
as
called as
idiopathic or
idiopathic or
primary
primary
hypertension,
hypertension,
in which
in
the
which the
causes are
causes are
there are
there are
multiple
multiple
factors which are
factors which are
leading to this
leading to this
particular
particular
hypertension.
hypertension.
And
And
secondary
second
hypertension, which is
hypertension, which
less
is less
common.
common,
Secondary
secondary
hypertension, which
hypertension,
is
which is
uh,
uh,
less
less
common,
common,
in which
in which
the
the
causes are
causes are
definitely
definitely
known,
known,
which
which
accounts for
accounts for
about
about
10% of the
10% of the
cases.
cases.
Should I admit
Should I
all?
admit all? Yeah.
So,
So
we
we
know
know
the
the
normal
normal
physiology of
physiology
blood
of blood
pressure
pressure
as
as
cardiac
cardiac
output,
output,
and
and
the
the
product of
product
cardiac
of cardiac
output and
output and
peripheral
peripheral
resistance
resistance
is
is
what
what
is blood
is blood
pressure.
pressure.
And cardiac
And cardiac
output
output
is
is
influenced by
influenced
the
by
blood
blood
volume
volume
as well as
as
the
well as the
cardiac
cardiac
factors like
factors like
heart rate and
heart rate and
contractility,
contractility,
which
which
are
are
also
also
influenced
influenced
by
by
neural
neural
factors, especially
factors, especially
sympathetic
sympathetic
nervous
nervous
system,
system,
which
which
also
also
influences the
influences the
peripheral
peripheral
resistance
resistance
in the
in the
blood
blood
vessels.
vessels.
Peripheral
Peripheral
resistance is also
resistance is also
influenced by
influenced by
various
various
vasoconstrictors and
vasoconstrictors and
vasodilators,
vasodilators,
and there are
and
a lot
there are
of
a lot of
other
other
local
local
factors which
factors which
influence the
influence the
peripheral
peripheral
resistance.
resistance.
And
Whenever
the
the
kidney,
kidney,
wherever
wherever there
there is
is
low
low
volume or
volume
low
or low
pressure
pressure
of
of
blood in
blood
the
in the
renal
renal
vasculature,
vasculature,
the
the
kidney
kidney
secretes
secretes
renin
renin
and
and
sets into
sets into
motion
motion
renin-angiotensin
renin-angiotensin
aldosterone
aldosterone
mechanism,
mechanism,
which
which
causes
causes
increased
increased
absorption or
absorption or
retention of
retention of
sodium,
sodium,
leading to
leading to
increased blood
increased blood
volume.
volume.
And
And
this
this
causes
causes
volume
volume
overload
overload
and
and
further
further
vasodilation. So this is
vasodilation.
the
So this is the
normal
normal
mechanism
mechanism
how
how
the blood
the blood
pressure is
pressure is
controlled.
controlled.
So,
So,
what
what
in the
in the
background of
background of
this?
this?
What is
What
the
is the
etiology of
etiology of
essential
essential
hypertension,
hypertension,
which is also
which is
called as
also called as
idiopathic or
idiopathic or
primary
primary
hypertension? Is
hypertension? Is
idiopathic
idiopathic
because
because
no
no
definite
definite
cause is
cause is
known, but
known,
there are
but there are
various
various
factors
factors
which
which
can
can
lead to
lead to
essential
essential
hypertension, which
hypertension,
have
which
been
have been
proposed.
proposed.
So,
So,
we all
we
know
all know
that
that
increased
increased
cardiac
cardiac
output may
output
be
may be
caused
caused
by
by
increased
increased
sodium
sodium
excretion
excretion
or
or
increased
increased
sodium
sodium
retention in the
retention in the
kidneys,
kidneys,
leading to
leading to
increased
increased
fluid or
fluid
blood
or blood
volume.
volume.
as well as the peripheral resistance may be increased whenever there is functional vasoconstriction of the blood vessels or any structural change in small vessels, arteries and arterioles, which is also called as vascular remodeling. So apart from that, there is a mosaic theory which is proposed, which includes a lot of factors, including factors like oxidative stress, even immune mechanism has been considered, genetics, sodium intake has been, and storage has been given a lot of importance, sympathetic activation, even microbiota in the GI tract has been given a lot of importance apart from renal mechanism. And when we study all these particular factors, we find that they are all interrelated. Each and every factor influences the other factors. So these are the various factors which we have just talked of. And in this, we find that salt intake and immune system has been now given a lot of importance in etiopathogenesis of hypertension. So let us see each of these factors individually and let us see how they are interrelated. So kidneys, as we all know, can secrete and synthesize and secrete renin, leading to renin-angiotensin aldosterone mechanism activation. Kidneys are also known to reset or alter the pressure diuresis or natriuresis. Whenever there is acute hypertension, then there is pressure diuresis, so the volume comes back to normal. But in case of chronic hypertension, there is a reset or alteration of this particular pressure diuresis, so hypertension is maintained. At the same time, afferent renal nerves are now known to modulate the systemic sympathetic tone by activating the critical centers in the brainstem. Even increased salt intake are now known to activate these afferent renal nerves. Even efferent renal nerves are known to be influencing the angiotensin II dependent hypertension. Kidney is also now known to be a site of immune activation, which can also influence hypertension. So we'll see that subsequently. As far as vascular changes in hypertension are concerned, we find that there is always, whenever there is hypertension, there is increased milieu of vasoconstrictors, as also there is altered function of the blood vessel, so that the blood vessel lumen, the caliber of the blood vessel is reduced, the blood vessel tone is also reduced. At the same time, the endothelium dependent vasodilation is reduced. So we find the lumen of these blood vessels is reduced. At the same time, many of the arterioles they suffer from smooth muscle hypertrophy and hence thickening of the walls and narrowing of the lumen. And this is basically because of the growth promoting actions of angiotensin II, catecholamines, etc., and so many other compounds. At the same time, it is found that the proximal aorta suffers from stiffness. Now, this may be a cause or effect of hypertension, also seen in so many other conditions. But this stiffness of the proximal aorta causes hypertension or increased pressure of blood in the peripheral vasculature, leading to narrow trauma in the target arteries. Also, because of high pressure of blood in the blood vessels, there is functional alteration of the endothelium. Endothelium starts expressing a lot of prothrombotic factors. So there is a high chance of thrombosis, and hence various complications like stroke, atherosclerosis with superimposed thrombosis, CVD, end organ damage can be explained. Also, in the blood vessels, there is immune activation. Central nervous system, basically the critical centers in the brainstem are activated by so many factors which we have just seen, like even renal afferent nerves can activate these particular factors. Increased sodium intake can activate these particular factors. Several prostaglandins, E3, reactive oxygen species, immune activation, and also afferent activation from adipose tissue triggered by high fat intake, and hypervolemia in the heart can also activate these critical centers in the brainstem, leading to enhanced sympathetic outflow, leading to vasoconstriction, increased sodium retention, and ultimately leading to hypertension. Now, Reactive oxygen species have also been implicated till now. We have seen so many times I have talked of reactive oxygen species. So it is said that in case of hypertension, there is oxidative stress in the tissues, and this is produced because of increased production of reactive oxygen species, as there is mitochondrial activation and so many other mechanisms for development of reactive oxygen species are activated. And these reactive oxygen species are have been implicated in increased vasoconstriction, in vascular stiffening, remodeling of the microarterioles, in increased renal sodium resorption, neuronal, and also increased sympathetic outflow. And as I said, inflammation and immune mechanisms are also playing a very important role. So these reactive oxygen species which are being produced or sympathetic outflow or endothelial cell activation is causing a lot of inflammation in important tissues like blood vessels as well as in kidneys. And all the immune cells of both the innate as well as adaptive immunity have been implicated in contributing to hypertension. These cells migrate to the interstitium of the kidneys and the blood vessels and start releasing a lot of cytokines, reactive oxygen species, and other factors which modulate both renal as well as vascular function and structure. Especially a cytokine interleukin 17A is known to be a very important factor in causation of hypertension. So as we see that the essential hypertension is a multifactorial disorder, and there are, apart from the factors which we have already discussed, there are multiple risk factors for the development of this essential hypertension, which are associated with increased sodium absorption, sodium retention, and increased peripheral resistance, as well as environmental factors, especially certain habits and conditions which have an interplay in development of essential hypertension. So we all know that
case of essential
case of
hypertension.
essential hypertension,
And
and
this
this
is a
is a
polygenic
polygenic
disorder. Not a
disorder. Not a
single gene
single
is
gene is
involved, but
involved, but
multiple
multiple
genes,
genes,
and
and
about more
about
than
more than
1,000
1,000
single
single
nucleotide
nucleotide
polymorphisms have been
polymorphisms have been
identified,
identified,
which
which
individually do
individually
not
do
cause
not cause
hypertension, but
hypertension, but
they
they
many of them
many of them
combined
combined
together
together
produce
produce
hypertension.
hypertension.
The
The
susceptibility
susceptibility
genes
genes
are
are
unknown, but
unknown, but
probably
probably
these are the
these are the
genes
genes
which
which
handle
handle
the
the renal
renal
sodium
sodium absorption
absorption
or
or
retention,
retention,
as well
as
as
well as
smooth
smooth
muscle
muscle
growth,
growth,
so on and
so
so
on and
forth.
so
So
forth.
they
So
are
they
basically
are basically
associated with
associated with
sodium
sodium
retention,
retention,
excretion, as
excretion,
well
as
as
well as
the
the
vascular
vascular
muscle
muscle
growth, as well
growth,
as
as well as
vasoconstriction.
vasoconstriction.
So
So
there's one more
there's
type
one
of
more type of
hypertension which is
hypertension
called
which is
as
called as
monogenic, in which a
monogenic, in which a
single gene
single
is
gene
involved,
is
which is of
involved,
a
which is of
rare
a
type of
rare type of
hypertension.
hypertension.
It
It
doesn't fall
doesn't
under
fall under
essential
essential
hypertension. It is a
hypertension. This is a
secondary
secondary
hypertension,
hypertension,
basically.
basically.
And
And
it is
it
very
is very
rare
rare
single gene
single gene
disorder,
disorder,
basically
basically
genes
genes
associated
associated
with
with
certain
certain
enzymes
enzymes
causing
causing
excess
excess
aldosterone
aldosterone
secretion,
secretion,
and
as
also
also
a
a
genetic
genetic
mutation
mutation
in
in
Liddle
Liddle
syndrome,
syndrome,
which
which
cause
cause
increased sodium
increased sodium
resorption from
resorption
the
from the
kidney,
kidney,
is
is
seen in this
seen in
particular
this particular
monogenetic
monogenetic
hypertension.
hypertension.
Again, it is
Again,
not
it is not
essential
essential
hypertension, it is
hypertension, it is
secondary
secondary
hypertension.
hypertension.
So,
So,
what are the
what are the
various
various
environmental
environmental
factors?
factors?
Various
Various
environmental factors.
environmental
The
factors.
most
The most
important
important
is
is
salt
salt
intake.
intake.
And this has
And
been
this has
given a
been
lot
given a
of
lot of
importance
importance
now, as
now, as
everybody knows
everybody
that
knows that
excess of
excess
salt
of salt
intake,
intake,
exceeding
exceeding
renal
renal
sodium
sodium
excretory
excretory
capacity
capacity
can
can
increase blood
increase blood
volume and
volume
cardiac
and cardiac
output, and
output, and
hence
hence
can
can
cause
cause
also
also
vasoconstriction.
vasoconstriction.
So,
So,
sodium,
sodium,
if
if
taken
taken
excessively,
excessively,
can
can
also
also
accumulate
accumulate
in the
in the
subcutaneous
subcutaneous
tissue
tissue
and other
and other
tissues,
tissues,
and
and
can
can
alter the
alter the
volume
volume
hemostasis,
hemostasis,
and
and
produces
produces
hypertension, and
hypertension, and
also
also
poses for
poses for
cardiovascular risk.
cardiovascular risk.
And this
And this
sodium can
sodium can
also
also
activate the immune
activate the
cells in
immune
these
cells
particular
in these
tissues.
particular
As we
tissues.
know
As
how
we know
immune
how
cells
immune
play
cells play
important role in
important role in
development of
development of
hypertension. We
hypertension.
have
We
already
have
seen it.
already seen it.
Also, a
Also, a
new
new
uh, uh,
uh,
theory which has
theory
been
which has been
proposed
proposed
is
is
microbiota, that how
microbiota, that how
microbiota plays an
microbiota plays an
important role in
important role in
modulating
modulating
BP.
BP.
So,
So,
dietary sodium,
dietary sodium,
when
taken
taken excessively,
excessively,
is
is
known
known
to
to
modify
modify
the
the
gut
gut
microbiota.
microbiota.
And
And
when the
when the
microbiota is
microbiota is
altered,
altered,
there is
there is
inflammation in
inflammation
the
in the
gastrointestinal
gastrointestinal
tract,
tract,
and
and there are
structural changes
structural
in the
changes in
intestinal
the
wall, leading
intestinal
to
wall,
increased
leading to
permeability
increased permeability
of
these microbial products, hormones, immune cells, etc., from the blood lumen into the circulation, which impact the peripheral and central blood pressure control and hence cause hypertension. As contrast to this, we see that diets rich in fruits, vegetables, fibers can decrease blood pressure and reduce the risk of hypertension. Also, obesity, everybody knows, is a very important risk factor for hypertension, especially centrally located fat acts as a source for insulin resistance. There is excess insulin in the body, which actually causes increased sodium retention and activates the sympathetic nervous system, causing smooth muscle cell proliferation, muscle contraction, etc. And this is also related with development of metabolic syndrome, in which hypertension is also one of the important constants. Apart from that, physical inactivity, tobacco smoking, chronic alcoholism, and increasing age are also risk factors for development of hypertension. And also stress, mental stress, as it also activates the sympathetic nervous system, is associated with development of hypertension. What about secondary hypertension? Till now, we have talked about essential hypertension. Now, what about secondary hypertension? We all know there are certain specific causes for secondary hypertension. The most common is the renal disorders. So we know that renal disorders may be parenchymal diseases like chronic renal failure, and the severity of hypertension is more in glomerular diseases than in interstitial renal diseases. Also, specific renal disorder like renovascular hypertension is one of the most important cause of secondary hypertension. And here the renal artery occlusion may be because of atherosclerosis or maybe because of myomuscular dysplasia. Apart from that, other endocrinal disorders like primary aldosteronism, which is autonomous aldosterone production. Very commonly, the cause is adenocortical adenoma, which produces excess of aldosterone and hence leads to hypertension. Also, pheochromocytoma is also Cushing syndrome. Cushing syndrome, with increased ACTH production, which may be primary, secondary, or tertiary Cushing syndrome, can stimulate mineralocorticoid receptors and hence lead to hypertension. Then pheochromocytoma, it is a tumor which is present in adrenal medulla. We call it as pheochromocytoma. If it is present anywhere else, it is called as extra-adrenal paraganglioma, and it produces a lot of catecholamines, and hence leads to sympathetic activation and hypertension. And it is a surgically treatable cause of hypertension. Apart from that, there are so many other conditions which are associated with hypertension, including pregnancy. Specific cardiovascular disorders, especially related with aorta, like blockage of aorta, rigidity of aorta, may also lead to isolated hypertension. Specific neurogenic disorders, psychogenic or increased intracranial tension, sleep apnea, etc., also lead to isolated hypertension. So these are all the various etiological mechanisms for the development of hypertension. We are going to go through all the complications in the subsequent talks, just going through the morphology, especially the cross and microscopy of this particular complication. In short, so various complications related with hypertension like peripheral arterial disease, renal diseases, heart failure, stroke, hypertensive retinopathy, and we find that there is for the development of complications of hypertension also there is genetic susceptibility. There are genetic determinants as well as there are individual variations for development of complications of hypertension. So very shortly, the blood vessels, especially in benign hypertension, the small arterioles, arteries and arterioles from hyaline arteriosclerosis, benign hypertension. And if it is present in kidneys, it is also called as benign nephrosclerosis. As against this, in malignant hypertension, the arteries and the small arteries and the arterioles suffer from fibrinoid necrosis or hyperplastic arteriosclerosis. And if it is present in kidney, it is called as malignant nephrosclerosis. Also, heart suffers from cardiac hypertrophy, and the patient may suffer from hypertensive heart disease with heart failure. Even there may be atrial fibrillation. The cardiac hypertrophy is mostly concentric hypertension as it is pressure hypertrophy. At the same time, if the patient, if there is atherosclerosis already present in this particular patient, the atherosclerosis may suffer from complication like superimposed thrombosis, as a result of which there may be acute events like myocardial infarction or cerebral vasculosis. Also, aortic dissection is common in patients of hypertension. In case of CNS, stroke is very common because of prothrombotic mechanisms. So that is very common cause for stroke and cerebral infarcts. Not only thrombosis but also cerebral hemorrhages. And also retinal arterial remodeling is very common in microvasculature of retina, leading to thickening of the walls, reduction in bilirubin. There may be even ruptures leading to hemorrhages and exudate at bleeding. So this is all with my presentation with pathogenesis of hypertension. Thank you, everybody.
Thank you very
Thank
much,
you very
madam.
much, madam.
As the
As
madam
the
is
madam is
in-house
in-house
speaker,
speaker,
we will
we
like
will like
to
to
felicitate
felicitate
madam
madam
here.
here.
Rest of the
Rest of the
speakers,
speakers,
those who are
those who are
presenting
presenting
from
from
outside
outside
the
the
venue,
venue,
we will
we
share
will
the
share the
mementos with
mementos
you
with you
in
in
short period
short
of
period
time.
of time.
Okay. I now
I
call
now call
upon
upon
Dr. Shafi
Dr.
sir
Shafi
to
sir to
kindly
kindly
felicitate
felicitate
madam
madam
by
by
presenting a
presenting a
memento to
memento
her.
to her.
Thank you. So our
Our
next
next
speaker
speaker
is
is
Dr.
Dr.
Abhimani sir.
Abhimani sir.
Dr.
Dr.
Abhimani
Abhimani
is
is
MD
MD
in
in
ESN.
ESN.
He has
He
done
has
his
done
MD
his MD
from
from
EN Medical
EN
College,
Medical College,
Mumbai,
Mumbai,
and has
and
done his
has done his
fellowship in
fellowship in
diabetes
diabetes
from
from
CMC
CMC
Vellore.
Vellore.
Also a
Also a
certified
certified
evidence-based
evidence-based
management of
management of
diabetes from
diabetes from
PFI.
PFI.
Sir is
Sir is
professor
professor
of
of
community
community
medicine
medicine
from
from
SMT
SMT
Krishna Medical
Krishna Medical
College.
College.
He is
Is
consultant
consultant
diabetologist
diabetologist
of
of
Diaby
Life
Diabetes
Diabetes
Specialty
Specialty
Center.
Center.
He has
He has
previously worked
previously worked
as
as
he has previously worked
previously worked
as
as a
professor and
professor
head
and head
and medical
and medical
superintendent, vice
superintendent, vice
principal,
principal,
and
and
also as
also as
MEU
MEU
coordinator.
coordinator.
He is member of
Member
Board of
of Board of
Studies,
Studies,
SAO
SAO
University,
University,
Bhubaneswar, Orissa. Sir is a
Sir is a
lifetime member
lifetime
of
member of
IAPSM,
IAPSM,
IPAH, and
IPAH, and
RSSDI.
RSSDI.
Sir has
Sir
got
has got
total
total
54
54
publications in
publications
his
in
name
his
in
name in
national and
national and
international journal.
international journal.
There is
There is
Associate
Associate
Editor of
Editor of
International
International
Journal of
Journal of
Public Health
Public Health
Sciences,
Sciences,
that is
that is
Scopus
Scopus
Journal.
Journal.
Sir is
Sir
on
is on
editorial
editorial
board
board
for
for
5
five
index journal,
index journal,
and he is
and he is
recipient of
recipient of
Best
Best
Project
Project
Award
Award
at
at
CMC
CMC
Vellore,
Vellore,
and
and
various
various
other
other
awards
awards
were
were
given to sir.
given to sir.
Now I
Now I
request you, sir,
request you,
to
sir, to
kindly share
kindly
your
share your
screen and
screen
PPT
and
and
PPT
go ahead
and
with
go
your
ahead with your
presentation.
presentation.
Am I audible?
Yes, sir.
Yes, sir.
Okay. Thank you. Thank you for the nice introduction.
Yes, sir.
Yes, sir.
Thank you. So, a very good morning to one and all. So, before I start my presentation, it was nice to see all my previous colleagues, Dr. Shafi, Leena ma'am, Siraj. We all
बोलिए ना सर.
had worked at Karimnagar together. And definitely, this group was more passionate towards teaching and academics. And same passion, Dr. Shafi, Dr. Tuba madam, Fatima madam, they are still carrying on. It's nice. And it's nice for me to be invited on this platform. A very thank you to the organizers. So let us move towards the next session, that is epidemiology of hypertension. Okay, so I'll be going through what is the current status and how hypertension has become a public health problem. So the learning objectives of my sessions will be that each participant should be able to understand why hypertension is a public health problem and how it has grown over a period of decades, and understand the epidemiology of hypertension. So, what is the burden of hypertension? Okay, an estimated 1.2 billion adults aged 30 to 79 years worldwide have hypertension, and two-thirds, this is very important, two-thirds of them will be living in low and middle income countries. Another fact, 46% of adults with hypertension are unaware. So this is the hidden iceberg of disease, that they have the condition. And less than half of adults with hypertension are diagnosed. So opportunistic screening plays a big role in identifying these adults and treated. Approximately 1 in 5 adults with hypertension have it under control. So only 1 out of 5 hypertensives are correctly controlled. And definitely hypertension is.
Now you can
Now you
share,
can
sir.
share, sir.
Just a minute.
Yes, sir, your screen is
Screen is
visible.
visible.
It's visible. Okay.
Yes, sir.
Yeah. I'll start.
Yeah, you
Yeah,
can
you
put
can
it on
put
the
it on the
slide
slide
share,
share,
slide
Sure.
presentation, and you can
Yeah.
start.
Yeah. I'll operate. Yeah. Good morning, all. First of all, thank you, our IIM SR chairman, CEO, and then our respected Dean sir, and my dear friend Dr. Shafi, for this fabulous webinar that has been arranged, and very important topic. We're having multiple mechanism and very complex therapeutic aspects. That role has been given to me to discuss with the therapeutic management or recent advances that I'll be discussing on. Uh, the screen is there, no?
Yes,
Yes,
sir.
yes, sir.
But you
But
have
you
not
have
put
not
it on
put it
your
on your
slide share
slide
mode,
share
sir.
mode, sir.
Slideshow mode
Slideshow mode.
in your
In your
PPT.
PPT,
Okay.
Put it on slideshow.
slideshow.
Yes, from
Yes,
the
from the
beginning.
beginning.
Okay.
Yes,
It's fine now.
yes,
Yes,
very
yes,
much
very
fine.
much fine.
You can
You can
continue.
continue.
Yeah. Now the objectives that will be here for this talk: identify mechanism of action of newer antihypertensive molecules. We have many old molecules that we have been using since last over 10 to 20 years, but there is always a need for newer molecules because there is a concept of resistant hypertension or refractory hypertension. Then second objective will be to summarize the indications for initiating newer antihypertensive therapy and to review the adverse event profile of newer drugs. As previous speakers have discussed, hypertension is the most common modifiable risk factor for the cardiovascular events. Almost it is having the 50% uh, burden on the global population, and very important to curtail this at early stage, and that has been a mechanism as well as the epidemiology has been discussed in detail by the previous speakers. I will not go in detail of that. JNC criteria, as you all know, the blood pressure readings when we diagnose the hypertension, that is also discussed as a part of epidemiology by previous speakers. Then the important aspect, essential and secondary hypertension. Secondary hypertension, particularly as a uh, clinical era, we see in the young, and when we as a clinician, when I suspect or we suspect
secondary hypertension, that is important part is less than 30 years of age, and main aspect is renal diseases in this case. That also will not go in detail. This is important slide that is important from a clinician's or physician's point of view. Resistant hypertension, when do we call resistant hypertension? Almost when we need the fourth drug to add to a patient. And in the refractory hypertension, even the 4 drugs that is not helping out, and you may need the 5th drug or any other measures. And even with all these measures, that may not be controlled, and then we need the newer molecules that might help, or the newer modalities of treatment in that case. So these newer therapeutics that has come over like last 10 years, or that will be developed during the next 10 years, that we'll be discussing mainly on treatment. First and foremost part is definitely the lifestyle modification that has been discussed, the diet that has been discussed extensively by Dr. Mane. Again, that intake of sodium that has been linked as a modifiable risk factors that everyone has to follow in their lifestyle. Then eating vegetables, exercise is important component of that. Then control of other associated diseases like diabetes, that is also important. Now, content of this talk, that will be mainly these drugs or newer therapeutic aspects I'll be discussing on, like direct renin inhibitors that has been coming into the picture these days, or that has been researched or being researched over the last 10 years, or that is coming into the market or on the commercial levels. ACE inhibitors, that has been the age-old medicines. ARBs we have got since last 20-25 years. Then vasoactive peptides, this is another mechanism that will be acting on this, and will be using this in the pharmacological armamentarium of ours. Then vaccines are also into the research. Then CCBs, diuretics, beta blockers, these are the age-old medications, but newer molecules are coming into this armamentarium also, that we'll be discussing on. This is the most and important part of mechanism of hypertension that has been discussed by madam, and everyone has to remember, or that in the brain this part, the angiotensinogen, angiotensin 1, then angiotensin 2, and aldosterone, that acts at multiple levels, that leads to like sodium retention, water retention, increase intravascular volume, and that is mainly leads to a complex phenomenon, and that leads to the hypertension or heart failure. This hypertension and heart failure, that goes hands in hand, and that you have to analyze as a clinician. So this is the important various aspects of therapeutics that we intervene on at this pathway. That is very important. Everyone has to know this. Again, this is the simplified figure. As we all can see that there are two more for the angiotensin 2. Two types of receptors are there. The type 1 receptor that plays into the hypertension, and type 2 receptor, that is, or alternative RAS pathway, that many of us may not be aware of. That is one entity that has come into the picture over the last 10 years, and these molecules are being developed on this pathway. The alternate RAS system I'll be discussing on. Now, first, newer drugs that will go by one. The direct renin inhibitors. The first generation and second generation, those were the research molecules, but they could not come into the market because of the different reasons. But the third generation molecule that is orally available, that is aliskiren, that has been that AC inhibitor, and along with the ARBs also. Okay, various trials are there. Other molecules were there. Mainly this molecule will be seeing on the commercial level. How is the bioavailability of aliskiren? This is orally bioavailable pharmacological part. It is only 2.5. It is 2.5%, but it has a high specificity and affinity for human renin. And this aspect we are like going into, because other previous molecules like AC inhibitors or ARBs, they were acting at some other level, and we are exploring various therapeutically. And what will be the important of this? Cytochrome P450 system is not very much involved, so that easily like this, even if 2.5% bioavailability, it works very well. And once a daily administration is possible. This has been taken from the Lancet 2006, like when the research was going on. Then important aspect of this molecule will be like at most of the time aliskiren will be used with the ARB like Valsartan. That these trials have been this trial is there, that is published in the American Journal of Hypertension in 2007, and it is having the greater antihypertensive effect when it is combined with the Valsartan. And that need to be combined, or combined drugs are available or coming into the market. Aliskiren and ramipril effect. Plasma renin activity is the important aspect that is significantly suppressed with aliskiren and ramipril. Ramipril that we have been using since a long time, and again this data has been published in this very important scientific session in 2007. Use of DRIs, possible implications in the myocardial infarction. It completely blocks the RAS pathway. Okay, renin is the first hormonal thing or biochemical molecule that acts on the angiotensin and converts it into the angiotensin 1. So when renin is only acted upon, that will be at the very first level, and that will be very important, because like this plasma renin activity, a risk factor for myocardial infarction. The hypertensive patients that uh, AC inhibitors or ARBs, there will be the in excess of the renin in the body, and that will have deleterious effects on the cardiac tissue, or it itself will have deleterious effects. And when that can have the additional mortality that has been researched, and when we act at the renin level itself, this plasma renin activity will be suppressed, and this will have additional positive effect or additional benefit to the patient. Many of the studies like additional therapeutic benefit of renin inhibitors that has on the cardiovascular or target organ protection, that has been researched upon, and that's why this will have the additional effect when we suppress the renin. This is one of the important therapeutic aspect that everyone has to know, and that will be we will be using clinically in the patients. That is the important aspects. It reduces the plasma renin activity along with the ARBs on a greater extent. Now, age-old angiotensin receptor blockers we have been using as a first line of drugs also, like telmisartan or any, and we have been using successfully, and they are not having as such. They are safe and not having as such side effects. And many of the molecules are there in this class. Most commonly, right and left, we are using the telmisartan, and very safe molecule that with experience also and with evidence also, safe molecule, less adverse effects. And why these ARBs were there into the market? Because AC inhibitors, like they had a more adverse risk protocol, or they were like angioedema or cough. These were more common with the AC inhibitors, and then these molecules like 10-15 years back or 20 years back, they come into the picture, and we have been using them successfully in the treatment of hypertension, also in the heart failure, and they are helping us to prevent the cardiovascular events. Newer molecule that has come into the picture, the ARBs, that is azilsartan, developed by the Takeda, that is a well-known pharmaceutical giant. As a product, it acts various doses. They are there. Again, it has having a very good safety profile. It decreases the BP and very much good safety profile as compared to other ARBs and that. But telmisartan is a well-tested drug that we can carry on with the telmisartan itself. This is one of the important aspect. Vasoactive peptides, like many of the vasoactive peptides, like many molecules are there. I'll be one more figure is there later on in this presentation that I'll be discussing mainly on various atrial natriuretic peptide BNP. This play a very important role when in the hypertension mechanism and also in the heart failure mechanism, and that is degraded by the naproxen or vasoactive peptides. And if we target this level, so this ANP level and BNP level will be maintained. Sodium and sodium excretion would be there, and diuresis would be there, and that will be helping us out in treating the hypertension. And this is one of the newer molecule or newer level where we'll be acting upon. Various molecules in this range, naproxen inhibitors that has been they are being tested in the clinical trials. The important molecule been tested like sacubitril and valsartan. This is combinedly used in the various trials. That is a naproxen inhibitor that we are discussing. Greater reduction in the systolic blood pressure than valsartan alone. Greater reduction in the symptoms, physical limitations, and cardiac death due to heart failure. Because for heart failure, or even there is a concept of heart failure with preserved ejection fraction that may be subclinical in the clinical practice. Even that is going to help in these patients, and these physical limitations is like more improvement in these physical limitations, greater decrease in the BP, pulse pressure, and arterial stiffness in elderly. Pathophysiology of the heart failure. This is the again RAS system
Recording stopped.
maladaptive response during which
Recording in progress.
renin pathway, that is very important aspect, and alternative renin pathway that is now also being researched upon. So these are the molecules like various aspects we can act upon, and we can have the newer molecules, more safe molecules, more important molecules that can have multiple pleiotropic effects we can get with all these molecules. That's why everyone has to know this RAS and alternate RAS pathways. That is very important aspects. RAS pathways we all know, but alternate RAS pathway, that is also equally important, very important in this scenario. Naproxen, as we are discussing with this is very important, right? In the circulation, this study was published, combined angiotensin receptor antagonism and naproxen inhibition. In the 2016 circulation, this was published, and this is the area of interest of scientists or working physicians where we can act upon. Why sacubitril and valsartan? They are in combination. They are to be used in the combination. Valsartan is an angiotensin receptor blocker. It works on blocking RAS system. However, because of the naproxen breaks down the angiotensin 2, and it breaks down the angiotensin 2. But when naproxen is inhibited, definitely it will increase the ANP and BNP level, but simultaneously it is going to accumulate angiotensin 2, and that can have the opposite effect on the mechanism. That's why valsartan combining with the sacubitril or naproxen inhibitor, that is very important aspect, and then you have to combine this molecule. Otherwise, only sacubitril will not have its desired effect. Key points to remember when you start this combined therapy or when you start sacubitril: allow at least 36 hours washout. Washout of when you are switching from SE inhibitors, just allow that 36 hours of washout period. Patient must be able to tolerate SE inhibitors or ARBs. There was no hypersensitivity reaction previously that you have to take into consideration. Precautions, again, renal impairment, as we are aware that ARBs or SE inhibitors, eGFR is less than 30, then avoid these drugs. Hepatic impairment, particularly child per class C. or they are the only contraindications, or you have to take precautions. Child Pux class B, then you can use this. Pregnancies, better avoid these drugs. Breastfeeding women, avoid this drug. This has been detected in the milk in the experimental studies. Contraindication, as we know, hypersensitivity to this molecule, angioedema, as with SCE inhibitor and ARBs. When renin inhibitors, aliskiren is that has to be avoided as a combined therapy, because that can have severe hypertension. Patient may land up into severe hypertension, hyperkalemia, or renal impairment. Now, the one more mechanism that is being evaluated is the endothelin receptor antagonist. Like in the primary pulmonary hypertension or pulmonary hypertension, we see that endothelin is the most potent vasoconstrictor that we have seen, and if we block that, then that can be the mechanism that might be used for the hypertension also, because many proliferative mechanisms that those play into the picture. There are two pathways here. We can directly block endothelin receptors, or we can block the conversion of big endothelin, that is the substrate, and that produces the endothelin, that is endothelin converting enzyme. We can block we have the molecules acting at on both these pathways, which we sparsentan, like I discussed, these are in the phase 2 trials still. They are the molecules, those are being used in the pulmonary hypertension also. They can be combined with the ARBs. And then important aspects, this randomized controlled trial, the Lancet, it's still ongoing. Sparsentan and irbesartan. Sparsentan in patients with IgA nephropathy, that has been tested. A pre-specified interim analysis has shown that it is effective in reducing the proteinuria in IgA nephropathy, and this trial is ongoing. Now, dagleutril, this is the molecule that it is the endothelin converting enzyme inhibitor. This is being tested, and that has been found to be effective. It decreases the pulmonary and right atrial pressure without affecting the systemic arterial pressure, cardiac output, and heart rate. So this is another molecule that is very important, that will be coming that will be coming into the practice, say next 5 to 10 years definitely. And potential data is also available. This trial, randomized trial is that is done, and into the picture, these endothelin receptor inhibitors, that is having the neural endopeptidase inhibitor activity also, that acts at the two levels, and that can be helpful in the hypertension control. Now, these two newer mechanisms we discussed, again we'll go back to some of the age-old molecules that we are having. Aldosterone, the most important aspect in the RAS pathway that we know, that plays itself, and also it acts at the pituitary levels in secreting the ADH, and that can have the increased sodium retention, then sodium retention and water retention, and that can lead to the hypertensive effect. This is the diagram that we have been seeing. It is secreted from the zona glomerulosa. And one important mechanism that we can see, that endothelial dysfunction and in the vascular disease, that is also affected by the aldosterone. That's why this is important mechanism that we are acting upon, and many newer molecules will be there. What we have with the aldosterone receptor antagonist, spironolactone, but lack of specificity. It also binds progesterone and androgens. That's why it has the side effects. And but relatively, as an experience with this molecule, it is definitely relatively safe. It's not. We do not get routine side effects. You can use it, and that we are combining with the loop diuretics like lacilactone we have available. Then eplerenone, and canrenone. Eplerenone is available in the market. even personally, I have been using this molecule in the resistant hypertension as an add-on drugs. It has given very effective treatment in my patients also, which I follow, like resistant or refractory hypertension. Few of the patients that I do get in my practice, eplerenone is a very good molecule in this resistant hypertension, and you may use this in the practice. Then some newer molecules into the picture also, finerenone. Then aldosterone synthase inhibitors. One more aspect that has been targeted is the aldosterone synthase inhibitor. This is like CYP, it blocks that aldosterone synthesis itself. This molecule, fetrozole, this is being tested. But what is the problem with this molecule? This will inhibit the like other enzyme that is important in the synthesis of cortisol also. So that is not specific for aldosterone itself. So then that was the need for the specific aldosterone synthase inhibitors. Like then these are also into the pipelines, LCI 699 and other one. If like primary molecule that is not specific for the aldosterone itself, that can lead to like decreased cortisol, and that can have the adrenal insufficiency. That can be like patient may have the clinical side effects of like weakness, excessive fatigues, that you have to always consider when you are treating these patients. Like you have to have the minimal side effects when you are treating these patients. uh, Disadvantage of aldosterone synthase inhibitors: hyperkalemia can be there, hyponatremia. Hyponatremia is very important aspect when you treat the hypertension, particularly in the elderly patients. Then you have to be a bit precautious, like when to start diuretics or when not to start diuretics in the clinical practice, because that can predispose to a very severe hyponatremia, and patient may land into emergency department with severe hyponatremia, or even it can be fatal. Then that's why this is the important aspects. And as already we discussed, that fourth or fifth line therapy in the resistant hypertension, very important aspect when we treat the resistant hypertension, or when we do come across the resistant hypertension patients. Like now, this is one of the important slide that I'll be highlighting. These are the important aspects: counter regulatory pathway or alternate RAS pathway that I was talking about in my previous slides also. This alamandine angiotensin converting enzyme 2. We all were aware of the angiotensin converting enzyme that is secreted by lungs. Like the left side of this figure, that you all see that this is the classical RAS pathway, that angiotensin is produced in the liver. Then AC angiotensin converting enzyme converts angiotensin 1 to angiotensin 2. Angiotensin then again has a angiotensin 2 has its role on various target organs, or mainly it is the vasoconstrictor, and that is the mechanism in the. But till now we were like only focused on this, but counter regulatory RAS pathway like ACE2, this is the enzyme that converts this angiotensin into the more favorable angiotensins, like angiotensin 1 to 9, angiotensin 1 to 7. And these are the angiotensin type 2 receptors that I was also previously discussing. These are the important that lead, and that can lead to this alamandine complex, then MAS receptors. All these are important in the vasodilation. These are the counter regulatory mechanisms that do exist in the body. We were not aware of these mechanisms. This is the area of interest for research nowadays. These are the various molecules are acting at these levels, and we are like various trials are going on these molecules. This is the important aspect that helps now, that those will be available for us to decrease the blood pressure, and to like prevent the target organ damages. Like already discussed, this is the important pathway. This alamandine, a newer member of angiotensin family. This is there in with this paper, current opinion of nephrology in hypertension. Drug activity, we discussed this part. 80 type 2 receptors agonist. This will be the next target. ACE2 When I say angiotensin converting enzyme, the classical pathway, we have to have the inhibitors, and here we will need the activators, because this is a favorable pathway in the body and we have to act on that. Then angiotensin 1 to 7 analogs, then activator of the mast receptor, and activate like agonist for the alanine complex, because this is the favorable pathway. At least now everyone will be by hurting this pathway, because this is something that will be coming newly, and that will be, these molecules will be available with us. 82 receptor agonist, this is a type 2 receptor which is having the uh, favorable effect or vasodilatory effect, that can be helpful in the hypertension or in the heart failure. This molecule, these compounds, C21, even as we have seen in the COVID pandemic, fibrosis was there, or proliferative effect was there. Even this was used, or in some few of the trials during the pandemic, because it is a proliferative, and it is again, these pathways mainly are helping in the apoptosis and development of the fetal tissue. That is the mainly, it will prevent the fibrosis in the end organs, and that can have its favorable effects on this pathway. Angiotensin converting enzyme to agonist, here we need the agonist. These two molecules are in the picture. The names are difficult to remember, because too many, the research is going at in a vast way, and definitely science is the important thing, where like we can alleviate the symptoms, we can alleviate the diseases because of science, and we also have to search for the newer molecules. We always need to have the data on that, safety data also. So these are the important things that we have to search for. Then these analogs, CGN 856, these will be the angiotensin 1,7 analogs at various levels in the trials. Like few of the preclinical trials are going on, phase 1, phase 2, phase 3. These molecules are at various. This is again AVE0991. You just remember, or you just remember the mechanisms at what level we all will be acting in the development of the newer therapeutics for the hypertension. This is the at the mast receptor agonist level. Alanine complex, very important last receptors or last molecule that acts in the vasodilatory mechanism in the alternate RAS pathway. Then you can see that hypertension is having very complex mechanism. It plays at renal level also, it plays at multiple organs, and definitely from the brain also there are many peptides which play important roles. As alternate RAS pathway we discuss, there are again fewer new molecules, those are coming into the picture, like angiotensin 2 converting into angiotensin 3, angiotensin 4, with the help of these aminopeptides, and that leads to the activation of the sympathetic nervous systems. Again, molecules are at the central level also. This RB150, that will be the inhibitor of these enzymes, and that can reduce the sympathetic outflow from the brain itself, and that will help us in reducing the hypertension, and this will be again into the clinical trials. This molecule crosses the blood brain barrier, that's why it is being tested at this level, at the centrally acting molecule. Vaccines are also there into the picture, like they act as a angiotensin 2 level antibodies do develop, and the effect remains sustained like up to 4 months. You can these are into the trials. Patient can be like every 4 months, a patient can take a, if their safety limits is tested, patient can take this vaccine every 4 months, and they can be free of the drugs. That might be the area of interest for these vaccines that will be acting, because nowadays many of the clinical phenomena or pathophysiology in all the diseases that is going at the, mainly immunology is concerned at various places. The mechanism is already extensively discussed by previous speakers, and that's why this will be the area of interest for the researcher and clinicians who are treating the hypertension. Then we will go back to these calcium channel blockers, the age-old molecules, newer and old. We have to channelize both the molecules, and we have to use precautiously, or we have to use justify their use in the clinical practice, and you have to have the experience with these molecules. Calcium channel blockers, good drugs that I have been using since last 10 to 15 years, more than 15 years. Safe molecules. These are the different types of calcium channels, and drugs do act on these different channels. L type most commonly, or previously used calcium channel blockers were acting on these channel. Then T type mainly concerned with the pacemaker, atrial cells, and Purkinje fibers. NPR type channels mainly in the brain, neuron, pituitary glands. These are the different types of channels, and drugs do act on these. Clevidipine is the third generation L type, the primary channel that is blocked. This is the molecule that has been available, mainly used in the cardiac surgery or in the severe hypertension, that pre-surgery or post-surgery that is developed, and it is a safe, it is easily controlled, just like it is more effective than the antigen or sodium nitroprusside that we were used to use previously. Due to hypertension, we can use this molecule. Then combined L type and T type. These are various molecules available. Ranitidine or benidipine is like available in the market. The other have been tested upon. Then combined L and N type. This cilnidipine molecule that has come into the market recently, having a good effective value. Also, the safety profile is good. Like with the calcium channel blockers or amlodipine, the most important part was the edema. Patient used to develop the edema fit. That was the side effect that has been elevated by this molecule, and now we have started using this molecule on a large scale. Like advantage, 24-hour BP control as effective as the traditional calcium channel blockers. Advantage of cilnidipine. Then cilnidipine will have greater reduction in BP and prevention of ankle edema that already we discussed. Decreased proteinuria in the diabetes patients as compared to amlodipine. First line of drug in the hypertension treatment. It can be combined with the diuretics also, and very important drug in the hypertensive management. Like ARBs and calcium channel blockers. Few of the trials studies, like in the Lancet 2004, outcomes in hypertensive patients at high cardiovascular risk factors treated with regimens. Few trials showed that amlodipine or calcium channel blockers are very important, but there is no evidence of increased MI risk with ARBs that has been demonstrated. But both are equally important molecules. Only what we discussed in the initial slides, like in the direct renin inhibitors, that can have the more favorable effects because it blocks renin itself, like otherwise which accumulates in the ARBs, and that can have deleterious effects on the end organs. That only the question or area of interest or area of research now that is available. Both these molecules are safe also and effective also. Diuretics, again, loop up Henle diagram we can see various diuretics are there, like they act on the proximal loop. Then loop diuretics like Lasix, that play into the role. Distal convoluted tubule hydrochlorothiazides, then aldosterone, or these acts at the collecting duct also. This is the famous Guyton diagram that we learned in our first MBBS itself. These are the various classes of drugs available in the diuretics. Loop diuretics, then thiazide diuretics.
I can help. No issues.
Then
What is
thiazide
your
like
problem?
diuretics, chlorothiazide. Chlorothiazide is more safe than the hydrochlorothiazide. Potassium sparing like spironolactone. This already we discussed. Eplerenone, all this aldosterone antagonist. Thiazides first choice in the RX of in the treatment of essential hypertension. But always remember that when I see in my clinical practice, if age is more than 55 or age is more than 60, I will not use the diuretic as a first choice of drug, because significantly it can even though in few patients, but it can lead to severe hyponatremia. You have to be precautious for this. Then like calcium channel blocker or ARBs or RAS pathway drugs you can use
So what we can do is
as
we
a
can
first line
just
itself also.
come
Then
and
loop
reach
diuretics,
me
the importance
tomorrow.
in the severe hypertension
Tomorrow is
associated
Monday,
with
right?
CRF and CACF. Potassium sparing, we already discussed.
In
Aldosterone is very
Department
important,
of Homeopathy.
and its inhibition is a very important in the treatment of hypertension. And beta blockers, like we have used extensively, say 15 years back or
Okay.
20 years back. Atenolol was still these are the safe, but like that will not be as a first line of drugs. Newer safer beta blockers are there, but as a first line of drug you don't use it clinically, because it can have the cardio suppression activity, and it can have deleterious effects. It also have the like in diabetic patients you have to be precautious when using the beta blockers. Newer molecules are there, like
the phone card that came
carvedilol,
to
which
you
carvedilol,
that
labetalol, which
is
blocks the
on
alpha
tomorrow.
receptors, so beta
I
receptors
cannot
also
help in
they
that
are also
because
available.
we are
Like
conducting a
labetalol,
webinar
even
today
I have been
and
using,
we are
like
hosting it.
rather than
So it is
NTG
not
nowadays
possible
for the
for us
severe
to work
hypertension.
today
I personally
on
I
the
also use
issue
in my
where you have
ICU
to
labetalol in the
tackle
acute severe
that
hypertension.
for
Then
tomorrow for sure.
carvedilol,
And
that is
tomorrow you
having the
can come
more
at
favorable
11
effect in
in
the
Department of
uh,
Pharmacology. We can have a one-to-one
in the heart
interaction.
failure
And
patients.
after
And
that, we
evidence is
will
most evidence
see
for
how
decreased
can we help you, right?
morbidity and mortality in heart failure. So this is like more it is being used than metro or something like that.
Okay,
Then
you can
nebivolol,
manage
this
it
is again the
as
recent
yeah,
molecule
yeah,
recently approved for beta 1 selective blocker. It is having the nitrous oxide enhancing effects, like more vasodilatory action it is having. These are the this is regarding the beta blockers that is into the practice, and when to use and when
okay.
not to use, and newer molecules, more safe molecules we need. Beta blockers versus ACE inhibitors. Uh, Trials similar, both similarly decrease in the morbidity and mortality. Famous UKPDS study has shown in the BMJ, which was published very like way back in 1998. Both are effective, but again, as a first line of drugs, more safer drugs are now available that we can use into. Now, like we are like moving that, we have to see the safety profile, because which we have tested in the post clinical surveillance, or we have tested molecules clinically on a large population, plus need of newer molecules. Again, the pathway, like we discussed that naproxen inhibition we discussed. Now we can have the molecules that itself acts as a ANP or BNP, that will have like excretion, that will increase the excretion of sodium and water. These natriuretic peptide receptor agonists, these are being researched into. These are the molecules, they have been given names. They are not into the clinical practice yet, but area of interest is going at multiple levels. The development of these molecules or research is going on a vast scale, and we have to be prepared that we'll be getting more and more molecules for our use in the clinical practice. Again, this is vasoactive intestinal peptide. Now, as we discussed, yes, mainly kidney is there, brain is there, which is modulating the hypertension response, RAS system or alternate RAS system. But even at the intestinal levels, there are some biological molecules. Those do act in and play a role in the hypertension. Like this VIP, this acts, and it's agonist that will act at the intestinal level, and that will be having the positive inotropic effects also, this molecule. That is one of the advantages that is being tested in the trials. Then again, we have seen the various channels or pumps at the renal level. Now again, this is one of the interesting channel that acts that is in the intestinal sodium hydrogen exchanger 3 inhibitor. This will, along with the dietary reduction of the sodium, it will act on inhibition of this pump, and that will help in reduction of the this will help in reducing the salt in the diet itself, like at the intestinal level also, and that will help in the hypertension, and that can be available say in the next 5 years, 10 years, and according to its safety level. Then dopamine beta hydroxylase inhibitor, again research molecule, prevents the conversion of dopamine to noradrenaline, acts on the sympathetic system, and helpful, that will be helpful in the hypertension. Then this is one of the things, soluble epoxide hydrolase inhibitors, that prevents conversion of lipid epoxides into dihydroxy lipids, and this is having positive effect on the BP control. Then it is having the favorable effect that prevents the cardiac hypertrophy, prevent the atherosclerosis, and now we have seen so many molecules, but the main thing will be to remembering the newer pathway, that is the RAS alternate pathway that has come into the picture in a large scale, and molecule acting on that RAS pathway, or like sacubitril molecule or daglutryl molecule, those will be coming into the that will be the recent future for all of us.
Yogesh, can we wind up in some minutes, please?
Yes. Few slides only. Yeah.
Thank you.
And these are the last few molecules. Those are into the pictures. Those have been used in the pulmonary hypertension. Sildenafil, that we have been using in the pulmonary hypertension patients. Sildenafil, vardenafil, tadalafil. And this is the same few tables only. Last of trials that is going on for all these molecules that has been listed in this table, what we have discussed in the last all the slides. And mainly aspects will be neprilysin inhibitor, then endothelin receptor inhibition, then AT2 receptor agonist, and a newer alternate RAS pathway. That will be the important thing. Newly approved drugs that are being into the practice. This is one table that is showing aliskiren, azilsartan, then clevidipine in the acute hypertension. Then cilnidipine is already available. Carvedilol, nebivolol, those are being used in the heart failure patients and hypertension patients. JNC 8 criteria is there for the treatment of hypertension, stage-wise treatment of the hypertension that everyone knows. Combination therapies we have been using since a long time. Various molecules we have been using in a combined way. And resistant hypertension, we have discussed this part also. A very important fourth, fifth drug like aldosterone inhibitors that already we are using, and newer methods we are into those are into the pictures. Interventional treatments, these are also into the trials. Renal denervation, baroreflex activation, that is into the picture. Carotid body ablation, AV fistula, that in the mechanism that was discussed, or in the epidemiology, fistulas were formed by the Hippocrates itself, like that was the age-old thing, very too many years ago. Again, that is being into the practice, or that will be many and more trials are needed on these interventional therapies. Thank you very much, Dr. Zubair. Yeah. Hello.
Yes, sir. I can hear you.
Yeah.
Yes. Thank you very much, sir. You can stop sharing your screen.
Yeah.
So this is the memento that we have prepared for you.
Oh yeah. Thank you.
It will reach you very soon.
Yes, sir. Thank you very much. Yeah.
Yes, sir. You can stop sharing your screen.
Yes. I'll do it. Is it stopped or it's still there?
It is there, sir.
Just a minute. It is stopped, I guess.
Yes. Now, I would like to call upon very senior consultant ophthalmologist of our city, Dr. Ehrar Khan sir. He has got total of 12 papers, of which 3 he has submitted in CMEs of IMA and 4 in CMEs of Maharashtra and ophthalmology. Sir is a very dynamic speaker and a very motivated and motivating person. He is always at the back of most of the doctors that are working in the city. I request sir to kindly share the screen and take over the charge. हाँ हाँ अब यहाँ पर बैठिए
Thank you, Zubair, and thank you, Team Elliot, for inviting me for this talk. The topic as is already clear, you have seen it. Most of the hypertensive changes that take place in this, they take place in the eye in the posterior segment, that is in the backside of the eye. You see primarily these changes that take place are in the optic nerve, the central retinal artery, the central retinal vein, and the macular area. This is where the main drama of the hypertension unfolds. How does the eye react to hypertension? Simply put, in response to hypertension, retina and its vessels, they are influenced by three elements: the state of the blood vessels before hypertension, that is whether or not there is hardening of the blood vessels; the rate of development of hypertension, that is how fast the blood pressure has risen; and the ultimate level of hypertension, that is how much has the blood pressure risen. How the elements matter is dependent much on the age of the patient, as they manifest somewhat differently in the young age and the aged. Now, what you see on the right side is the fundus, the retina in childhood. The retinal venules and arterioles, as you see, are of equal width. Both are well stuffed with elastic tissue, and the arterioles also with muscle. They glisten regularly in the light of an ophthalmoscope, and a thin white streak of light reflecting off the central portion of the arterial surface. It is simply referred to as the light reflex. As old age arrives, these fibrotic changes are advanced and are referred to as involutionary sclerosis. The blood pulses normally through these retinal vessels over the years. Both the elastic tissue and the muscle tissues are in due course replaced by fibrous material, which dulls the glistening arterial reflexes. The dulling is referred to as silver wire and copper wire appearances, although these terms keep turning up in textbooks, but we don't classically see it on ophthalmoscopic examination. But anyway, there is a difference between the appearances somewhat, which might be picked up by some kind of some senior ophthalmologist, but especially now with high definition technology, it is being picked up. After some time, the caliber of the arterioles too becomes slightly reduced. The shifting shines of the young retina gradually give way to a generalized dry coarse mottling. Finally, as the age decline arrives, these fibrotic changes are advanced and referred to as involutionary sclerosis. Here, what you see is an aging retina. The upshot, the how does the state of vessels varies? The upshot of all that is the vessels of the young eye, full of elastic tissue and muscle, will behave very differently from the rigid fibrotic vessel of an elder eye when it is exposed to hypertension. How? That we will see in a later slide. Rate of development of hypertension, just as the state of the vessels is important, matters also the rate of development, how fast it has developed. When blood pressure moves into the pathological range, it may rise slowly and moderately, or it may rise swiftly to unrecordable levels. The response of the eye is not the same in each case. The gradual and moderate rise, which is less than 200 to 120 millimeters of mercury. In the aging eye, again, we have to see these differences in the aging eye and the young eye. In the aging eye, the involutionary, that is sclerotic changes, are exaggerated. Any muscle remaining in the arterioles goes into spasm. The fibrotic arterial segments remain very much as they were or even dilate somewhat. These irregularities are seen as the shift in the arterial reflex. That is, the arterial reflex, as mentioned above, which is seen as a white streak, it now somewhat becomes broadened. The shift is from a silver wire appearance to a copper wire appearance, as also its appearance changes. Differences now develop at the same time, differences now develop at the arteriovenous crossings
which are described in a later slide. There is thickening of the arterial wall, which is obvious only where it passes over or under a venule and gives the illusion of compressing it. These AV changes can be taken at the point where pathological evidence of hypertension is taking over from the physiological evidence of passing time. Exposed to the youthful eye, when the youthful eye exposed to that kind of level, as already mentioned, exposed to a gradual and moderate rise of blood pressure, young vessels protect themselves with involutionary patterns, which, although acceptable at 60, this involution must be regarded as pathological at 20. We should then not be surprised to see the typical AV changes as are seen in the aging eye. When there is a rapid rise in blood pressure that is greater than 200 to 120 millimeters of mercury, both the old eye and the young eye now go on to the next stage in the process with hemorrhages, as you see here, which are flame shaped, typically flame shaped hemorrhages on the surface of the retina, which following the pattern of its superficial layers. Soon, lipids oozing from the disintegrating nerve tissue accumulates usually around the macular hollow, following the pattern of retinal fibers, which impart it a shape of a star. Here, as you see, is what you refer to as macular star. When the rise is rapid in blood pressure, what that is greater than 200 to 120 millimeters of mercury, what we see is cotton wool spots, which are whitish fluffy patches on the retina. They start appearing in both age groups and they do eventually fade out with time. These are actually the debris of intra-axonal. These are actually the intra-axonal organelles of the debris of the intra-axonal organelles of the nerve fibril layer of retina, which indicates acute renal ischemia. Hemorrhages present in simple hypertension will, of course, become more florid and indeed may burst into the vitreous, as you see in the lower slide that it has burst into the vitreous and caused vitreous hemorrhage. Rapid rise in blood pressure that is greater than 100 to 120 millimeters of mercury, whether the patient be young or the patient be old. Finally, the optic nerve, the head takes part and swells into a state that's called papilledema. Here you see how the optic disc is totally swollen. There are other. This is the normal disc as you see it here. This one is the swollen disc where you do not see the cup at all. This is the optic cup. You don't see cup here at all. And this is referred to as papilledema. The grading of hypertensive retinopathy, we generally use a 4-grade system to identify the severity of hypertensive retinopathy. The grades range from 1, general narrowing of the arterioles, to grade 4, signs of severe retinal damage. As we have already seen, hypertension causes 2 types of changes in the retinal vasculature: arteriolar constriction and arteriosclerosis. This is important to remember that there are these 2 kind of changes we see. Arteriosclerotic means hardening of the arteries. It's a general medical term that means the normally flexible artery wall is becoming hard or stiff. This occurs in long-standing hypertension. It is due to intimal hyalinization, medial hypertrophy, and endothelial hyperplasia. Here you see the 3 layers, and all these 3 layers, they undergo a change which makes the arterioles very hard. Arteriosclerosis is divided into 4 stages. There are 4 grades of arteriosclerosis. Grade 1 is broad arteriolar reflex and simple vein concealment. If you can make out here, you see there is the broadening of the reflex, and there is enhancement of the arterial reflex, and there is vein concealment. That is, you cannot see the vein at the point of the crossing. In grade 2, there is grade 1 plus deflection of veins as AV crossings, arteriovenous crossings. This is called as Salus sign. It is right here, the one below, the more on the left side. This the cursor is pointing to the Salus sign. Then come the tapering of the veins. There is tapering of the veins. This is called as the gun signs. And there is banking, that is dilatation of the blood vessels, and this is known as Bonnet's sign. This happens because the arteriole and arteriole and the venule share a common sheath. The common sheath, the arteriole's thicker wall push against those of the venule, forcing the venule to collapse. This makes the venule form an hourglass shape around the arteriole, or as the other theory says, this results not from the compression from the arteriole, but from the sclerotic thickening of glial cell proliferation at the site where the two vessels cross. The grade 3 is grade 2 plus copper wire arterioles, and marked changes at arteriovenous crossings. Retinal arterioles appear orange or yellow instead of red. Well, you can't surely make it out here, and I failed to find a very high definition of this figure of it from image of it from the internet. Grade 4 is grade 3 plus cerebral arterioles. Retinal arterioles look white if they have become occluded. This is known as silver wiring. Mild changes at AV crossings may occur in normotensive with involutional sclerosis, but severe changes are indicative of long-standing hypertension. Here you can clearly make out the silver wire changes. Arterial vasoconstriction, this is the primary response. As you have seen, the arteriolar constriction, the arteriosclerotic changes are somewhat, they happen over a period of time, but this is the primary response which happens immediately when the blood pressure rises. Its severity is dependent on the level of the blood pressure and the coexistence of age-related involutional sclerosis. The secondary effects are retinal vascular leakage, giving rise to edema and hemorrhages, and retinal ischemia. Now, it too has got 4 grades. You see here, it is somewhat difficult to make out, but you will see that this is the normal retina. This is grade over the normal vasculature. This is grade 1 changes. In the earliest stages, there is a mild generalized arteriolar constriction evident by a decrease in the ratio of the width of the retinal and to that of the retinal arterioles to that of the retinal venules. It is very evident here. You can see it here. In grade 2, there is severe grade 1 plus focal constriction. The focal, unlike the general constriction that you see here, there are focal areas that undergo more severe changes. Then what you see below is the later changes that will be discussed later on. In grade 3, you see grade 2 changes plus hemorrhages, cottonwool spots due to obstruction of precapillary arterioles, retinal edema, and hard exudates in the form of a macular star. The macular star that we have already seen while we were discussing the changes in the old age and the young age, sudden rise of hypertension. So these are the flame-shaped hemorrhages that we see. There is retinal edema, and finally there is disc swelling, as we have already seen. This is the grade 4 change, which is usually seen in malignant hypertension. To summarize, grade 1, there is arterial thickening, tortuosity, increased reflectiveness, silver wiring. Grade 2, grade 1 plus constriction of veins at arterial crossings, arteriovenous nipping. Grade 3 is grade 2 plus retinal ischemia, that is flame-shaped hemorrhages or blot hemorrhages and cottonwool exudates. Grade 4 is grade 3 plus papilledema. Diagnostic tools, I won't like to go much in detail about this. There are the two methods, the direct method, the direct ophthalmoscopy. This is the preferred method to the first one because it gives a very limited view, that is only of the posterior pole, while the indirect ophthalmoscopy, it gives you a wider view even of the peripheral retina. Then the next investigation is optical coherence tomography, or OCT. It is an imaging method used to generate a picture of the retina. The non-invasive method produces an image by measuring the amount of dim red light that reflects off the retina and optic nerve. Optical thickness and coherence tomography can measure the thickness of the retina and optic nerve. Here what you see is the normal OCT, which describes the various layer of the retina, and it is a very simple procedure. Here you can see how it can be done in a very simple way. It is a non-invasive method. The current gold standard, however, is the angiography, is the fundus fluorescein angiography. The procedure is used for examining the circulation of the retina and choroid using a fluorescent dye and a specialized camera. Sodium fluorescent dye is injected into a vein in the arm or hand, and approximately 10 seconds after the injection, a series of black and white or digital photographs are taken of the retina before and after the fluorescence reaches the retinal circulation. Photos are taken approximately once every second for 20 seconds. Then less often, a delayed image is obtained at 5 and 10 minutes. Sometimes a 15-minute image is taken as well. A blue filter is placed in the camera, so only the fluorescent yellow-green light is recorded. The principle is very simple, that is, the dye shouldn't be found where it is found, and dye is not found where it should be found. That is, here you see a normal, what you see is here is a normal angiography. You see the dye should be in the blood vessels, so it is shining in the blood vessels. Suppose if there are leaks or some kind of pathology, you will see the white fluorescence in those areas. So the basic thing to understand is where it should be, it shouldn't be, it is, and where it should, it is, it isn't, which often happens when the macula is totally ischemic. Complications. The sometimes, while other investigations resorted to are not regularly recorded to, but they are resorted to as and when indicated as ocular ultrasonography in hemorrhage to rule out RD. Complications is subconjunctival hemorrhage, occlusion of the central retinal artery, occlusion of the central retinal vein, vitreous hemorrhage, non-arteritic anterior ischemic optic neuropathy, and adverse effects of anterior hypertensive drugs. Now, this is very unusual. Nowadays, it was actually very controversial whether subconjunctival hemorrhage is really caused by hypertension or not, but it is now established that the sudden presence of blood scattered over red area of sclera, which is known as subconjunctival hemorrhage, is usually due to is one of the causes of it is hypertension. Though hypertension is often associated, it is not exactly the cause unless there is a sudden rise of blood pressure to very high levels. Also, unless subconjunctival hypertension is subconjunctival hemorrhage is severe and the blood pressure is uncontrolled, hypertension isn't a cause of subconjunctival hemorrhage. Such uncontrolled hypertension patient is most likely to have other systemic symptoms. Hence, it is unlikely that in an otherwise normal patient, SCH should be the presenting clinical feature of hypertension. Nevertheless, in an already known long-standing case of hypertension, subconjunctival hemorrhage does occur even if the blood pressure is controlled with drugs, as it causes microvascular changes in the conjunctival vessels. It requires no specific treatment except tear substitutes if there is scratchy feeling. Depending on the extent of the SCH, the blood gets absorbed in 8 to 10 days or at the most 2 weeks. Here you see specifically that it is turning yellow. You have to tell the patient that while it is clearing off, the eye may turn yellow and the patient may not get scared or think it to be due to jaundice, which is usually what patients think. Central retinal artery occlusion, interruption in the arterial flow leads rapidly to the total retinal infarction. The retina normally is transparent, clouds into opacity, except at the macula where the cherry red spot choroid can be seen through the macular flow. You can see that the whole of this is very opaque, which is usually transparent, and right in the center, you see a cherry red spot. This is the classical sign of central retinal artery obstruction. At the very outset, it is one should know very clearly that there is no standard treatment for CRAO. There are invasive and non-invasive managements that have been tried without much success, or the fact that any treatment has essentially to be administered in less than 2 hours of the onset of loss of vision. The goal of each non-invasive treatment is to increase blood flow and blood oxygen content. Most invasive procedures are aimed at reducing intraocular pressure and to lyse or dislodge the obstructive embolus. The first one is the very simple one. It is the ocular massage. It can dislodge the embolus to a point further down the arterial circulation and improve retinal perfusion. Pars plana vitrectomy with direct central retinal artery massage invasive. Ocular massage, as here you see, is the in and out movement with 3-mirror Goldman contact lens or digital massage. This is usually done by the could be done by the ophthalmologist. It can dislodge an obstructing embolus, increase pressure for 10 to 15 seconds, followed by sudden release. There is an 86% increase in the volume of the flow. One has to keep in mind that even if you are digitally pressing from one end to the other end, you should not press it very hard. It should be a very slow 10 to 15 seconds for a very short time, a movement of fingers from one to the other end or the tip of the with the tip of the finger. The pars plana vitrectomy with direct in central retinal artery massage. It is an invasive procedure. A probe was designed to apply direct gentle pressure massage over the CRA and the optic nerve head. Of 10 patients, circulation was restored in only in 4. One of the commonly employed at general practice level, at clinical level by most of the practitioners is anti-chamber paracentesis, which is an invasive method. A 0.5-inch 30 gauge metal is as a tuberculin syringe without plunger is used. Needle is placed between iris and cornea. Between iris and cornea, here you see between iris and cornea, not in the pupil. It should not go in the pupil. Central corneal pressure stabilizes eye and facilitates removal of aqueous humor from the anterior chamber, which causes a decrease in the intraocular pressure. This is believed to allow greater perfusion, pushing emboli further down the vascular tree. Medical reduction of intraocular pressure. This is non-invasive. Acetazolamide 500 milligrams intravenous or 500 milligrams per oral can be administered to immediately lower the intraocular pressure. Topical medications are also used to lower intraocular pressure. They act by decreasing aqueous humor production with beta-adenergic blockers or carbonic anhydrase inhibitors, or increasing outflow with prostaglandin analog or alpha agonist. Laser emboloptomy. This is again an invasive procedure. Lysis of the emboli can be achieved with neodymium YAG laser. Retinal perfusion with gain of visual function can be achieved. However, complications such as creation of false aneurysms and vitreous hemorrhage may arise. Intra-arterial fibrinolysis is again a non-invasive procedure. It has been used anywhere from between 1 hour to up to 24 hours, although this procedure is still very controversial. Thrombolytic agents have been studied for CRO, the thrombolytic agents that have been studied for CRAO treatment include intra-arterial tizoplasminogen activator, TPA, and urokinase. Just like the paracentesis, hyperbaric medicine is again has remained a popular treatment. It is effective in the first when the patient has come to you in less than 2 hours. The basic thing is the inhalation of the patient is made to inhale 100% of oxygen at 12 atmospheric absolute provides an arterial PO2 of 1000 to 1200 millimeters of mercury, which results in a threefold increase in oxygen diffusion distance through ischemic retinal tissues. It must be kept in mind that these patients are usually also having some multi-organ problems, so these should not be tried in an isolated institution and should other organs should also be taken into consideration, and there should be a team of specialists available around the clock. Intravenous methylprednisolone, which again is a non-invasive method. A single dose of intravenous methylprednisolone of 1 gram has been reported in a case series of patients whose vision failed to improve following the conventional treatment of measures to reduce the intraocular pressure. The possible mechanism of action is reported to be a reduction in the retinal edema and hence improvement of vision. Management of central retinal vein occlusion. Here, as you see, the disc is swollen and hemorrhages dominate the appearance of an equally swollen retina. Should the oxygen supply be compromised, and it is not always, the eye may respond as it does in diabetes, often an associated disorder with new blood vessels sprouting out over the retina and creeping over the iris root into the drainage angle where it may block aqueous outflow, turning the eye into a visually useless ball of pain and redness by causing close angle glaucoma. Here you see is the classical CR view. What you see here, down here, this is the formation of new blood vessels, new vascularization of the organs. and this is the angle. The angle is blocked due to these new vessels, due to which the aqueous cannot flow out, and as a result of that, glaucoma develops in the eye. Management of central retinal vein occlusion in patients who receive no treatment, about one-third improve on their own, about one-third vaccine vein and stay about the same, and about one-third get worse. If there is macular edema, it may improve on its own, especially in the young aged patients compared to elderly patients. Commonest treatment is periodic injections into the eye of an anti-VEGF, that is vascular endothelial growth factor. These drugs include Avastin and Lucentis. Avastin is very commonly used and it is the cheapest, and studies suggest that it has got all these molecules have got equal effect. Avastin is cheapest among them, so one can definitely opt for Avastin. Their effect in the eye wears off, so re-injection is often needed. A rare lucky patient needs only one injection, but the norm is a series of periodic injections over the course of a few years. Management of continuing the management of central retinal vein occlusion, intraocular steroid intravitreal injection of triamcinolone or a small steroid pellet called dexamethasone implant. The steroid injections typically last several months, but can cause elevated intraocular pressure requiring eye drops or increased rate of cataract formation. This is also commonly used treatment, the injection of the triamcinolone, and it is quite effective too. Laser for photocoagulation is considered to be the first-line therapy for treating the compilation of the retinal vascular disease. There is pan-retinal
Recording in progress.
Praveen sir, you can unmute yourself.
Yeah, thank you. First of all, I would
Yes, sir, you
congratulate the
we can
organizers.
hear you. Put your presentation on. Yes, definitely. You're perfectly going on, sir. You can go.
First of all, I would like to congratulate the organizers of the CME for a wonderful CME which is going on hypertension. I was given the topic of kidneys and hypertension, and I would be very brief, like maybe I would complete the topic before the time allotted to me. Let's begin. Hypertension is one of the leading cause of global disease and affects more than 1 billion of individuals and around 10 million deaths per year. Hypertension usually doubles the risk of cardiovascular diseases such as coronary artery disease, congestive heart failures, cerebrovascular accidents, peripheral arterial disease, and renal failure. The genetic and environmental factors also contribute to the prevalence of hypertension, out of which obesity, weight gain, high dietary sodium chloride intake, low dietary intakes of calcium and potassium, alcohol consumption, psychosocial stress, and low level of physical activity, that is sedentary lifestyle, is one of the leading causes of the hypertension. Genetic considerations has also been taken into the mind. Its hypertension is considered to be a polygenic in inheritance. There are significant heritable components into the range of 30 to 40%, with more than 25 mutations and more than 100 hypertension related polymorphisms, which are seen in the pathways related to hypertension regulation or blood pressure regulation. Also, there is a phenomenon called genetic anticipation in hypertension. Just go through the mechanisms of hypertension. For understanding the regulation of arterial blood pressure, normal or elevated, is necessary to formulate the treatment strategy. Now, the determinants of hypertension are cardiac output and the peripheral vascular resistance. And the cardiac output, as we know, it depends on the stroke volume as well as the heart rate. And the stroke volume is directly proportional to the myocardial contractility and the size of vascular compartment. And the peripheral vascular resistance is proportional to the functional and anatomical changes in the small arteries, arterioles. The intravascular volume, which is related to most of the time kidneys, is both the kidneys is considered as target as well as the cause for hypertension. The mechanism of secondary hypertension is usually most of the time related to kidneys. And the mechanisms are reduced capacity to excrete sodium, excessive renin secretion due to volume status, that is pressure natriuresis, and autonomic nervous system sympathetic overactivity. Sodium chloride, that is salt, can activate various neural, endocrine and paracrine as well as vascular mechanisms. And that's why the non-chloride salts of sodium has a relatively little effect on the blood pressures. Salt retaining leading to volume retention leads to hypertension. This is a simple phenomenon. And conversely, if there is a diseases which are salt losing or salt wasting, then the diseases are associated with the low blood pressure or hypertension, I would say. Autonomic nervous system, that is norepinephrine, epinephrine, dopamine, are short-term tonic and phasic cardiovascular regulators. The hormones and volume-related factors associated with the long-term lipid regulations. Norepinephrine, epinephrine, and dopamine are mediated through G protein-coupled receptors, and there are the adrenergic receptors like alpha-1, alpha-2, beta-1, beta-2, and alpha receptors bind avidly to the norepinephrine, then epinephrine, and the converse is true with the beta receptors. The alpha receptors are post-synaptic vasoconstrictors and increases the tubular reabsorption of sodium. Alpha-2 receptors are presynaptic. It inhibits the secretion of norepinephrine and will eventually decrease the blood pressure. The beta-1 receptors are in myocardium. It stimulates the heart rate and the strength of the to increase the cardiac output, and it stimulates the renin release from the kidneys. Beta-2 receptors stimulation relaxes the vascular smooth muscles, leading to the vasodilatation. The arterial baroreflex mediated through the stretch-sensitive sensory endings in carotid sinus and aortic arch. These baroreflex control of blood pressure usually deteriorates with the advancing age, hypertension, and atherosclerosis. The autonomic neuropathy and impaired baroreceptor function is associated with the labile hypertension or a labile blood pressure. The next mechanism of action is mostly related to kidneys, and this is like the RAS system or renin-angiotensin-aldosterone system. It controls the blood pressure via vasoconstriction by angiotensin II and sodium retention by aldosterone. The stimulus for renin secretion is decreased sodium chloride in macula densa. And this leads to decreased pressures of stretch of renal afferent arterioles through the baroreceptor mechanisms, and the sympathetic nervous system activation of renin secreting cells by beta-1 receptors. The angiotensin 1 receptor mediates the activation of angiotensin 2 the potent vasopressor, and a trophic substance for secretion for aldosterone. Angiotensin receptor 2 is a vasodilator, sodium excretion, and inhibition of the cell growth and the matrix formation. And aldosterone is the potent mineralocorticoid. Some vascular mechanisms are there, like vascular radius and the compliance of the resistant arterioles. The resistance to the flow is inversely proportional to the fourth power of the radius. Hence, the small decrease in the radius increases the resistance significantly. Also, arterial stiffness is the manifestation of hypertension. Mean arterial pressure is cardiac output multiplied by peripheral resistance. And one more term you need to know is like aortic augmentation index, that is central aortic pressures divided by pulse pressures. The last contributory mechanism for the hypertension would be immune mechanisms from inflammation and oxidative stress. Low-grade inflammation and uncontrolled activation of immune cells, immune system associated with vascular injury and hypertension. Both T cells and B cells are considered to be involved in this. Increased in the sympathetic nervous system activation also is possible with chronic inflammations. Mechanical forces in the vascular walls, interstitial sodium concentration, and a high salt intake are considered to be the factors for increasing the blood pressures. So the definition of hypertension as given is like normal is less than systolic blood pressure less than 120 and diastolic less than 80. Normal elevated would be the 120 to 129 of systolic blood pressure and less than 80 of diastolic. Stage 1 hypertension and stage 2 hypertension. Stage 1 is like 130 to 140 systolic blood pressure and the diastolic blood pressure of 80 to 89. And stage 2 hypertension is more than 140 millimeters of mercury systolic and more than 90 millimeters of mercury diastolic blood pressure. But along with these numerics, we need to consider few more things while labeling the patients as a hypertensive. The level of blood pressure at which addition of treatment reduces the blood pressure related morbidity and morbidity. On an average, 2 or more seated BP recordings should be during the two separate OPD visits. In children and adolescents, the systolic blood pressure and diastolic blood pressure should be more than 95th percentile of age, sex, and the height. And the blood pressure between 90 to 95th percentile should be considered as a pre-hypertension. Ambulatory blood pressure monitoring is the best out of office or out of OPD method of BP measurements. Normally, there is a 10 to 20% dip of blood pressure in the night, and the attenuation of this nighttime dip of blood pressure is the earliest indication of hypertension and the coronary artery diseases. We need to consider white coat hypertensions, that is increased office BP but normal home and ambulatory blood pressure monitoring. And masked hypertension also, like we need to consider the normal office BP but raised home as well as ambulatory blood pressure monitoring. So these are the few the kidneys, like as the topic given to me is the kidneys along with the hypertension. The kidneys, there are two ways the kidneys can be considered in hypertension. One is as a cause and the other one would be as a target organ. The cause would be renal parenchymal disorders like acute renal failure, chronic renal failure, acute glomerulonephritis, tubular nephritis, autosomal dominant polykidney, polycystic kidney disease, and obstructive uropathies. The renal vascular disorders also has to be considered in the mind. That is renal artery stenosis as well as fibromuscular dysplasias. Renal hormonal disorders like erythropoietin and other things are known to increase the blood pressures. Renal metabolic disorders like congenital adrenal hyperplasia, diabetes, hyperaldosteronism, and all of those things. Renal angiotensin aldosterone system plays a central role of salt and water retention or homeostasis and blood pressure control. Juxtaglomerular apparatus, that is granular cells synthesizes and releases the renin, which acts on angiotensinogen to produce angiotensin 1, which is converted by angiotensin converting enzymes in the lungs to angiotensin 2, which acts on 81 and 82 receptors in the kidneys. This renin release is mediated by decreased afferent arterial pressure, sympathetic nervous system activation, decreased sodium delivery to distal convoluted tubule, and through the prostacyclin and ACTH. The causes of renin release increases are renal artery stenosis, renal cell carcinomas, benign reninomas, antihypertensives like calcium channel blockers and diuretics, and in essential hypertension. Actions of angiotensin 2 are like arteriolar vasoconstrictions, efferent renal arteriolar vasoconstriction, aldosterone secretion, adrenaline release, smooth muscle hypertrophy, increased reabsorption of sodium in proximal convoluted tubule, inhibits the renin release, a negative feedback, a renal mesangial cell growth and matrix expansion, myocardial growth, stimulates the thirst and ADH release. The other part of the RAS is aldosterone, which acts on the collecting duct to promote the sodium reabsorption and potassium excretion. Hypertension, low plasma renin activity, cardiovascular diseases, and renal damage. Ratio of plasma aldosterone to plasma renin activity is a very useful screening test. One is associated with adrenal adenoma. Now, in this as hypertension, usually it presents as a benign nephrosis with fibrinal necrosis and flea-bitten kidney appearance. Glomerulosclerosis, like focal segmental glomerulosclerosis and other glomerulosclerosis. Persistent proteinuria, which can be microscopic or macroscopic sometimes. Microscopic hematuria also, and small kidneys. When should we suspect kidney disease in hypertension? When the patient is younger than 30 years, the blood pressure is having sudden onset of over the previous stable blood. The
Recording in
requirement
progress.
of the antihypertensives is considered to be more than 4 or 5. Deranged or raised kidney parameters like creatinine, urea, and other. Unequal kidneys, like in cases of renal artery stenosis, one can have unequal kidneys. Usually, the flash pulmonary edema is usually present in the kidney-related hypertensions. Persistent proteinurias and microscopic hematuria has to be considered as a patient having renal hypertension. And abdominal bruit, which is one of the classical findings in the renal artery stenosis. We have to consider few things while considering the hypertension because of the kidneys. Is this a sustained hypertension? Is this a primary or a secondary hypertension? Are there other severe risk factors? And is there a target organ damage? We usually advise following investigations in these patients. One is urine analysis, the kidney function test like creatinine, blood urea nitrogen, eGFR calculation, urine examination, and serum calcium levels. Blood glucose and HbA1c, as diabetes is considered to be one of the cause which can create hypertension through the kidneys. The ECGs, ECOs, urine albumin creatinine ratio or protein creatinine ratio, acid, arteries, plasma renin and aldosterone activities sometimes has to be considered, and sonography abdomen for renal sizes, corticomedullary differentiation, calculus, and renal artery Doppler sometimes. management of the hypertension, which is related to kidneys, there are few common guidelines and but few are kidney related. One is weight reduction. We should grams per
Recording in
day.
progress.
We should adopt a DASH diet, that is dietary of hypertension diet, which is rich in fruits, vegetables, low in fat, and dairy products. Diet rich in potassium, calcium, and magnesium is promoted and will cause the control of the hypertension. The alcohol consumption should be in moderation, but these are Western guidelines. In India, I would consider that there should be no alcohol consumption, but like conventionally, less than 2 drinks for male and less than 1 drink for female is to be strictly followed. And physical activity, the regular aerobic activity such as brisk walking or a slow jogging for around 30 minutes has to be followed. The treatment of hypertension, kidney hypertensions, CC and AHA, one is like indication use BP lowering treatments, that is secondary prevention of recurrent coronary CVDs events in patients with CVD with systolic blood pressure of more than 130 and 80. The primary prevention in the patients with estimated 10 years ASCVD risk more than 10% with systolic blood pressure of 130 and diastolic of 80. Primary prevention of
Recording in
from
progress.
hypertension and known case of CVD and known ASCVD risk of more than 10%, the BP target of less than 130 to 80 millimeters of mercury. The possible exceptions are patients with more than 80 years of age, patients previously untreated for hypertension with ischemic stroke or TIA, and acute. The antihypertensive treatment armamentarium is like beta blockers, alpha blockers, vasodilators, calcium, centrally acting antihypertensives, calcium channel blockers, diuretics, ACE inhibitors, ARBs, and renin inhibitors. And the last four are having majority of action through the kidneys. Earlier lecture had covered almost all the new and recent advances in the treatment of
Recording in
distal convoluted
progress.
tubules. The problems are hypokalemia, raised sugars, raised triglycerides, uric acid, sometimes erectile dysfunctions, and cannot be used with patients who are on lithium treatment. The loop diuretics, which blocks the sodium potassium 2 chloride channels in thick ascending limb of loop of Henle. Sequential nephro blockade to be considered in the patients who are edematous, like to overcome the diuretic resistance, includes the loop diuretic as well as the thiazide diuretics. Some potassium sparing diuretics are also important, which blocks the epithelial sodium channel in late distal convoluted tubule and collecting duct. Calcium channel blockers, though his majority of action is on the arteriole, but has to be considered in the kidneys. Two kinds of these are there: the dihydropyridine, that is DHP, and non-DHP. The dihydropyridine usually blocks the voltage-dependent type of calcium channel, decreasing the calcium entry into the smooth muscle and decreasing the smooth muscle contraction and leading to the arteriolar vasodilatation. And as we know, the smallest dilatation in the arteriole will reduce the blood pressure significantly. The non-dihydropyridine derivatives are usually cardiac. They are used as an antiarrhythmics. Why we use DHP-CCBs? This has got a better BP lowering effect, less BP variability. It can be combined with any antihypertensives. Is a good choice in patients with angina, effective in low renin blood pressures. They are lipid neutral. BP reducing effect not blunted by NSAIDs, but the side effects are flushing, tachycardia, peripheral edema, gum hypertrophy, and not effective as ARBs and ACE inhibitors against hypertension or diabetes related kidney disease, nephroprotective wise or a kidney protective wise. Angiotensin converting enzyme inhibitors like initially captopril, enalapril, and now the ramipril, perindopril, and other things blocks the angiotensin 1 conversion to angiotensin 2, having relatively mild antihypertensive effects, but they are very much cardioprotective and nephroprotective. They have a synergistic effects with diuretics, beta blockers, calcium channel blockers, alpha blockers. The combination with ARB is not recommended as it would lead to complete RAS blockade. It would be decline in the renal artery stenosis, decline of the KFTs in the renal artery stenosis, congestive cardiac failure, and volume depleted status, and will lead to deleterious hypotension, hyperkalemia, cough and angioneurotic edema sometimes. 82 receptor blocker of 81 leading to inhibition of vasoconstrictive effect of angiotensin 2 has a comparable efficacy with the angiotensin converting enzyme inhibitors and synergistic with diuretics, and renal protection is documented. Renin inhibitors antagonizes the RAS system. Aliskiren is not commonly, but used, not very popular, only indicated in high renin blood pressures. No apparent CV or renal benefits. Increases the potassium and decreases the blood pressure. Non-pharmacological treatment for hypertension, there are few. Renal denervation with radiofrequency energy, thought to be associated with reduction blood pressure, usually done endovascularly in the patients with the resistant hypertension by a cardiologist. Blood pressure, not the definition of resistant hypertension in this, which is given, is like BP should not control even after the 5 antihypertensives. The mean reduction of blood pressure with this treatment is around 28 to 32 millimeters of mercury. The benefits are sustained for around 3 years. Around 15% treatment failure is there, and the disadvantage is in invasive procedures. Few other non-pharmacological treatment for hypertension is device-guided respiration, which promotes the slow and deep breathing. And the other one is the baroreceptor activation methods. So this is from my side regarding the kidneys and antihypertensives. Thank you, organizers.
Thank you very much, sir. Can you hear me?
Thank you very much, sir.
Okay, thank you very much.
Yes, sir. You can
I would like to thank Dr. Shafi Saab. He is my batchmate from IGMC Nagpur, and I congratulate him for organizing this wonderful CM.
Yes, sir. Thank you, sir. Dr. Shafi sir is here, and he would like to present a memento to you.
Thank you, Shafi bhai. Thank you.
Yes, thank you, sir. So next, I would like to call upon our next speaker, Dr. Ehsan sir, a very dynamic consultant diabetologist at Diabetes Center, practicing since last 12 years in city of Aurangabad and the periphery. He is director of Diabetes Care Center and Khushi Women's Hospital in Aurangabad, Maharashtra. He has been a regular and a very beautiful orator in national and regional diabetology conferences. Uh, he is the university ranker in diploma in diabetes of Mumbai University. He has presented many posters in conferences, one of which we will like to highlight is the real life experiences using vildagliptin versus sulfonylurea, which he has presented in Lisbon in 2011. He had participated in GARD studies of vildagliptin by Novartis. One of the investigator in landmark trials by Sanofi. He is in organizing committee member of RSSDI 2009 and he is treasurer of DEFCON 2016 held in Aurangabad. Sir, all over to you. You can share your screen.
Yeah, respected chairs. Thank you, Dr. Zubair, for the kind introduction and kind words. I'm audible?
Yes, sir. Yes, sir. You are audible.
It is proper, no problem?
Yes, sir. Very, very, very proper.
Yes,
Yes,
thank you. So, good afternoon, esteemed delegates. Next 20 to 25 minutes, I will be talking on the hypertension updates in diabetes. Since morning, I have listening lectures with all great details. Actually, I'll try to save some time. My topic is very simple and small, so I will be very specific to my topic actually. As the Indian patients in the Asian Indian patients, actually, we are having very high risk of development of metabolic illnesses like type 2 diabetes, hypertension, dyslipidemia, central obesity. The more worrisome part as a Asian Indian patients is actually we are having very high predisposition of the metabolic illnesses due to very high fat content, visceral fat content, the high insulin resistance at lower BMI, so that we develop type 2 diabetes, hypertension 10 years before the Western population. So this is the very much a worrisome fact as far as healthcare professionals are concerned, and this is creating a largest burden on our health system actually. We know that this is the dual combination like hypertension and diabetes. They go in hand in near about 40 to 80% of the patients. At diagnosis, we have got hypertension in diabetic population near about 50% of the patient. If patients are not having hypertension, in diabetes, the risk of developing hypertension is 2.5 times high. And if patients are having diabetes, development of hypertension in this patient is also twice high. So both share the common pathology. If you see the prevalence of the hypertension in type 1 diabetes, it is near about 25% of the patient. At diagnosis, the prevalence varies from 20 to 40%. With microalbuminuria, it is seen in 30 to 50% of the patients, and with macroalbuminuria, it is seen in 65 to 88% of the patients. In type 2 diabetes, at diagnosis, 50% of patients of type 2 diabetes, they diagnosed hypertension. And along with the microalbuminuria, almost 80% patients have hypertension, and in with macroalbuminuria, more than 90% patients have hypertension actually. So in 50% of the patients, we are having hypertension to treat. And as far as diabetes is concerned, diabetes management is not only restricted to glycemic control actually. It is equally important to control the blood pressure of the patient. It is equally important to control the weight of the patient. It is equally important to control the lipids of the patient and to prevent the complications. If you see the magnitude of the problem in India actually, we are having the burden of 31 crore of the patients having hypertension in our country. And the worrisome fact is that among that 31 crore of the patients, only 50% of the patients are aware that they are having hypertension, and among that 50% of the patients, only 50% patients are taking treatment, and among that 50% patients, those receiving treatment, only 50% patients are under control. So this is the rule of half, which is applicable to Indian habits. So this indicates there is a lot of room for the improvement of the metabolic care in our country, and the same are still undiagnosed in our country. So this is the very important, and this indicates that there is a large room for the improvement of the metabolic care in our country, and we have to do the regular screening, detect maximum number of patients at lower age of onset, do the lifestyle that patient up to the target so that we can prevent the micro and macrovascular complication in the future life. So this is very important. If you see the data or projection of the magnitude metabolic diseases in India, diabetes, pre-diabetes contributing to near about 24 crores of the patient, and if you see the hypertension, 31.5 crore of patients are having diagnosed hypertension. If you see the distribution among the rural and urban areas, it is approximately rural areas are not lagging behind in the metabolic illnesses nowadays, and they are showing equally high figures as compared to the west urban population. So this is the data from the ICMR in-depth study launched in the Lancet actually. If you see the control status, this is very important slide actually. If you see the control status of the metabolic parameters in our country, diabetes is controlled only in 36% of the patients who are maintaining HbA1c less than 7. Blood pressure is controlled only in 50% of the patient. Cholesterol is controlled in almost 65% of the patient. Triglyceride is controlled in 48% of the patient, and LDL is maintained under target range less than 100 in 42% of the patient. If you combine the A1C, cholesterol and blood pressure, it is controlled only in 8% of the patient in our country. So 90% patients who are having risk of metabolic illnesses in the form of diabetes, blood pressure, dyslipidemia, 90% patients are not maintaining their target, they are not under control. So this definitely increases our responsibility as a healthcare professional. So we have to treat our patients up to target. Definitely we are lagging somewhere line in the system actually. Now coming to the pathology, since morning we are learning this pathology. The hypertension and diabetes, they share the pathology of same pathology like insulin resistance in the background of genetic predisposition and environmental factors. We can see here this insulin resistance and hyperinsulinemia leads to inflammation. It leads to increase in the neurohumoral activation in the form of renin-angiotensin aldosterone system activation. There is sodium retention and volume expansion. There is sympathetic overactivity, and we have to target all these three parameters as far as neurohumoral activation is concerned. On the other side, we are having oxidative stress with the increased vascular remodeling, endothelial dysfunction, arterial stiffness, which increases the peripheral resistance and leads to the high hypertension actually. So everything is going on in the background of high genetic predisposition, environmental factors, lack of sleep, different addictions and stress and all that. Now these are the definition and screening of the diagnosis. Since morning we are knowing normal blood pressure is 120/80, pre-hypertension 120 to 139, stage 1 is 140 to 159, and diastolic is 90 to 100, stage 2 is more than 160/100 actually. So these are the definition of screening. Now what is the peculiarity of the hypertension in diabetic patients actually, that we are going to talk. In the pre-hypertensive patients, we have to just do the lifestyle modification. I'm coming to that details like proper diet, proper exercise plan, adequate sleep, lack of addiction, everything we have this come under the lifestyle modification. But stage 1 and stage 2 needs the proper anti-hypertensive treatment. In case of pre-hypertensive stages, along with diabetes or CKD, we have to maintain the lifestyle modification, and if you are not able to sustain the target that is less than 130/80, we have to give the drug treatment actually. So the ADA recommendation that to maintain the target blood pressure in diabetic patients should be less than 130/80, and always measure the orthostatic hypotension at each and every visit for the diabetic patient to rule out the autonomic neuropathy. Now, screening and diagnosis. We have talked since morning. We have talked just to complete the forum. I'll just tell you, whenever patients are coming to you, every visit you have to check the blood pressure. Keep the room calm and quiet. Tell the patient to rest, take rest for 5 minutes. Do check blood pressure readings in the 3 formats, 1 minute apart. Take the average of last 2 readings, and check the postural drop as well. If the patients are in the lying down position, stand stand him, wait for 1 minute and then check blood pressure. If the postural drop is significant, more than fall in the systolic blood pressure more than 20 millimeter of mercury and more than 10 millimeter of mercury in the diastolic, this is significant postural drop. It indicates autonomic neuropathy actually. So every visit we are supposed to check this. If patients are having masked hypertension, like they are borderline hypertension and they are not having usual readings of high blood pressure, this is called as masked hypertension. In that cases, there is a very good tool that is called as the ambulatory blood pressure monitoring system. With this very easy and very handy tool which we have to use. Apply that tool, send the patient at home, check the blood, take the readings for 24 hours, and then we can definitely detect at what time of the day patients are having hypertensive readings. Actually, this is very good tool to rule out the white coat hypertension. This is very good tool to be helpful in the resistant hypertension, and this is also useful to detect the cases of masked hypertension. So if patient diagnosed hypertension, what is now I am going to talk regarding the what is the peculiarity of the hypertension in diabetic patients particularly. So these patients are typically shows the lack of nocturnal dipping in the arterial blood pressure, lack of nocturnal dipping. This Dr. Rizwan sir is going to talk on the hypertension in the cardiovascular illnesses. Definitely is going to give the significance of lack of nocturnal. Lack of nocturnal dipping is associated with the increased risk of stroke and myocardial infarction. So nighttime blood pressure control is very essential in diabetic patient to reduce the CV risk actually. So this is one peculiarity. Second peculiarity is this hypertension is salt sensitive. So sodium sensitivity is found in the diabetic patient in the absence of nephropathy as well. So if we are controlling the salt intake in this patient, definitely we are giving very good help to control the blood pressure in the population. Third category is like there is a systolic blood pressure rise in majority of the patient at the time of microalbuminuria, which leads to rapid progression to the nephropathy. And isolated systolic hypertension has got a high risk of micro and macrovascular complications. So these are the four peculiarities of the hypertension in particularly diabetic population. Now coming to the management straight away, lifestyle modification is very essential and very important part of the management of management of hypertension in the diabetic population. See, proper diet and proper exercise and weight loss implementation program, good adequate sleep of 8 hours, and keep the patient away from the addictions like any form of tobacco, any form of alcohol. All these things we need to stop and regulate actually. So what is the significant weight loss in the metabolic illnesses? If patients are doing 5 to 10% of the weight loss in the duration of 1 year actually, so this is called as significant the significant weight loss, which gives the good metabolic benefits actually as far as glycemic control is concerned and as far as the reduction in the blood pressure is concerned. So 1 kg reduction will reduce the blood pressure by 5 millimeters of mercury in the hypertensive patient. Diet, which Pant sir has already spoke about, the dietary approach to stop hypertension. It is rich in the fruits and vegetables and whole grains, and reduction in the fat, and the trans fat gives rise to very good blood pressure reduction up to 10 to 11 millimeters of the mercury. Now third point is in the lifestyle modification is reduce the sodium intake to less than 1.5 gram per day. So this is the sodium content actually, and sir was talking regarding the salt content actually, which we have to reduce to 2.3 grams in a day. So sodium reduction up to 1.5 milligram or 1.5 gram per day will reduce the blood pressure by 5 to 6 millimeter of mercury, and then simultaneously we have to increase the potassium content like up to 3.5 to 5 gram. It is rich in the fresh fruits and nuts actually. Coming to the exercise is very important. All the metabolic illnesses, the ADA guidelines, the AAC guidelines, they recommend to do the aerobic exercise at least 150 minutes or 30 minutes in a day, or maximum 150 minutes per week. But in that exercise also try to achieve the maximum heart rate up to 80%. That gives rise to reduction in the blood pressure by 5 to 8 millimeters of the mercury. Along with that, we have to do some resistance exercises, because nowadays there is a concept called as sarcopenia, which is a very very bad state of the muscle in the patients, particularly in the patients with the metabolic illness. Less muscle mass is very dangerous as far as metabolic risk is concerned. So we have to not only control the weight of the patient, but simultaneously it is very essential to increase the muscle mass in the patient. So that to increase the muscle mass, we have to cut down the carbohydrate, we have to increase the protein content in the diet, and do some strenuous exercises like push-ups, pull-ups, weightlifting and all. That exercise for 15 to 20 minutes and 30 minutes of the deep walking in the form of aerobic exercises, which is very essential to control the metabolic risk. And then the control of moderation of the alcohol, already I spoke about. So the general treatment, like the drug of choice, I'm going to talk regarding in detail regarding the guidelines and the resistance hypertension, but the general recommendations in the patients of diabetes, patient has to be on ACE inhibitor or ARBs. Generally, diabetic patients require multiple drugs to control the blood pressure. Aspirin therapy is very essential and is very ethical to give aspirin to all patients with diabetes with hypertension. The patient for the primary prevention essential, unless contraindicated, every patient of diabetes with hypertension, with cardiovascular risk, it has to be on aspirin therapy, number one. Number 2 point is statin therapy is also very essential to control the blood, to control the LDL levels. All the diabetic patients should be on these statins for lifelong treatment. Because in spite of lipids level, actually, if lipid levels are high, definitely it is indicated. But even though lipids levels are normal, we have to give therapy, because in diabetic patients, the quality of lipids is very bad. It is a high dense LDL, which is very highly atherogenic and leads to cardiovascular illnesses. So statin has to be there in the therapy for lifetime. So these are the points I would like to tell you. So what is the need of the control of the blood pressure? Because we know that both the conditions, they are having high risk of premature micro and vascular complication. They increase the mortality and morbidity in the future life. These are the background mechanism of development of complications due to diabetes and hypertension. In the background of insulin resistance, dyslipidemia, genes and obesity leads to diabetes, hypertension, atherosclerosis, endothelial dysfunction, vascular inflammation, vascular fibrosis, arterial remodeling. This causes micro and vascular complication. Now, what is the impact of this double condition in the day-to-day clinical practice? If the patients are having hypertension and diabetes, both, all-cause mortality is getting doubled here. All CV events getting doubled here, risk of MI getting double, stroke also getting double. So it is very essential. This is the data from the Framingham cohort. And the end organ damage is also seen high in the population with the diabetics, actually. So prevalence of LVH is 72% in the diabetic hypertensive patients, as compared to 32% of the patients in the non-diabetics, actually. Cerebrovascular accidents are very common. Hypertension, mainly systolic hypertension, is strongly and directly related to stroke in all age groups. Presence of diabetes more than the double the risk of developing strokes with the hypertension. Lowering blood pressure in the patients with hypertension and diabetes reduce the risk of stroke by 44% of the patients. So what is the landmark study of the diabetes, like UKPDS study? UKPDS study shows that the 10 millimeter of mercury reduction in the systolic blood pressure reduces the 12% reduction in the all-cause mortality or complication related to diabetes, 15% reduction in the deaths related to diabetes, 11% reduction in the myocardial infarction, 13% reduction in the microvascular complication. Now coming to the guidelines. There is a flood of guidelines given for the treatment of hypertension in diabetes, like IDA guidelines, then guidelines from the European Society of Hypertension, guidelines from the American College of Clinical Endocrinology, the guidelines from the DFROM textbooks, and the RSSDI guidelines, like the regional guidelines, like the study group of diabetic study group of India. So these are the practical guidelines which I am going to talk. So these are the sites where we have to target so that we can control the blood pressure in the, like, diuretic, which reduces the volume expansion, aldosterone mechanism, aldosterone excess, vasoconstriction and peripheral resistance will be controlled by the calcium channel blockers. Sympathetic overactivation will be controlled by the beta blockers, and RAS inhibitor will help to reduce the RAS activation. So these are the antihypertensive drugs. Since morning we are learning all this medication. Now, what is the drug of choice of as antihypertensive in diabetic population? So definitely AC inhibitors and ARBs on the cards. In type 1 diabetes with micro and macroalbuminuria, AC inhibitors are preferred. In type 2 diabetes with hypertension with no albuminuria, either AC inhibitor or ARB, both are preferred actually. In type 2 diabetes with microalbuminuria, both are preferred. But in type 2 diabetes with microproteinuria, ARB shows to reduce the progression towards the CKD actually. So what are the guidelines to recommend it? These are the European study of hypertension guidelines. They also, the more or all the guidelines, they are more or less same. The target blood pressure is less than 130/80 in majority of the guidelines actually. And there is only differences in the switching of the antihypertensives. Like for some guidelines says AC inhibitors and ARBs on the top in the list. Then some says either you go for some says go with the calcium channel blocker, some says go with the diuretic, some says we can add with the a combination of triple drug if required, and then you can use the beta blocker. Some points regarding the beta blockers I would like to highlight over here. Many patients who are coming to our OPD day-to-day OPD, they are already on the beta blockers, and beta blockers are supposed to be used in specific set of the patients with the diabetes, particularly those who are having cardiovascular risk, we are having a thyrotoxicosis, those who are having the risk of arrhythmias actually, and that too cardioselective beta blockers in the form of bisoprolol or metoprolol. And if patients are having heart failure, then carvedilol is recommended. The problem with the beta blockers, high doses of beta blocker in diabetic patient gives rise to hyperglycemia, number one. Number two, they gives rise to dyslipidemia. Number two, they gives rise to erectile dysfunction. Number four, they gives rise to hypoglycemic unawareness. So it is very dangerous if patients are having hypoglycemia, but they don't feel the symptoms of hypoglycemia due to the masking effect of the beta blocker. So this is very dangerous condition. So try to avoid beta blockers, and if they are indicated, definitely we have to use them, but the use has to be judicial. So these are the ESC guidelines. These are the ADA guidelines, like we have to initiate the one agent like AC inhibitor or ARBs, go with the if patients are not maintaining target more than 130/80, add the calcium channel blocker. If not maintained, then add the diuretic. More or less guidelines are same actually. So these are the American Association of Clinical Endocrinology guidelines. I am going to talk regarding the guidelines of the RSSDI, Research Society of Study of Diabetes in India. They are very practical and they are good, very good guidelines to treat our Indian patients actually. So in the background of proper lifestyle modification, we have to start the one single agent with either AC inhibitor, if not tolerated ARB. Monitor renal function and potassium. If BP is not controlled, if still BP is more than 130/80, add the diuretic. Number two. Number three, if still blood pressure is not controlled, go with the non-dihydropyridine calcium channel blockers like cilnidipine or amlodipine. And still blood pressure is not controlled, then go with the beta blockers. Yes. Yes. Yeah. So these are the guidelines. So recommended ARBs like telmisartan, azilsartan, cilnidipine, amlodipine, or combination can be used. If the blood pressure is more than 150/90, we can straightway start with the two-drug combination, monitor blood pressure by every monthly. If not controlled, then add the diuretic to the therapy. Try to treat the patient up to target, do the screening on the regular interval of time, monitor potassium and the renal function at regular interval of time, and do check the end organ damage every yearly actually. If still blood pressure is not controlled, we can add the cardioselective beta blockers to the therapy. If still blood pressure is not controlled in some set of patients, we can definitely go with the alpha blockers as well. So these are the hypertensive guidelines comparison. As I already spoke about, more or less the starting of the blood pressure range more than 140/90 is definitely, this is the point where we have to initiate the treatment along with the lifestyle modification, and target blood pressure is 130/80 in majority of the guidelines. Now, just 2 slides for the resistance hypertension. If patients are on 3 drugs, and if the blood pressure is more than 130/80 and among that three drugs is one drug is diuretic. This is the time we have to label patient as a resistant hypertension. Patient on three drugs, uncontrolled, one drug is diuretic, still blood pressure is more than 130/80, we have to label this patient as a diuretic. Remember that if you are using thiazide, we have to give the time to the thiazide diuretic to give the good antihypertensive effect, and that will come at the time of 2 to 3 weeks actually. So diuretic will take little longer time to get the desirable antihypertensive effect actually. So what are the causes of resistant hypertension? Many times due to stress, fear, hypertension, hyperventilation. These are the neuronal activity. There are some states of hypervolemia in that particular set of the patient due to excessive use of sodium intake, heart failure, kidney diseases, ineffective diuretic uses, and drug that causes fluid retention. There are some associated conditions in some patients like obesity, older age group patient, endocrine disorders, alcohol abuse, and sleep apnea, and some drug. This is very important. So detailed history is very important in resistant hypertension. NSAIDs are used right, left, in center in our day-to-day clinical practice. Steroids are also commonly used like erythropoietin, lorcaserin, cyclosporin. OC pills are commonly used. Antidepressants are commonly used. So this drug history is very important in case of the resistant hypertension. So there is one terminology called as the pseudo hypertension, in which we are not titrated dose properly. There is poor adherence to the therapy, and white coat hypertension. These are the category which comes under the pseudo-resistant hypertension. If you cover that, then the patient will be controlled. And if these conditions are not there, in that case, we have to label the patient as a resistant hypertension and modify treatment up to the mark actually. So the incidence of resistant hypertension in India varies from the 5 to 10%, and somewhere in India, like it is near about 20% of the patient. We have to take the detailed history of that particular patient, do some proper investigation in that particular set of the patient, try to increase the dose of the medication. Now newer medications like mineralocorticoid receptor antagonist, eplerenone, and the direct renin inhibitors. All these can be used to treat the patient, but 90% of the patients will be controlled on triple drug with proper dose titration in the background of proper lifestyle modification and reduction in the addictions actually. So this is all about the hypertension in the diabetic population. So it is very just the take home message for the today's talk. 50% patients are undiagnosed, so do screen the patient for diabetes and blood pressure at your regular visits, even though they are not having any risk of metabolic illnesses. Number one. Number 2 point, the proper lifestyle modification with proper diet, proper exercise implementation program, good adequacy of the sleep, and lack of the reduce the addictions is definitely going to help the metabolic condition in our country. There are important devices like ambulatory blood pressure monitoring, which are helpful for our patients to which are recommended to analyze the risk actually. And it is very essential to treat the patient up to target level of less than 130/80 millimeter of mercury with proper antihypertensive uses to reduce the cardiovascular risk and end organ damage in our diabetic population. So learn regarding the updated guidelines, do the proper counseling of our patients, sit across the table and give good advice to the patients, use the antihypertensives judiciously, and try to help our patients to treat up to the target level of blood pressure less than 130/80. Thank you very much for the patient hearing.
Thank you very much, sir. The presentation was full of expertise on the subject you are dealing with. Sir, I would like to request you to kindly stop sharing your screen.
Thank you, Zubair, and thank you, Shafi sir, for the opportunity.
Sir, Shafi sir is here, and as you are a distant speaker, we would like to present a memento to you, and this memento will reach you soon.
Thank you, sir. Thank you very much.
Thank you.
Thank you.
So our next speaker, very young and dynamic, Dr. Rizwan Deshmukh. He is a MBBS graduate from MGM Medical College, Aurangabad. Did his DNB in internal medicine from SIMS, Hyderabad. Did his DNB in cardiology from Satya Sai Institute of Higher Medical Sciences, Bangalore. His work experience goes in a very huge way. He was consultant interventional cardiologist at Satya Sai Hospital, Bangalore. He was consultant interventional cardiologist at Seth Nandlal Dhut Hospital in Aurangabad. And currently, he is the apex, the atlas of the cardiology department of Apple Hospital Multi-Speciality.
Recording in progress.
ठीक है. Sometimes non-dihydropiridine calcium channel blockers or chlorine can also be used. Beta blockers useful नहीं है, and nitrates are useful for the relief of ischemic pains. Now the first drug which we use in hypertension with chronic stable angina is a beta blocker. The first line therapeutic agent. In this also, it is preferable to use cardioselective beta blockers which do not have an intrinsic sympathetomimetic activity. Now, this word intrinsic sympathetomimetic activity is a very difficult word to understand. I'll just speak just 2 or 4 lines about this. देखिए, बेटा ब्लॉकर्स 2 किस्म के रहते हैं. एक रहता है नॉन सेलेक्टिव कार्डियो, एक रहता है कार्डियो सेलेक्टिव, एक दूसरा रहता है नॉन कार्डियक सेलेक्टिव. कार्डियो सेलेक्टिव में भी selective beta blockers, there are 2 types. One is with intrinsic sympathomimetic activity, and the others are without intrinsic sympathomimetic activities. Those without intrinsic sympathomimetic activities, मतलब atenolol, metoprolol, bisoprolol, ये are drugs are which do not have intrinsic sympathomimetic activity. Other drugs like, for example, carvedilol, pindolol, ismalol, libitalol, these have intrinsic sympathomimetic activities. So you have to use a drug which is cardioselective. Second, it does not have an intrinsic sympathomimetic activity. For example, etanol, beta blocker, like bisoprolol and metoprolol. ये हुई पहली बात. So beta blockers, they also they decrease the ischemia, they also decrease the angina, they decrease your heart rate. And this causes decrease in the oxygen consumption. And when they decrease their heart rate, this also allows for the coronary blood flow to increase. And to a very little extent, they also inhibit the renin, release of renin from the juxtaglomerular apparatus. But unfortunately, the thing is that they are also contraindicated if there's hypertension or the patient has SO dysfunction in a very severe decompensated heart failure. And especially those patients with a very severe bronchospastic disease. In fact, the thing is that nowadays, even in patients with COPD or those with severe bronchospasm also, we do use a little bit of beta blockers. For example, a very cardioselective like bisoprolol, which don't have intrinsic sympathomimetic activity. As Ehsan sir had just said, कि आपको diabetic patients में, especially those जिनका क्या कहते हैं, insulin they are on very high doses of insulin, avoid beta blocker because it usually masks the symptom of hypoglycemia. But the thing is that frankly speaking, I have not seen any patient who I've given a beta blocker to and the symptoms of hypoglycemia have been masked. So, but still, F1 coronary artery disease and a diabetic patient, I will say that start with a very low dose, because these are the first line of medication. You would want to start a beta blocker. After beta blocker comes calcium channel blockers. In chronic stable heart disease, ischemic heart disease, stable angina, which we say. Here we have two types of calcium channel blockers. One are dihydropyridines, and the second are non-dihydropyridines. Dihydropyridines matlab aapke nicardipine and non-dihydropyridine agents are also not preferred in patients with stable heart failure initially, and especially the short-acting dihydropyridine agents are not preferred in acute MI, pulmonary edema, and left ventricular dysfunction. This last line I would like to talk a bit more about it. Whenever we have a patient, suppose his LV function is around 30%, 25 or 30%. And a lot of times he has bradycardia, severe bradycardia. You can say a heart rate around 45, 50, like that. And or in patient pulmonary edema. At that time, there's very much doubt whether we can start calcium channel blockers or not. But my experience or what we've practiced, we found that starting with very low dose of long-acting calcium channel blockers like amlodipine can help in such patients also. Now, management of hypertension and coronary artery disease, that is chronic stable angina with ACE inhibitors and ARBs, they have been shown in a lot of trials to reduce the left ventricular hypertrophy, the remodeling, and the blood pressure, and a lot of studies. दो particular studies हैं, एक तो यूरोपीय study है and दूसरा होप trial है. They have definitely showed that there is 20% reduction in the risk of sudden cardiac death. 20% reduction is very good amount. मतलब अगर आपने 80%, 100% patients में दिया है, तो 20% patients में there is a definite improvement, that there is reduction in mortality. And जो patients में AC inhibitors are advised not to be given, जैसे जिनको renal artery stenosis है, या जिनको angioedema हो चुका है, या जिनको allergic reaction है AC inhibitor से, तो ARBs can be used in their place. Chronic stable angina, use of thiazides and nitrites. Thiazide diuretics are highly effective in lowering the blood pressure, and they even prevent cerebrovascular events. This has been found in a number of trials like the MRC and the SHEP trial. Nitrates, long-acting nitrates are better to be used compared to short-acting ones. They help in controlling or alleviating chest pain, and they are also used in adjunct with beta blockers and calcium channel blockers also. And hypertension does not impact the use of long-acting nitrates for the prevention of angina, or of sublingual nitrate for the relief of anginal attacks. Now, the limitation of thiazide diuretics is that thiazide diuretics should be used very cautiously in patients with chronic kidney disease, ultimately those who have a low GFR. They are also not recommended in diabetic patients on oral hypoglycemics, as they increase the resistance of insulin. And in such patients, if you do want to start with the diuretics, and if you want a fast action, use the metalazone, or in the previous time, indapamide reduced. Nowadays, the use of indapamide has come down drastically. And if you want a very, very potent and a very a loop diuretic with a very good bioavailability, it is torsemide. So the cautions which we've seen in patients with symptomatic coronary artery disease and hypertension, the combination of beta blocker and a non-dihydropyridine calcium channel blockers should be used with cautions. Simples, एक beta blocker को एक diltiazem के साथ देना नहीं है, या एक metoprolol को verapamil के साथ देना नहीं है, because significant bradyarrhythmias happen and it precipitates heart failure. And when you use such a combination, it's very difficult to get the heart rate back to normal. And those patients with coronary artery disease, the BP should be lowered very slowly, and caution should be advised when inducing fall in the BP. Here, I would like to tell something very important. See, the management of blood pressure in a neurology patient, the management of blood pressure in a nephrology patient, and the management of blood pressure in a cardiology patient, thoda sa different rehta hai. See, the most important thing is that those patients in cardiology patients who have low blood pressure, around 50% of them also have a LV dysfunction. Okay, as it is, their blood pressure is a bit on the lower side. For any organ, whenever you're starting the treatment for blood pressure, always look at the mean pressure also, because a lot of times what happens is that you try to bring the blood pressure to a lower level and the auto regulation mechanism fails, and that itself leads to complications. It's not like statin therapy, the lower the better. The hypertension management has a upper limit as well as a lower limit. Try not to go down the lower limit, because if you try to go as low as possible, then you're going to have a lot of problems. Then organ damage is definitely going to start in. So try to maintain, even if you're going at a lower range, try to maintain a mean pressure of at least 7 to 100. That's the most important thing. So if you're having a systolic blood pressure of 100, see that your diastolic blood pressure doesn't go more less than 50, 40, 55 or 60. Try to keep a mean pressure of around 7 to 100. Now, my most important topic, or my favorite topic, hypertension and acute coronary syndromes. ठीक है, acute coronary syndromes में आपको unstable angina मिलेगा, आपको NSTEMI मिलेगा, and आपको ST elevation myocardial infarction मिलेगा, right? Here, arterial hypertension is one of the major leading causes of atherogenesis. Number one. Number two, hypertension से वो जो vulnerable plaque है, the plaque which ruptures, it is one of the most important cause for causing instability of the plaque. And we have seen that 50% patient जो NSTEMIC से present होते हैं, उनमें hypertension रहता है, and जो patient में MI रहता है और उनमें hypertension की history भी है, उनके mortality भी ज़्यादा रहती है. So it's a double-edged sword. And elderly women, elderly individuals, Asian and Africans, and those with more comorbidities are more likely to be affected with mortality in a patient who has MI. Coming to management of hypertensive patient with unstable angina and STEMI, initial management, this is it's a very basic thing. Get a good bed rest, continue ECG monitoring, start oxygen therapy if you're suspecting the patient is in failure, start morphine if the patient agar pain bhi hai, and sedation if necessary agar patient is very restless. Pharmacological therapies includes nitroglycerin, beta blockers, calcium channel blockers, AC inhibitors, and aspirins, right? Nitroglycerin is the cornerstone of treatment. अब मैं nitroglycerin का ऐसा होता है कि patient comes to you with MI, having hypertension, start NTG. NTG will cause a lot of, will help in a lot of things. सबसे पहले it increases the coronary blood flow. Second, it stabilizes the myocardium also. Third, it stabilizes your plaque also. When you're starting NTG, I'm going to make very subtle points. आप जब NTG start कर रहे हो, try to maintain the blood pressure less than 130, 140 systolic, and if your diastolic blood pressure goes in less than 70, try to stop the this thing. Second thing, NTG से coronary flow improve होता है. Even post plasty, हम लोग जब stent डाल देते हैं, when we put a stent, the flow from the coronary artery also increases with the help of NTG. Coming to beta blockers, if possible, the first minute the patient comes to the hospital and he does not have any contraindication for starting a beta blocker, start a beta blocker. It always in combination with nitrate has a beneficial effect. हम लोगों we have to use a cardioselective beta blocker. मैंने जैसे आपको बताया है, cardioselective non-intrinsic synthethomimetic beta blocker जैसे metoprolol or bisoprolol should be used. शॉर्ट एक्टिंग बीटा ब्लॉकर्स यूजुअली इंडिया में मिलते नहीं हैं. जो शॉर्ट एक्टिंग बीटा ब्लॉकर्स जो पहले मिलते थे आईवी फॉर्म्स, वो भी उनका भी मार्केट में व्हाट डू यू से द सेल्स इज वेरी लेस. सो द बेस्ट थिंग इज ट्राई टू यूज अ बीटा ब्लॉकर as early as possible. The things which stop us from using a beta blocker is if the patient is in severe heart failure, वो आपके पास आता है एक pulmonary edema के स्टेट में, उसका saturation 30, 40, 70, 80 है, he is in failure, hypertension में है, CHB में है, and patient is a chronic smoker, पूरा एक barrel shaped chest है. So in these conditions, be very careful. I mean, hold on to your beta blocker. लेकिन apart from these conditions, use a beta blocker as much as possible. Second, calcium channel blockers. अब देखिए calcium channel blockers MI में usually a lot of physicians and a lot of cardiologists hesitate to start it. There are two types of calcium blockers. एक तो मैं बताया आपको amlodipine की फैमिली है, दूसरे verapamil diltiazem है. Verapamil diltiazem बहुत rarely use होता है, especially in those conditions जहाँ पे आप beta blockers दे नहीं पाते हैं. लेकिन verapamil और diltiazem should be very cautiously used. In fact, should not be used, I would say, if you have LV dysfunction. Anything less than 40% of LV function should avoid using a verapamil or diltiazem. But if the patient has MI and the blood pressure is very highly raised and you're not able to give a beta blocker, you have started with an AC inhibitor, still the pressures are not coming down. In those conditions, you can start using a long-acting dihydropyridine calcium channel blockers. Like for example, at our place, we use amlodipine. Second comes to AC inhibitors and ARBs. AC inhibitors and ARBs, I personally prefer using an AC inhibitors because most of the studies which have been done are with perindopril and ramipril. So I prefer using a ramipril rather than more expensive drugs. So ramipril I usually use when hypertension persists and the patient diabetic भी है, साथ में साथ LV dysfunction भी है आपने. Aspirin, all of you know, aspirin, the sooner the possible. Agar you can crush the aspirin, you can give it, sabit, or you can crush it and give it. Crushing it increases the absorption, helps to achieve the blood levels as soon as possible, and gives a better result. The recommendation, as I've just mentioned, beta blocker को जितना जल्दी use कर सकते हैं, start using it. Use a beta blocker, cardioselective beta blockers or IV if available. Use an IV as soon as possible. Just see for the side effects or just see for the contraindications. Second, those patients who are not able to use a beta blocker. So, hello? Yeah. So those patients who are not able to use a beta blocker, try a calcium channel blocker. And every patient should be at least started with a dose of AC, ARBs inhibitors. One small point I would like to mention over here, the use of ARNI. ARNI, the salcubitril/valsartan combination. Till now, unfortunately, there are no proper studies which show that using ARNIs in acute setting of MI. So as soon as a week passes of a patient having MI, you can definitely start using an ARNI in those patients. The trials which have shown the beneficial effect of beta blockers is TIMI study, then ISIS study. These are the style. AC inhibitors also should be started as soon as possible. Preferably, they say within 24 hours. And if they're intolerant to AC inhibitors, go with ARBs. Aldosterone antagonists are always added in a patients with MI or with basically ACS, acute coronary syndromes, except if they have a potassium level more than 2.5 or the creatinine is definitely more than 2.5. I mean, potassium level more than 5 and a creatinine level more than 2.5. And otherwise, a diuretic with an aldosterone antagonist is always a good drug of choice. Calcium channel blockers like non-dihydropyridine calcium channel blockers may be used for the treatment of patients with supraventricular tachycardia if they get, and long-acting non-dihydropyridine calcium channel blockers are used for the control of blood pressure. Yes. I'd like to stop my talk over here. I've tried to keep it as basic as possible. And if anyone has any doubt whatsoever, they can ask me over here or they can directly contact me also. I'd be happy to revert back. Thank you very much.
Thank you very much, sir, for your very much practical inputs into the subject. Definitely, the way you have said this should be used and this should be not is very much practically what we do understand. Thank you, sir.
Right. Thank you very much. Thank you.
You can stop sharing your screen. Yeah. Okay. Okay, sir. So you can. Yeah. Okay. So it is the time for our chief guest, Dr. Abdul Majid sir, to do his presentation. Sir needs no introduction, but just formally, I would like to tell you all that he did his MBBS and MD in medicine from GMCH Aurangabad. Sir has done his DM in neurology from KEM Hospital, Mumbai. Sir is a practicing and Alhamdulillah highly successful consultant neurologist since 24 years in the city and around the city in the region, I would say. He is
I've tried to keep it as basic as possible. And if anyone has any doubt whatsoever, they can ask me over here or they can directly contact me also. I'd be happy to revert back. Thank you very much.
Thank you very much, sir, for your very much practical inputs into the subject. definitely the way you have said this should be used and this should be not is very much practically what we do understand. Thank you, sir.
Right. Thank you very much. Thank you.
You can stop sharing your screen. Yeah. Okay. Okay, sir. So you can. Yeah. Okay. So it is the time for our chief guest, Dr. Abdul Majid sir, to do his presentation. Sir needs no introduction, but just formally, I would like to tell you all that he did his MBBS and MD in medicine from GMCH Aurangabad. Sir has done his DM in New.
Yeah. Good afternoon, everyone. I know it's late. I hope I'm audible to everyone.
Yes.
Yeah. So we are running late because of some technical issues. No worries about that. But I'm worried people are getting hypoglycemic, and so I wonder, should I make my topic little more practical? And I've prepared slides which are little less crowded and has more practical inputs. Yeah, here is an overview. Hypertension, we have been hearing this since morning, and we'll discuss how hypertension causes brain damage. There are some misconceptions about hypertension, and I'll be giving some practical tips about managing hypertension out of my 24 years of clinical practice. And we'll talk a little about pathophysiology of brain damage caused by hypertension, and then what is stroke and its types, manifestations of effects of hypertension on brain, some illustrative cases, and then treatment goals and take-home messages. That will be overview. So coming to misconceptions, people ask so many questions in day-to-day practice. Mildly elevated BP is okay, doesn't need treatment sometimes, but in these cases, I think where the people are not convinced, ambulatory BP monitoring is important in few select cases. And that once started, lifelong treatment is needed. So that is a very common misconception among people. एक बार शुरू हो गई तो फिर जिंदगी भर गोली लेना पड़ा. I take the medicine on alternate days or once in 3 days, and I'm okay. I don't have any symptoms. So I think understanding. Then some people will say, I sense the elevated BP and take the BP medicine SOS. मुझे समझ जाता है कि मेरा blood pressure बढ़ रहा है, तब मैं medicine लेता हूँ. Few people are really worried about side effects of allopathic medicines, as we all know. And some people will say, my GP said your BP is normal now, so you can stop the medicine. The person is taking medicine, that's why his blood pressure is not normal now, but he wants to stop the medicine. And few people will say, I don't have any symptoms, so why should I take the medicine? Because as we know, hypertension is a silent killer. So sometimes there may be absolutely no symptoms and signs whatsoever, except for raised blood pressure. What are the practical tips? Learn to record BP properly. I think that should be learned. Though we are becoming senior day by day, we should learn to take it properly. We should teach our junior doctors and residents to record the BP properly. That has been talked about since morning. Don't rely on blood pressure recorded by paramedics and junior doctors. Listening since morning, so two times, 3 times, because it is important, because all stroke patients have reactive hypertension. Especially in hemorrhagic stroke, that is very common. So just don't take any decision based on a single reading. Check the BP apparatus regularly. that it can be faulty, and so giving rise to faulty readings, taking pushing us to take wrong decisions. Use correct size cuff, especially for obese patients. So I've shown this obese cuff is there. People who have obesity, and then preferably use mercury BP apparatus. There can be controversy into that, but I think it's easy to use and gives proper readings. As we know, hypertension causes, what happens in hypertension is the force of blood pushing against the blood vessel wall is high. So there is a more pressure. What is systolic pressure? Is the pressure in artery when the heart beats, and diastolic when the pressure in the heart arteries when the heart rests between the beats. Hypertension damage arteries and organs over time. So there is a wear and tear effect on the arteries, on the pipes. We can imagine it as a water pipes. So over the years, these pipes, they have wear and tear effect. If the pressure is high, they tend to get blocked or get ruptured. So there can be endothelial damage, which causes narrowing of the artery and ultimately resulting into ischemic stroke. High blood pressure strains blood vessels. Over time, they no longer hold up to the pressure and rupture and produces hemorrhagic stroke or IC bleed, which we commonly refer to as. What are the mechanisms? High intraluminal pressure causes extensive alteration in endothelium and smooth muscle function. There is an endothelial stress which increases blood-brain barrier permeability, causing brain edema. There can be endothelial damage and altered blood cell endothelium interaction, causing production of local thrombus, which causes blockage of the arteries. There can be fibrinoid necrosis, which produce small lacunar infarcts, and ultimately this fibrinoid necrosis can produce gangliocapsular bleeds. Hypertension accelerates arteriosclerotic process, causing stenosis of large extracranial and intracranial arteries, and these atherosclerotic plaques can embolize, producing atheroembolism. Stroke is the most common cause of mortality worldwide. It is the third most common cause of disability. And hypertension is the most prevalent risk factors. It is seen in around 64 have stroke. What is stroke? It is defined as rapidly developing clinical signs of focal or global disturbance of cerebral function, with symptoms lasting 24 hours or longer, or leading to death. There is a controversy regarding this 24 hours. We'll see this matter in few minutes. There is no apparent cause other than vascular origin. So there is a problem with vasculature. It has ruptured, causing neurological signs, that is stroke. We know what are the types of stroke. Grossly, there are two types of stroke, ischemic and hemorrhagic. Ischemic is more common, around 83 to 84%. Hemorrhagic is around 13 to 16%. And out of these ischemic stroke, 51% has thrombosis, embolism. Embolism is usually from the heart, or it can be atheroembolism, and there can be large or small vessel disease. Hemorrhage, there is intracerebral hemorrhage or subarachnoid hemorrhage. There are various manifestations of brain damage caused by hypertension. It is not just stroke. There are a few more things which are produced by hypertension. We know about ischemic stroke, that can be TIA or infarct. Hemorrhagic stroke, there can be IC bleed, parenchymal bleed, or subarachnoid hemorrhage. There can be cerebral small vessel disease, which ultimately produce dementia kind of picture. There can be PRES, which is called as posterior reversible encephalopathy syndrome, or RVCS, reversible vasoconstriction syndrome. Hypertensive encephalopathy is the manifestation, and ultimately small vessel disease can produce vascular dementia and Parkinsonism. So we know this is ischemic stroke. There is a blockage of the artery, and in the hemorrhagic stroke, there is a rupture of the artery. It's very simple. To come to some conclusion, to make complete diagnosis, it is important that we have all the investigations at our hand. We have to image the parenchyma, we have to image the vessel, and we have to investigate about the end organ damage. that will give the complete diagnosis to us. So in this era also, some people ask, is CT scan and MRI necessary? I ask them, in a case of chest pain or heart attack, is ECG is necessary thing or not? They'll say, yes, it is necessary. So it's as simple as that. CT scan is a must, or MRI, whatever it is, imaging is must, preferably MRI. So we have to image parenchyma, we have to image the vessels. This is circle of Willis, extracranial and intracranial blood vessels, and we have to see the end organ damage in the form of cardiac involvement, renal involvement, liver involvement, ocular, and so on and so forth. So what happens over the years, there is a hypertension causes acceleration of arteriosclerotic process, which produce plaque. And these plaques are common at the sites where the artery is getting branched, because the traction or shear effect is more. So they get plaques at the branching. So there can be angionecrosis producing small lacunar infarcts and ultimately hemorrhage, or there can be atherosclerosis causing large artery involvement, or there can be cardiac embolism. To begin with, TIA is almost previous definition of TIA was something which is lasting for less than 24 hours, but nowadays it has changed and still it is evolving. TIA nowadays are referred to all neurological symptoms caused by vascular problems in the brain, and which last for less than 30 minutes actually. But let us see less than 1 hour, because more than most last less than 10 minutes. And if the symptoms are persistent after 10 minutes and after 1 hour, they usually have small infarcts, and it is not TI. So what happens in ischemic stroke? There is a blockage and blood vessel is occluded, causing ischemia and infarction. What happens in TI is, at the site of branching, there is a atherosclerotic plaque producing reduced blood flow. So it is not totally occluded, producing TIAs. And if it gets ruptured, that produces hemorrhagic stroke. So we saw there is a atherosclerotic plaque which is getting accumulated at the bifurcation, and usually it produces TIA. Again, this is the healthy artery, and this is the plaque which is at the branching site and producing less blood flow and causing transient ischemic attack. This is ischemic stroke. You can see the infarct is there in the left MCA territory area. So this is how MR is important, because it picks up the infarcted area very early. Initially, on the day one, first 24 to 48 hours, CT scan may not show anything, and we are misguided by a normal CT scan. So in this case, we see this is MR angiography, and this is ICA. This is a vertebral, both vertebral joining to produce basilar artery, and PCAs we can see, and these are ICAs, and these are MCAs. On the right side, MCA is seen clearly, and there is a cutoff on the left side of the MCA, producing left MCA infarct. So this is again ischemic stroke. You can see the hypodensity. So gradually, roughly, we can say that the infarct appears hypodense on CT scan, and hyperintense on MRI, T2-weighted, and diffusion. So the important thing to know is on day one, the CT scan may be negative. On day two, it will show infarct. But as we progress, like for example, day 3, day 4, day 5, especially day 4 and 5 are dangerous, where the edema and the infarct size increases, and if you don't repeat the CT scan or MRI, you might land into problem, because the patient might cone due to raised ICT infarct and might certainly deteriorate, and we might lose the patient. So it is very important to clinically observe these patients and repeatedly do the imaging. Again, we can see the left MCA infarct here, and there's a large infarct, right MCA infarct. This is a evolved infarct, maybe day 3, day 4, and they carry bad prognosis. And there's a bleed. There are 3 types of bleed. This can be subarachnoid bleed. They can be basal ganglia. The most common cause is hypertension, as we have seen. This is the most common site where hypertensive bleeds occur. If there is a subarachnoid bleed, usually the cause is aneurysm. And if the lobar bleed is there, the other, apart from hypertension, hypertension also can produce lobar bleed, but we have to look for amyloidosis, venous infarct tremor, or AV malformations. So here it is very clear, this is a subdural, this is a below subdura, this is a epidural. Usually trauma causes subdural and epidural, and this is intracerebral hemorrhage, which is usually caused by hypertension due to fibrinoid necrosis of small thalamocyte arteries, and subarachnoid hemorrhage, which is usually caused by aneurysms. The typical sites, this is a lobar bleed, this is a putaminal hemorrhage caused by hypertension, thalamic hemorrhage, there can be pontine hemorrhage, and cerebellar hemorrhage. These are the various sites where bleeding can occur due to hypertension. As we have seen, the blood can go into the ventricles, causing ventricular extension, and in a way it decreases the intracranial pressure, but usually the complications are more. They can be different in sizes, like this is cerebellar bleed causing compression of the brain stem, and these patients might need decompression or sometimes external ventricular drain because of hydrocephalus caused by obstruction. This is a gangliocapsular bleed left-sided, and this is a large bleed, has very poor prognosis. Whatever you do, usually the patients succumb. This all happens because of hypertension. So again, this is a small bleed, there's a large, there's a thalamic bleed, there's a cerebellar bleed, or bleeds. So usually bleeding doesn't occur due to rupture of large vessels. Usually it occurs because of the rupture of thalamostriatic arteries. These are small arteries which are ruptured because of raised blood pressure. There is a fibrinoid necrosis, and if the patients with lacunar infarct, they have high chances of getting bleed if the blood pressure is not controlled. You can see this is subarachnoid hemorrhage, where you can see the hemorrhage in the arachnoid spaces. This is the typical spider-like appearance of the SAH. SAH is not commonly caused by hypertension, very rarely. We have to document, we have to do DSA and to rule out aneurysm, and if the blood pressure is high, because there can, as I said, there can be reactive hypertension, and we might go thinking that hypertension has produced subarachnoid hemorrhage, but usually that is not the case. It is a reactive hypertension which causes raised BP readings. Subarachnoid hemorrhage is commonly caused by aneurysmal bleeds. Hypertensive encephalopathy, the patient will present with severe headaches, confusion, blurring of the vision, and as we saw in the mechanisms, the persistently high blood pressure will cause breakage of blood-brain barrier and causes edema. And this is a typical picture of hypertensive encephalopathy. Then there's something called as posterior reversible encephalopathy syndrome. As we can see, the areas affected are usually posterior, so the patients will present with visual disturbances and seizures. This is very common in patients with eclampsia, prenatal or postnatal. The people who have fluctuating blood pressure, people on immunosuppressant drugs, after blood transfusion, in malignancy, press can happen. And then can be atypical press also, as we've seen. It may not be posterior always, but it can be anterior. It can affect the basal ganglia also. They can be atypical press. There's a syndrome which is called as reversible vasoconstriction syndrome. This is also, the pathophysiology is almost similar to press. So there can be infarcts seen, especially in posterior region, but anywhere it can be seen. And you have to demonstrate that there is an involvement of the arteries. So the typical pattern which is seen on angio is beaded arteries which are seen on MRI, MR angio, CT angio, or DSA, and the patient will have severe headaches and hypertension. It is not a compulsory thing to have hypertension, but and this is a typical condition where the vasoconstriction is reversible. When you do DSA or angio after 10 days or so, the angio is normal. There can be Binswanger's disease. As I said, it can affect the small vessels of the brain, causing leukoariosis and white matter lesions, periventricular, and this produces typically dementia, gait abnormalities, and forgetfulness is the presentation. The presentation would be like vascular Parkinsonism. So hypertension can produce stroke. Hypertension can produce white matter lesions. It can produce cognitive impairment and dementia. Ultimately, that's the end result of long-standing hypertension, which is producing either recurrent strokes or white matter lesions, producing higher mental function affection. So ischemia or white matter disease, focal brain atrophy, amyloid accumulation. But these two changes, because of hypertension, will produce dementia. As we can see in this slide, this is a healthy brain, the brain with diffuse white matter lesions or small strokes. And as it progresses, as the blood pressure remains high, it produces atrophy of the brain due to extensive white matter involvement. There's a brain atrophy and brain is shrunken, producing dementia, which is called as vascular dementia. You can see there is extensive white matter involvement. There can be microbleeds also, producing atrophy and brain changes, leading to vascular dementia. You can see there's a mild few lesions, periventricular white matter lesions. There's a moderate multiple lesions and extensive lesions in severe vascular dementia. This is cerebral small vessel disease. As we know, it can affect the small vessels. Hypertension can affect the small vessels, producing white matter hyperintensities, lacunes, enlarged perivascular spaces. There can be cerebral microbleeds, multiple of them, hundreds of them in the brain, present small subcortical infarcts, brain atrophy, and cortical microinfarcts, all of them leading to ultimately vascular dementia. These are microbleeds seen on gradient imaging, multiple hundreds of them. These are effects of long-standing effects of hypertension, which is uncontrolled. So microbleeds can be there. So ultimately, these all changes, white matter changes and small vessel disease, they produce dementia. It can be isolated vascular dementia or it can be Alzheimer's dementia. But most common dementia which is seen in India is usually mixed dementia. They have some part of it is because of Alzheimer's type of dementia, and most of the part is because of vascular dementia due to prevalence of hypertension and diabetes in our community, in Indian subcontinent. So hypertension primary prevention of stroke is important. There was a study, SPRINT, systolic pressure intervention trial, which said that decrease the goal from 140/90 to 130/80 for primary prevention of stroke. Patient has never got a stroke, but we have to prevent the stroke. This is a primary prevention, but overall consensus is target blood pressure of 140/90. Hypertension is commonly seen in ICH, though it can be reactive hypertension. But if it is very high, systolic BP 150 to 220 with no contraindication to acute BP treatment, acute lowering of BP to 140 is safe. Systolic BP of more than 220 needs aggressive reduction with parenteral drugs. We'll see what are the drugs which are used commonly in our ICU. Hypertension is linked to greater hematoma expansion and poor prognosis. Why is it important? Because if you keep the blood pressure high, the hematoma can expand, producing very poor prognosis. If the BP is rapidly controlled, there are more renal adverse events, which are obviously seen. In hypertension in acute ischemic stroke, nowadays, there's no only veranda treatment for stroke patients, as we saw in our Ghati days. Stroke means admit in veranda and do nothing. You just give aspirin, RT feeding, and catheterization and physiotherapy. But now the things have changed over last few decades. We can thrombolize these patients. If the patient is in window period, reduce the systolic pressure to less than 185 and diastolic to 110 before thrombolysis. Because lowering the BP helps in decreasing hemorrhagic transformation after lysis. Because around 6% of these patients who receive thrombolysis will have hemorrhage, and sometimes these can be fatal hemorrhage. Sometimes they might need craniotomy also. So if you control the blood pressure before lysing, the chances of hemorrhagic transformation are drastically decreased. If no lysis but intraarterial therapy is planned, like mechanical thrombectomy, maintain the blood pressure less than 185 above 110 before the procedure. A rapid reduction in BP can be detrimental, but nowadays studies are there in which they have documented that rapid reduction is not that harmful as it was thought. BP should be cautiously lowered by about 15% during the first 24 hours. Patients with acute ischemic stroke and BP of less than 180/105 in the first 72 hours after stroke don't seem to benefit from antihypertensive drugs. So we have to wait and watch. Don't jump onto conclusion. Don't start treatment because it can be just reactive hypertension, especially in hypertensive bleeds. So wait for 72 hours if it is not harming anything and if you are not going for any interventional treatment. For stable patients who remain more than 140/90, more than 3 days after acute ischemic stroke, if it is persistent after 3 days, sometimes people say up to 7 days, then initiation or reintroduction of antihypertensive should be considered. Restarting blood pressure control is reasonable after the first 24 hours for a hypertensive patient who is stable. If the patient is known hypertensive, restart after 24 hours. If he is a new patient, not a known case of hypertension, then you can wait for 3 days. If it is not emergency, of course, if the patient is stable. If it is emergency, you have to treat. Hypertension and secondary prophylaxis of stroke. Patient with underlying hypertension less than 140/90. Patient with lacunar infarct, as I've already mentioned, the target is less because here the chances of hypertensive bleed are very high. Patient with hemodynamically significant large artery disease, BP should be reduced cautiously. And the patients who develop recurrent neurosymptoms, which are referable to stenotic artery, when the BP is lowered, they get symptoms. So in these cases, we have to maintain the BP above threshold. We have been hearing about these drugs, very simple A, B, C, D. A for ACE inhibitors, ARBs, alpha blockers, B for beta blockers, C for calcium channel blockers, and D for diuretics. Pril, everything pril is ACE inhibitors, sartans is ARBs, ocins is alpha blockers, LOL is beta blocker, dipine is calcium channel blocker, and IDE is diuretics. And we have seen the speakers speaking about the judicious use of these various molecules in different conditions. As we know, if my patients are usually not stroke patients, they will be having bronchial asthma, COPD, diabetes, CKD, and whatnot, hypothyroidism, everything. So they are usually these things go hand in hand, as Dr. Hassan told us. So calcium channel blockers are preferred when the patient has COPD and bronchial asthma. Young patient, of course, diuretics, ARBs, or combination of these drugs. As the previous speaker has also told, we don't prefer diuretics in elderly people because of two things. One is hyponatremia. Second, I've noticed that they get syncopal attacks, and which can be very dangerous, causing falls and fractures of the bones. CVD, judicious use of new beta blockers, and when BPH is there, alpha blocker, and avoid ARBs in CKD, that we all know. Hypertensive emergencies made the three molecules which are used. One is sodium nitroprusside, another is nitroglycerin, labetalol. People have been using nitroglycerin for hypertensive emergencies in stroke also, but that has been discouraged now. This is sodium nitroprusside, which is available in 2 ml vials, 50 milligram per 2 ml. So this is a very nice molecule for hypertensive emergencies. It has to be given in IV infusion, 0.25 to 10 micrograms per kilogram per minute IV infusion in 5% dextrose. A separate line is needed and it should be covered because light should not fall on this molecule. So we have to keep it in dark. So the separate arrangement for administration is required. And nitroprusside is better in patients with raised ICP, which is seen in large infarcts and ICD. As I said, nitroglycerin is preferred when there is associated coronary ischemia. So few patients will have acute myocardial infarction, and then later on they'll develop acute ischemic stroke also. These patients may be coronary ischemia. Since it is there, nitroglycerin is better. Otherwise, routinely we don't encourage using nitroglycerin in patients with stroke. And the most handy treatment is injection labetalol. Dr. Lakas also was telling, Lobet injection, 20 to 80 milligram IV bolus every 10 minutes. We have to continuously monitor, or we can give an infusion 0.5 to 2 milligram per minute IV infusion. It's good in all hypertensive emergencies except acute heart failure for the obvious reasons. So we have discussed about this also, and then this is the algorithm showing how it should be managed. The important thing is whether the patient is going for thrombolysis and mechanical thrombectomy. If he's in the window period, the targets will be different. And if he is not going, if he's out of the window period or not going for lysis or mechanical thrombectomy because of other reasons, then the goals are different. Of course, we have to speak about the lifestyle changes also. We have to encourage our patients and tell them and make them aware of the importance of lifestyle modification, get active, eat better, lose weight, stop smoking, control cholesterol, manage blood sugar, and reduce blood sugar. All these things are very important in preventing stroke. What are the take-home messages? Hypertension is the most prevalent risk factor for stroke. It is the most important treatable factor for stroke prevention, primary and secondary. Hypertension-induced brain damage can manifest in many ways, not just stroke. As we have said, it can produce Parkinsonism, it can produce dementia over the years. Goals of BP lowering vary from condition to condition and situation to situation. A rapid fall is not warranted except for thrombolysis or mechanical thrombectomy or severe hypertension. So there can be reactive hypertension. Beware of that and don't take decision based on initial readings. Lifestyle modification is very important, but it is not very stressed upon. Thank you for kind listening. And I'm grateful to GU and Professor Shafi Saab and Dr. Khazi Saab for giving me this opportunity to present neurology of hypertension in front of this audience. Thank you.
Thank you, sir. It is our honor that you, after taking so much pain, you have arrived here, and you are such a busy person, and you took out time for this talk. So, Elite Academy, and on behalf of JUICE IMSR, I thank you very much.
Thank you.
Now we will start with our short inaugural function. We have the Dean, the Dynamic Dean of Indian Institute of Medical Science and Research, our chief guest or for today's webinar, to whom you were listening, Dr. Abdul Majid sir. And we will start a bit of felicitating function of Majid sir, because it is very important that he has came in person and attended.
आपको बात करेंगे तो
Started. Absolutely. Karo.
Like to request our team, sir.
I would like to request our dean sir to kindly say a few words about this webinar.
Good afternoon, all. It's my pleasure to host you for this CME. Being online CME this time, our delegates are not only from the city, but from the state, nation, and also abroad. And online CME is having its own advantages. People can attend it from anywhere. Some disadvantages also there. We cannot have lunch together. Somebody is taking lunch on his own. I can see that. Our college is situated in a rural area at the border of Aurangabad and Jalna district. So we are arranging 3 CMEs per year at our institute. But people from Aurangabad, it's difficult for them to arrange to attend all those CMEs. So we have started this concept of keeping 3 CMEs in the city, so the people in the city can attend. But this time it's the first time that we are arranging an online, so people can attend from outside also. And it gives me a great pleasure also to share the screen with one of our mentors, Dr. Abdul Majid sir, who has been supportive throughout all our activities. Whenever we give a call to him, he has never said no. I've never heard a no from him in spite of all this busy schedule. And I once again welcome you all, and I hope that you are enjoying the academic feast today. Other feasts, as I said, cannot be enjoyed online, but at least you are enjoying the academic feast. And I wish all the best to all the hosts as well as all the speakers. I once again welcome all the speakers also from various parts of India who have attended this CME. And I wish all the best for the remaining section also. And with this, I thank once again Majid sir and all the other speakers who have attended and we have given a lecture on this. And I have seen this online. I was attending it in the morning. Everybody was very enthusiastic. They were very effective, to the point. And I hope that after this end of this CME, we'll have a good gain of knowledge in our respective fields. Thank you all. I have missed one point. I thank especially Dr. Shafi, Dr. Zubair, and Dr. Jawad for arranging and taking all this pain because it's the first online CME. So there may be some technical glitches. Whatever we try our best, there is always some technical glitches. In spite of that, they have kept a good rapport. They have kept a good momentum as well for this. Only half an hour late, I think, is going on, but they will cover that time. So thank you all.
I thank you very much, sir. Now I request our chief guest, Dr. Abdul Majid sir, to kindly enlighten us with his vision of medical education.
So I feel honored to be here to inaugurate the CME. This has been going on since morning, and we all know the importance of knowledge in our respective field and the importance of updating ourselves. It is said that either you get updated or get outdated. So we have to update ourselves continuously, and there's a tremendous effort from the GU people and LH Academy, which has been presenting these opportunities to all of us to update ourselves. It is not that these points are important and we have to earn these points to renew our registration. That is one part of it. But the important part is by sitting at home also, we are enjoying the feast of academic knowledge and excellence and experiences of lots of experts in their respective fields. So this is not a small thing. This is a very big thing which needs congratulations. So I congratulate all of them, especially our Dean Dr. Azhar Siddiqui Saab, Professor Shafi Saab, a young dynamic Dr. Hazi Saab, Dr. Jawad. They are doing and taking tremendous efforts to arrange this. This is not easy. This is not simple as it looks. It takes time, effort, and a lot of perseverance to arrange these kind of CMEs and get it over successfully. So I congratulate and declare this CME as inaugurated. Thank you.
Thank you, sir.
Thank you very much.
Sir is very kind. Sir is our actually teacher. He is my teacher. So we are honored to be his students.
Now I request our Dean sir to kindly felicitate our chairperson and chief guest, Dr. Abdul Majid sir, by presenting a shawl and memento.
Sir, बैठिए. Thank you, sir.
Thank you.
सर हम यहाँ से तालियां बजा रहे.
Yes, definitely. We are listening, madam. We know your good vibes are with us.
Yeah, thank you, thank you. It's a great
Delegates are
session.
telling that they are clapping from their side.
Okay. Thank you very much for that.
Thank you. I request the Director of Elite CME and Professor of PSM Department, Dr. Shafi sir, to kindly felicitate our Dean sir, Dr. Adar sir, Dean of Indian Institute of Medical Science and Research.
Is it necessary to felicitate the host also?
No, sir, it is just a token of gratitude.
Thank you.
So, here I get a chance to get felicitated by the esteemed members present here. I request Dean sir to kindly felicitate Shafi sir. He is one of the person who is very much motivated in the team of Elite Academy.
I request Majid sir also to join me because we are colleagues. It is honor to be felicitated by Majid sir.
Now I request Dr. Jawad sir, the playback singer of Elite Academy. He does not come on screen much, but he is one of the most helpful person. I request Dr. Majid sir and Dean sir to kindly felicitate Dr. Jawad sir with shawl and memento.
Thank you very much.
And as you all can see that I am also taking very much efforts. So I request everyone to please present me my memento.
All of us are lucky that we are getting felicitated by one of our mentors from Aurangabad.
Thank you.
Maximum talia, maximum claps for you. Great.
Thank you, madam. Some delegates are telling that maximum claps are for me.
Because he is facilitator.
Thank you very much. So we'll continue with our session. I would like to thank all of our esteemed guests to being here, and we will continue with our session. I would like to involve Dr. Faisal Siddiqui sir with his introduction just in 2 minutes. So our next speaker is very dynamic and very genius psychiatrist, sir, Dr. Faisal Khilji sir. He has done his MD in psychiatry from Government Medical College in Gujarat, and he has done his fellowship in psychiatry. He has done many certificate courses, one of which we would like to highlight at this moment is de-addiction psychiatry. He is an expert in that, and child psychiatry, one of his expertise, and he is also working as male sexologist, one of the understood stigma of the society, but sir is working in that. Sir is associated to many of the psychiatric associations and has conducted workshops and training for young psychiatrists. Sir is a co-author in the book of sorry, Hamari Nafsiyati Sehat. The book, sir is co-author in this book. He is also an academician, an ex-associate professor from Badnapur Medical College, that is Indian Institute of Medical Science and Research. I request sir to kindly share his screen and he can continue with the session.
Thank you, Dr. Jawad. Can you hear me? Am I audible?
Yes, sir. I can hear you, sir.
Is my presentation visible?
Yes, sir, your presentation is visible. Okay, sir, you are all set for the session, sir.
Okay, thank you.
Thank you.
So, without taking much of your time, I would like to thank the organizers for giving me an opportunity to give a talk on this topic. As we all know, today's CME is on hypertension. I would like to highlight the connection between hypertension and anxiety disorders. So, first of all, let us see the as we all know, we have heard since morning what hypertension is, but as everybody stressed upon the fact that for managing the hypertension properly, what we need is there should be lifestyle modifications, appropriate medical interventions, as well as reducing the health risks, adopting a healthy lifestyle, balanced diet, regular exercise, and stress management. And that is very important topic that is linked to anxiety and psychological problems. So, coming to just an overview about psychiatric disorders, we know that these mental health disorders, they are close to 60 to 70 million people in India. They suffer from common and severe mental health disorders, according to a Lancet study. Well, actually, according to WHO, it says that almost every second person suffers from a mental health disorder in their life once at least. And at a particular period of time, cross-sectionally, if we see, 1 in 4 of us, they suffer from one or another psychological problem. So that can just give us the idea about the immense burden that these psychological problems have. So coming again to this, a complication of those psychological problems is suicide. India has been identified as the world's suicide capital with over 2.6 lakh cases of suicide reported annually. So it's a very shocking and frightening data, and that indicates the need for handling these mental illnesses properly. And the most, I would say, the challenging task in this is the handling the stigma associated with mental illness. Mental illness continues to carry a stigma in India, which can hinder awareness, timely intervention, and access to mental health services. So, what is needed, in fact, is a comprehensive approach, multifaceted strategy, awareness camps, campaigns, destigmatization efforts, increase access to mental health services, policy initiatives, and public education and community engagement that all can lead to a better future and better control of these mental health problems. Now, coming to the topic, anxiety. What is anxiety? Actually, everybody of us feels anxious. Anxiety is a natural response to stress. It is characterized by feelings of fear and worry. It's a normal part of life, and it can be triggered by various situations and events. Excessive prolonged anxiety that interferes with daily life may indicate an anxiety disorder. That is the difference between having anxiety or an anxiety disorder. If that prolonged and excessive anxiety is interfering with our daily life, then it becomes a disorder. And the common symptoms of anxiety disorders are restlessness, tension, racing thoughts, physical manifestation like increased heart rate, and of course, can lead to many physical illnesses, even hypertension. So, anxiety disorders, they represent a group of mental health conditions which are characterized by excessive persistent feeling of fear, worry, or apprehension that can significantly impact daily life. And there are several types of anxiety disorders, each with unique features. So the first one is generalized anxiety disorder, and we'll see what it actually is in later slides. Panic disorder, social anxiety disorder, specific phobias, OCD, and post-traumatic stress. Now, just to sum up, I have presented this presentation, I have made this presentation in a way that we can relate with the day-to-day cases that we see in our OPD and try to explain that how these cases are interconnected with the psychological problems like anxiety. And as is said by many of my physician colleagues, that almost 50% of the patients that they see in their OPDs are actually psychological patients who don't know where to go, and they actually have psychological issues. So let us look at this first case. A 28-year-old female with a chief complaints of recurrent episodes of intense fear and discomfort. And the HOPI patient reports experiencing sudden, unpredictable episodes of overwhelming anxiety, accompanied by physical symptoms such as palpitations, sweating, trembling, and feeling of impending doom. These episodes last for about 10 to 15 minutes and occur unexpectedly. The patient worries about having additional attacks, leading to avoidance behavior. So there's no significant past medical history, and the family history is also negative. Social history. The patient works in a high stress environment and reports recent life stresses, including a change in job responsibilities, and there's no significant trauma or abuses. Developmental history is normal, and the patient describes increased stress at work and challenges in managing her work-life balance. And there's patient not on any medications. According to the DSM-5, the patient is suffering from panic disorder. There's no evidence of any medical condition contributing to symptoms. Now let us just try to recollect. A lot of patients like this, they are coming to the routine OPD. Maybe you also have seen such patients coming to your OPD. So this is how a patient of panic disorder comes to the OPD. The typical symptoms will be अब सर सीने में बहुत दर्द हो रहा है, घबराहट हो रही है, दिल की धड़कन तेज हो रही है, बेचैनी हो रही है, और कहीं डर लग रहा है कि कुछ हो जाएगा. And when you check, the BP is absolutely normal, the patient is relaxed, and definitely when the time of panic attacks, there can be a slight raise in the blood pressure. But otherwise, in between the attacks, the patient is absolutely normal. Patient is but having apprehension that he might have some cardiac illness or some major illness or hypertension, and all these kind of fears the patient has. And this is how we have to reassure and treat the patient. We have to, of course, do psychoeducation of the patient that this is not a severe physical illness. It's just, it's a psychiatrical illness. And we have to reassure that, okay, if you get the proper treatment, we'll be fine. And what are the treatment? First of all, psychotherapy, you have to counsel the patient. And the common one is CBT, cognitive behavior therapy, that addresses the maladaptive thought patterns and behavior. So basically, everybody has got some patterns, thought patterns and behavior. Each one of us has a pattern of thought and has a pattern of behavior that is embedded in us. Some of those patterns and behaviors are, some of them are negative or maladaptive. So this happens when the maladaptive thoughts and patterns, thought patterns and behaviors, they are, increasing. They are leading to this anxiety. So we have to correct those thoughts. What are the wrong thoughts? Patient might be catastrophizing, thinking, yeah, if I have those symptoms, I heard somebody having those symptoms and they had a heart attack and they passed away. So some patients might think, okay, ऐसा हुआ तो मुझे भी हो. Was an age. You are a
Recording
healthy
in progress.
person. You don't have any medical history. Your BP is normal. Your ECG is normal. There's nothing like that. So this kind of CPD, correcting those thoughts, you are catastrophizing. You are just overgeneralizing. These kind of wrong cognitions you have to correct. And if required, obviously you can start the patient on pharmacotherapy such as SSRIs, and also for a short period of time we can give some anti-anxiety medicines like tranquilizers or benzodiazepines for a short period of time, and as the patient becomes fine and stable, gradually those medicines can be tapered off. So this is how actually we treat the patient with anxiety, especially the panic disorder. Now let us just see rapidly what are the criteria of a panic. So, coming, yes, what are the criteria? Sudden intense apprehension, fear or terror, and then a rapid development of at least 4 of the following: palpitations, sweating, trembling or shaking, sensation of shortness of breath or smothering, feeling of choking, chest pain or discomfort, nausea or abdominal distress, dizziness, unsteadiness, lightheadedness or fainting, derealization, depersonalization, fear of losing control or going crazy, fear of dying, numbness or tingling sensation, chills or hot flashes. So any 4 of these symptoms, if they are present, then it amounts to be a panic attack. And what is panic disorder? If you are having recurrent panic attacks, at least one of the attacks has been followed by a month or more of one of or both of them, persistent concern or worry about additional panic attacks or their consequences, and a significant maladaptive change in behavior related to the attacks, then this becomes a panic disorder. Now, panic disorder is actually uh, quite underreported. Like we can see in the study, the lifetime weighted prevalence is 0.5%. And of course, male gender and unemployed individuals, they have a high incidence. And elderly individuals, those in urban metro areas and the married group, they have significantly lower incidence. Comorbidities, most common comorbidity are psychiatric disorders, of course, like agoraphobia, that is fear of places from where escape can be done. So the person with panic disorder will classically present with fear of going in a crowded place, fear of going in a closed place, fear of traveling in a public transport like a bus or a train or aeroplane, where they cannot just to stop the transport, stop the vehicle whenever they are having a panic. This kind of fear that if I have a panic attack, what will happen? How will I recover from this? If a lot of people they restrict themselves to their homes and to the localities, and they are not comfortable to travel alone. These kind of symptoms are present in agoraphobia. And obviously, depression, anxiety, and depression go hand in hand. If you have severe anxiety, you're bound to, you're at risk to go in depression. And also, generalized anxiety disorder is present in 10% of the cases. And of course, around 80% of the patients with current panic disorder had some level of disability, and 20 to 25% had marked disability. And of course, as I told you about the stigma and the lack of education, psychoeducation, knowledge about these diseases, it's so common in us, the doctors. So how would the common people know much? So the treatment gap is again huge. 71.7% of people, they actually don't get the right treatment that they deserve. Now, just coming up to the second case. This case is of a 45-year-old male. He was having elevated blood pressure readings, especially at the doctor. Patient reports consistently elevated blood pressure readings during medical appointments, but normal blood pressure measurements at home. Episodes of increased anxiety and nervousness, specifically during medical visits, are noted. Past medical history is negative, the patient is generally healthy, and family history is positive for hypertension with both parents having diagnosed. So that again creates a lot of anticipation and fear in the patient that like my parents have blood pressure, maybe I will develop blood pressure, and that kind of thinking sometimes make the patient anxious. Social history: the patient works in a demanding job and reports high level of stress, particularly related to work responsibilities. There's no history of substance abuse, and developmental history is normal. Psychosocial history, again, the patient acknowledges feeling anxious and uneasy during medical appointments, often anticipating a rising blood pressure, and there is no significant recent life change or losses. Medication history, the patient is not on any medication for hypertension or other medication. And according to the, what's the diagnosis? So this patient is actually suffering from white coat hypertension, most probably, and we can confirm this by ambulatory blood pressure monitoring that we'll see later on. And yes, of course, patient needs. How will we actually know what is it white coat hypertension or is it real hypertension? So let us understand what is white coat hypertension. It's a form of labile hypertension in which people exhibit an elevation of blood pressure level in a clinical or hospital setting, although they do not exhibit the same in other settings. And as it is said, it is not this that white coat hypertension patients are actually not having blood pressure. Sometimes they actually have blood pressure, but what happens is the blood pressure is not that severe. Then the patient is at home, and when the patient comes to the clinic, the blood pressure actually shoots up. So that leads to a overdiagnosis, and sometimes the patient are given over medication, and that leads to the problem. And what is again, the ambulatory monitoring is very important. In 24-hour ambulatory monitoring of the blood pressure can let us know actually how the average real-time blood pressure of the patient is for the most of the time of the day, and whenever it is increasing, is it increasing only at the doctor's clinic? And management again is relaxation techniques, suggestions for overcoming anxiety during BP measurements, and again ambulatory blood pressure monitoring for the confirmation, and follow-up recommendations very important. We should regularly monitor those patients, and we should reconfirm the diagnosis. Maybe later on, turn up to be patients of actual hypertension, or they might be suffering from some or the other psycho. Now coming to the third case, so this is a 35-year-old female with recurrent panic attacks with a specific fear of developing hypertension. Like the patient reports experiencing sudden and intense panic attacks characterized by palpitations, shortness of breath, and sense of impending doom. And a distinct aspect of the panic attacks is preoccupation with the fear of developing hypertension, often exacerbated by concerns about impact on overall health and past medical history. Is heightened awareness of health-related issues and frequently monitors blood pressure at home. We all have seen, I think, these patients who just keep on, taking their blood pressure every day and many times a day, and they have a very strong fear of getting hypertension. So this kind of, cognitive distortion that they have, that, oh, if I have hypertension, then I think my life is done. So this leads to all the anxiety. So on the family history, it was negative for panic or hypertension. Social history, the patient has a busy lifestyle and has difficulty in balancing work and family. There are no significant stressors or recent anxieties, no such substance abuse or smoke. Normal developmental history and psychosocial history. Of course, the patient has health-related anxiety and a persistent fear of development. There is increased focus on physical sensations, leading to heightened worry and what typically what these patients tell us. अगर मुझे बीपी नहीं है तो मुझे छाती में तकलीफ, अगर मुझे बीपी नहीं है तो why am I feeling dizzy all the time? Why I have this feeling of I have these palpitations, why I have these tremors, why I have this sweating, and they don't actually know that these are because of the anxiety that they have. It's not because of blood pressure. This fear of getting blood pressure actually is because of their anxiety, and it's leading to the diagnosis or development of anxiety. There's no use of medications for mental health concern, but there is limited use of over-the-counter medication for anxiety. And diagnosis, according to DSM, is a diagnosis of panic disorder with a specific phobia of developing hypertension. No evidence of medical conditions contributing to the symptoms. Treatment plan, again, recommendation from CBT to address the wrong patterns of thought, psychoeducation about the nature of panic attacks and the association with hypertension fears, collaboration, with a healthcare provider for periodic blood pressure monitoring and reassurance. Follow-up appointments again and monitoring is very important, and they should be encouraged to communicate with the healthcare provider to address the concern that the patient has about blood. And again, the prognosis with appropriate treatment and the panic disorder with specific periodic hypertension is generally favorable. So CBT is again very useful in managing these. Now, coming to specific phobia, like this patient was having that specific phobia of developing hypertension. A lot of people accept hypertension like it's a normal, it's a stage of life, or it's something that happens to most of us. So there's nothing to worry. you can live with it. But a lot of people have a specific phobia, that irrational fear of getting hypertension. So specific phobias are irrational fears of specific objects, situations, such as heights, animals, or flying. These phobias can lead to extreme avoidance behavior and can significantly impact daily life. Like I have a patient who comes daily to my clinic because of this anxiety. I have to, counsel him and assure him, and that is actually a very, big task. Exposure to the feared object or situation often does intense. Now coming to the case 4, this patient is a 40-year-old male having the chief complaint of persistent anxiety with a specific fear of experiencing a heart attack. So, history of the present illness: the patient reports ongoing anxiety characterized by worry about his heart health. Specific fears revolve around the possibility of having a heart attack, leading to increased vigilance regarding physical sensations and symptoms such as chest discomfort, shortness of breath, and palpitation. Anxiety often intensifies when engaging in activities that may be perceived as physically demanding. This person doesn't have a fear of getting hypertension, but actually has a severe fear of getting a heart attack. The past medical history is absolutely normal, no cardiovascular problems, negative family history for heart disease or anxiety disorder or early onset heart disease. Social history: the patient again has a high stress job, difficulty in balancing the family and the profession, limited social support, no history of substance abuse. The developmental history is no. Psychosocial: patient acknowledges experiencing chronic stress related to his family with heightened anxiety, specifically surrounding heart health, sleep disturbances, and fatigue. Medical history: medication is negative, and again the diagnosis of generalized anxiety disorder with a specific fear of having a heart attack is made. Treatment plan: again CBT, relaxation, and meditation if needed. And now, what is generalized anxiety disorder? It involves chronic and excessive worry about various aspects of life, often without a specific trigger. Individuals with GAD may experience persistent feelings of tension, restlessness, and irritability. The worry extends to everyday concerns like work, health, relationship, impact. Like GAD वालों का ऐसा होता है, जब सुबह उठते हैं तो they are like आज किस बारे में like it's a daily work for them. हर सुबह they are anxious about one thing or other. Now coming to this case 5, page 30-year-old female having somatic chest pain, palpitation, burping, following a panic attack with persistent fear of developing heart. Now this patient experienced.
Sir, it will be very kind of you to wind up. Okay. After some minutes, definitely.
Yeah, sure.
Yes,
Yeah.
yes, yes.
This is the last case.
Yeah.
So the patient.
Sir, please unmute yourself.
Thank you. So this patient experienced a sudden and intense panic attack a month ago, and it was characterized by feeling of impending doom. And subsequently, she developed somatic symptoms like chest pain, palpitations, excessive burping, and they have persisted since the panic attack. The patient is preoccupied with the fear of having heart disease, leading to heightened anxiety. In all the the reports, everything is normal, and history otherwise is all negative. The diagnosis of panic disorder with somatic symptoms, specifically chest pain, palpitations, and burping based on DSM-5 rate. So, similar case, I won't go into it. So yes, so what is the hypertension and anxiety? The relationship is intricate and bidirectional, involving psychological, physiological factors, and hypertension and can exacerbate symptoms. And anxiety disorders are more prevalent in hypertensive patients, like 37.9% of hypertensive patients have anxiety disorders, while 12.4% in the general population have anxiety disorders. Anxiety can be a contributor to hypertension, Anxiety triggers the body's stress response, releasing stress hormones like cortisol, increasing sympathetic nervous system activity. Acute and chronic effects of anxiety can increase, like acute anxiety can temporarily increase blood pressure, while chronic anxiety can cause sustained elevated levels of blood. An unhealthy coping mechanism of patients with anxiety may lead to hypertension, like smoking, excessive alcohol consumption, which are again risk factors for anxiety. And hypertension can contribute to anxiety, like hypertension can have physiological effects on the brain and cardiovascular system, potentially contributing to anxiety. And some medication side effects, as you will see in the next slide, like beta blockers, potentially can lead to fatigue, depression, vivid dreams, and sleep disturbances. In some people, calcium channel blockers can lead to headache and mood. ACE inhibitors can changes in mood and diuretics can lead to changes in sodium potassium levels, electrolyte imbalance, which can influence. And both can have shared risk factors like lifestyle, common sedentary behavior, poor diet and smoking, and some there can be genetic factors that also cause both of them. And it can impact the overall well-being, both of them. The coexistence of hypertension disorders can significantly impact the individual's quality of life, leading to challenges in daily functioning and emotional well-being. And the combination of both these may increase the risk of cardiovascular complications and other health issues. Treatment implications, again, there should be lifestyle modification and collaborative, coordinated care between mental health professionals and the healthcare providers for hypertension. So with this, I end my presentation. Thank you. Thanks for the patient list.
Thank you very much, sir. It was very informative, and as you have shared the cases, so a very much practical overview of the topic. Now I would request Dr. Mohini Apte, madam. She is Associate Professor in Indira Gandhi Government Medical College, Nagpur. She is a pediatrician, and she will be presenting the topic on perspective of pediatric hypertension. I request madam to kindly share her screen, and she can go with the presentation.
So good afternoon, everyone. Can you hear me?
Yes, madam, we can hear you.
Okay. So,
madam, you have to share your screen, and your camera is not on.
Okay, I'm trying actually. Now?
Your camera is on. You can share your screen.
Yeah, just a moment.
Yeah.
Is it on?
No, madam.
I'm trying to share.
It's okay, madam. First of all, open your PowerPoint presentation in your laptop and minimize it.
Achha, okay, minimize it, is it?
Okay, you minimized it?
So I'm doing it on a tab.
Okay, madam. Exit from the slide share view and then minimize it, the window.
Okay. So, but I should put the slideshow on.
Afterwards, then come to the Zoom meeting now. With that, click the option of share screen. That is the 5th option on the script that is coming up.
Okay, now I'll just check.
Come to the meeting.
Yes. And what do you want me to do now?
After sharing your screen will be visible to us. Then you can go back to the PowerPoint presentation and you can start the slideshow. So then we all will be able to see that.
Okay, just a moment. So
Yeah,
I'm sharing the screen now.
Right.
But it's not opening. It's so it's not happening.
Okay, madam. Don't worry. We will make it in this way that I will share my screen and your presentation, and
Yes.
you will be talking from there, and then you can just say next, and I will change the slide. Okay.
Right. Great. Thank you.
Just give me 2 minutes so that I can do arrangements for that. Right.
Right.
Okay, ma'am. Okay, madam. Now can you see the your PPT?
Yes, I can see, ma'am.
Yes. Now you can continue.
Yes. Thank you so much, and sorry about the trouble. So
No,
good
madam,
afternoon.
it's okay. It's all right. Don't worry. Just do your best.
Yeah. Thank you.
Thank you.
So good afternoon, everyone, and today we are going to look at perspectives on pediatric hypertension. Now, since morning, you've been listening to speakers who are talking more or less on adult hypertension. So I thank organizers for recognizing the importance of hypertension in children, especially Dr. Shafi, who's my batchmate, and he's also the organizing chairperson of the CME. So thank you so much, Shafi, for inviting me to for this talk. And I'm very happy that the organizers have recognized the importance of awareness among people, because I see I'm talking to a very wide audience. Some of you are physicians, general practitioners, neurologists, and so on and so forth. So it's very important that people understand pediatric hypertension. So the medical services in this country are more therapeutic than preventive, and a person has to be sick to be for him or her to have access to healthcare. They seek access only if they have a problem, and then they just forget about it. So but it's slightly different in pediatric health scenario, because people are slowly understanding the importance of vaccine. Government is also doing its bit towards vaccination. So preventive care up to under 5 children is improving. But what remains is that after 5, when the vaccination is hardly there, people are not accessing healthcare just for checkup. And that is a very big problem. So vaccine has decreased the burden, infectious disease burden. There is improved sanitation. There is improved socio-economic status. And we are slowly moving from a country which was considered to be a capital of malnutrition to a scenario where you are having a population which is now thought to be the capital of diabetes. So just see the change from malnutrition, people dying of hunger, to people dying of other end of malnutrition, that is obesity. And that brings us to today's topic, that why is it important to know about hypertension in children? So now hypertensive children, although very infrequently they are symptomatic, they will have end organ damage just as in adults. Up to 40% of hypertensive children, when diagnosed, will have left ventricular hypertrophy, or as seen in adults, or even early signs of atherosclerosis. Hypertension during childhood often continues into adulthood, and children with BP of more than 90th percentile exhibit a 2.4-fold greater risk of hypertension as an adult, and therefore early coronary and artery disease and risk of stroke and so on and so forth. Adolescent hypertension, it's a very big thing. It's an in thing, and it's also independent predictor of both end-stage renal disease and left ventricular dysfunction. Next slide. So childhood hypertension is also divided into two broad groups. That is the primary hypertension, just like you have in adults, and secondary hypertension, where there is an underlying cause or a disease which is causing the secondary hypertension. Next slide. So now in infants and children, the systemic hypertension is really, really uncommon. The prevalence is less than 1%, and when present, often indicates that there is an underlying disease process. The prevalence of primary hypertension, mostly in school-age children and adolescents, is now increasing, and it is in this prevalence has increased because of the parallel increase in prevalence of obesity. That's the obesity epidemic we are looking at. So severer the hypertension, more symptomatic the hypertension in children, it is usually caused by secondary hypertension. So secondary hypertension means that there will be an underlying cause. The younger the child, more severe the hypertension, it is more likely that there will be an underlying cause. Next slide, please. So, and there is something called the phenomena of tracking. Now, the tracking refers to the pattern of repeated BP measurement. This is just to highlight that if the child has primary hypertension, he is likely to have, over a period of time, he will be hypertensive, and he will be hypertensive as an adult. And this has been seen under various long, the result of a long-term follow-up studies done in Western world. So if you happen to have a child who is hypertensive, then you need to follow up these children and monitor them very closely, because they are the children who will need treatment. Because if you don't treat them and leave it like that, they will. So now, ब्लड प्रेशर मेजरमेंट इन चिल्ड्रन. सो किस में देखेंगे कि कौन से बच्चे हैं जिनके लिए आप सोचेंगे कि इसमें मुझे बीपी देखना चाहिए. सो फॉर चिल्ड्रन 3 years old, annually taken. So it's about older children, 3 years and older. This is all 2017 AP guideline. If the children has risk factors such as obesity, chronic kidney disease, or diabetes, it should be checked at every healthcare encounter. So every time a child who's obese or has had a kidney problem, need not be a chronic kidney disease or diabetes, he or she should have a blood pressure recording. Now, in younger children who are less than 3 years old, if there is a history of prematurity, congenital heart disease, renal disease, some drugs which the child has received which can lead to hypertension, or there are neurocutaneous stigmata like neurofibromatosis, tuberous sclerosis, or there is evidence that child may have raised ICT, then these are the children who will require follow-up, and they will require blood pressure recording at every encounter with the healthcare professionals. Next slide, please. So I'm going to be very, very basic here, because see, every time pediatricians talk to non-pediatrician, they always try to highlight that children are not small adults. So to measure BP, we have to be very, very careful. The BP cuff, the sphygmomanometer and auscultation by the BP has to be measured by auscultation using a sphygmomanometer cuff of appropriate size. Now, why the appropriate size? Because if the cuff is too large, the BP will be less, and if the cuff is too small, the BP will be more. So either you will fail to diagnose or you will miss the diagnosis if you are not using a proper size cuff. Next slide, please. Next slide, please. So see, I have deliberately brought this picture here because the cuff size, if it is improper, you will find that your blood pressure readings are faulty. So a blood pressure cuff should cover 40% of the circumference at midpoint, that bladder of the BP cuff, and it should cover 80 to 100% of the arm. And what part? How do you measure arm? Arm is between acromion and olecranon, and you have to cover 80% of the length and 40% of the circumference. So that is an appropriate BP cuff. So after using the appropriate BP cuff size, next slide, please. Next slide, please. So this is the variable size cuffs. We see. I'm not aware. Most pediatricians will also not have, but these are up for sale and not very expensive. So those of you who are seeing children in their regular practice, please have these various size blood pressure cuffs, because only then you are sure and confident that really the child does not have hypertension or does have hypertension. So next slide, please. So once you have taken adequate care for BP measurement and you've got a value, then you have to see whether this child has normal blood pressure, mild elevation of blood pressure. Is he in stage 1 hypertension or stage 2 hypertension? That is how hypertension is graded in amongst children. So now for children aged between 1 to 13 years, you will have normal blood pressure. That is, so we have centile charts for children. So you can Google it. They're available widely. So if your child is falling at less than 90th centile, then your child has normal blood pressure. If that systolic BP for a less than 13-year-old is falling between 90th to 95th centile, you will have to keep a close watch on this child. Now, if this systolic and diastolic, if the systolic and diastolic blood pressure is between more than 95th centile or to 95th plus 12 for systolic and diastolic BP, or more than 130 but less than 139, it is stage 1 hypertension. Or if it is more than 95th centile plus 12 or BP more than 140, it is considered systolic and diastolic 140/90, it is considered as stage 2 hypertension. So you have to use centile charts for younger children. For 13 years children or older, it's like adults. So normal BP is systolic less than 120, diastolic less than 80. Stage 1 elevated is more than 120 up to 129. Stage 1 is 130 to 139, and more than 140 is stage 2 hypertension. Now, why we have the graded this hypertension is, when we will come to the treatment, we will decide on how we are going to treat these children. So next slide, please. So once we have got a child who has hypertension, we want to know or understand whether it is a primary hypertension or essential hypertension, just like you have in adults, or it is like a secondary hypertension. So if your child is a prepubertal, so we have already discussed that the younger the child, more symptomatic the child, it is likely to have an underlying cause. So secondary hypertension is more common in younger children, especially if the child is less than 6 years of age. If it is a post-pubertal child, then you are more likely to have a child who would possibly have a primary hypertension. If there is diastolic hypertension, it is going to be a secondary hypertension. If it is nocturnal hypertension, it is going to be secondary hypertension. If the child is overweight, obese, there is family history of obesity, it's going to be primary hypertension. And if the child is presenting with headache, sweating, vomiting, tachycardia, left ventricular dysfunction, the likelihood is that it is a secondary hypertension, because secondary hypertension appears when there is a cause, And if there is a cause like a pheochromocytoma or like a transient cause like a post streptococcal glomerular nephritis, then it has happened acutely. There is no time for the child to compensate, and therefore secondary hypertension will become more symptomatic even if there is a very mild rise in blood pressure. Next slide, please. So in children, etiology could be, it is not, since it is not essential, it can be renal, vascular, endocrine, and so on and so forth. More very important to understand is if there was an antenatal diagnosis of polycystic kidney disease, dysplastic kidney, dilated pelvic alveolar system, or there was any evidence of obstructive kidney disease, because these are the children who will later, they may progress to have a very severe form of this condition and will have hypertension. So these, some of these children are can be diagnosed even antenatally because the problem starts in fetal life. Then you have other causes like VUR causing pyelonephritis, or younger children less than 1 year old have recurrent pyelonephritis. There can be chronic glomerulonephritis, primary or secondary, or there could be renal tumors, trauma, and so on and so forth. Vascular is a very important cause of hypertension in children because renal artery lesions, mainly stenosis and fibromuscular dysplasia, are the commonest cause of hypertension in children. So if it is a congenital, if you look at coarctation of aorta, there will be a variation between upper limb and lower limb. The lower limb blood pressures will be higher and than the upper limb blood pressures, and that is how we come to the diagnosis. Umbilical artery catheterization, if there is a history in neonatal life, then obviously this can be the cause. Or in younger children who have suffered acute gastroenteritis and now they are having hematuria, it could be younger children, it could be renal vein thrombosis. Other vasculitis syndromes like polyarteritis nodosa, Takayasu arthritis, also known as pulseless arthritis, and ANCA-associated polyarteritis nodosa, and so on and so forth, can be diagnosed because the child has come to you with symptoms of hypertension. Next slide. So, continuing on the etiology, it can be endocrine. So there are certain conditions called congenital adrenal hyperplasia, where the child has a defect in synthesis of hormones, and they primarily present as hypertension, especially if it is a 11 beta or 17 hydroxylase deficiency. There can be tumors of various types or syndromes like Little or Geller syndrome. Then a very very uncommon situation, but which presents with acute hypertension, is intracranial bleed or intracranial mass, where the child suddenly loses sensorium after a episode of acute headache. So this is most common is intracranial bleed. Next slide, please. So these were the causes of secondary hypertension, where there is some other problem in patient, and but the child is presenting like hypertension. So now there are certain transient hypertension conditions which can lead to hypertension. So that is why when you have a child whom you thought or whom you have measured and has a higher BP reading, or he falls into a child with hypertension, first and foremost thing you have to do is understand that whether it is transient or it is going to be progressive. So transient condition most commonly in children is drugs. Drugs being as simple as nasal decongestants or other sympathomimetic drugs. Some children are on amphetamines for conditions like ADHD or vitamin D intoxication and rest of the other things. But most important are these common drugs like pseudoephedrine containing cough syrups, though they are banned, but they are still available. Sympathomimetic agents with a nasal decongestant. Then there are certain conditions which affect the nervous system but can produce a transient hypertension. Those of you who have seen Guillain-Barré syndromes in your ICUs, you will know that they have autonomic dysfunctions, and therefore they will have tachycardia, bradycardia syndromes, and even hypertension, which is so much so that they will need treatment. Then acute intermittent porphyria sometimes presents as acute abdominal pain with hypertension, and it is episodic. So it is not going to be sustained. When the child is well, he'll have normal BP. When the child is not well, he'll have hypertension. So all those conditions where there is autonomic dysfunction can have hypertension. Then post-streptococcal glomerulonephritis is a very relatively common condition in pediatric wards, where you have a child who has suffered from skin lesions or sore throat, and then he presents with high colored or cola colored urine or red urine, that is hematuria, hypertension, edema, and that triad is your glomerulonephritis, which is a self-limiting disease. The child is going to be better within 3 months. Henoch-Schönlein purpura has a peculiar rash. It is a vasculitis, but it will improve within 3 months' time. So then hemolytic uremic syndrome, like situation where you have the child has preceding history of diarrhea and then suddenly becomes sick as he's recovering. And this diarrhea is very classical. That means there is a blood in stools. That means dysentery. So E. coli diarrhea or Shigella diarrhea, EHEC or Shigella type 1, which is a positive organism in this for this dysentery, and which in some children will lead to hemolytic uremic syndrome. The child becomes pale and develops all parameters of renal dysfunctions. So it can be drug-induced acute kidney injury, it can be infection-induced acute kidney injury as seen in malaria, and many more such conditions. Next slide, please. So we have looked at various causes. So hypertension can be primary, it can be secondary, it can be transient, or it can be progressive. So when we are evaluating a child with hypertension, we have to take a detailed history of what was preceding event, what happened before the child presented with these symptoms of hypertension. Whether there was history of any sore throat or impetigo, as we have discussed just now, or dysentery, whether there was history of any fall and head trauma, whether there was any rash, joint pains, joint swelling, whether there is a sensory neural hearing loss in this child, what were the medications the child has received recently for whatever reasons. It could be simple URI for which he was prescribed pseudoephedrine or nasal decongestants, or it could be or this child who is presented with hypertension. You have to take history of whether the child is passing, what is the color of urine, what is the amount of urine the child is passing, to understand whether he is having hematuria along with raised blood pressure, or whether there is any flank pain which can suggest renal stones. So depending on what, other than hypertension, what is the background history and what are the other symptoms the child is presenting, the child you can narrow down on at least the symptom or system of the affected system which is causing hypertension. So if there was a head trauma, probably there was intracranial bleed or a contusion, raised eyes, followed which there is cerebral edema, and therefore the child has now hypertension. So a background history, background medication history, some developmental problems, family history is very, very important, especially if there is a history of hypertension, renal disease, obesity, or MI. Hypertension is important, especially if the family has hypertension. Rarely I find that sometimes we have newborns who are accidentally diagnosed with cystic kidneys, bilateral cystic kidneys, and when we screen their parents with an ultrasound, we find that they themselves have cystic kidneys. So it is a ADPKD, that is autosomal dominant polycystic kidney disease, or ARPKD, which is a autosomal recessive polycystic kidney disease. So in both, the family history can be positive. So if there is a family history of hypertension and there is a young child presenting with symptoms suggestive of hypertension, you have screened Please take a detailed 3-generation pedigree chart to know whether this is a genetic condition. Obesity runs in families. And early MI, death in a family in less than 55-year-old, this is the old definition, with cardiac illness, you have to screen this family's adolescents at least for hypertension. Now, birth history, if there is, this is pediatricians' forte, they keep asking history about everything. So now birth history becomes important, especially if there is an IUGR. Now there is something called Barker's hypothesis or a thrifty gene hypothesis, where because this child grew in an environment for whatever reasons, mother may be hypertensive, she was diabetic, she had paracental vasculopathy, or whatever was the reason, this child grew in an environment, fetus grew in an environment where he had to conserve everything. So this gives rise to a peculiar metabolism in this child who after birth, when given normal nutrition, still the metabolism is thrifty. Thrifty is conjuice. So it goes on saving everything. And this child is ultimately going to be obese, will have extra fat stores, will develop early atherosclerosis, and will have the hypothesis is called as early markers of in children for adult disease. So if the child had IUGR, it was a premature baby who required umbilical catheterization. Here you have a cause which has led probably to this hypertension. Growth history is also very, very important. Generally, children with chronic kidney disease come to us not for kidney problems, but they come to us for not gaining height, for knock knees, bow legs, because they have developed rickets, which is secondary to renal dysfunction, or they have just chronic growth failure because of the chronic disease. Next slide, please. Next slide, please. Previous slide. So it is important to measure weight, height, BMI. There in examination there will be a lot of clues. If you have upper limb pulses which are good but lower limb pulses which are absent or weak, it could be coarctation of aorta. Then it could be peripheral pulses are weak all over. It could be like vasculitis syndrome, like pulseless disease or Takayasu's arteritis. So a good examination in a child who presents with hypertension is very, very important. You can have mooning or moon faces in child with Cushing syndrome. So Cushing syndrome is nothing but excess cortisol in the body, which will lead to hypertension. There can be goiter and child may be hyperthyroid and therefore will have hypertension, or tonsillar hypertrophy leading to obstructive sleep apnea and therefore causing hypertension. A good eye exam. Once you have diagnosed hypertension in a child, you have to do a complete examination or get checked by an ophthalmologist for any retinal changes or papilledema. A skin rash, which has peculiar distribution, like in SLE, where a post-pubertal girl presents with a peculiar butterfly rash over face, and hypertension and some mouth ulcers, you have a child with SLE. There could be cafe au lait spots, multiple hyperpigmented spots in less than in prepubertal age, they are small but multiple. In post-pubertal age, they suddenly increase in size. So if you have hyperpigmented patches, your patient possibly has neurofibromatosis, which can cause hypertension because of a malignant space-occupying lesion in brain, or because of renal vascular causes. Now, genitalia, as we have discussed, congenital adrenal hyperplasia is a very rare, but if the child with hypertension has ambiguous genitalia, you have to think of congenital adrenal hyperplasia as one of the cause. Abdomen may present with renal mass in a child with hypertension. So it could be a tumor like Wilms tumor, neuroblastoma in younger children, or any other like a rhabdomyosarcoma or something like that, presenting as hypertension. There's a renal mass. So there's so many things which which can happen to a child, but a good history and a good examination in a child whom you have found that the blood pressure is high can give you a good insight into the cause of hypertension. Next slide, please. So once you have documented, so this is a brief algorithm. So once you have documented hypertension, it is mandatory to take blood pressure in upper and lower limbs. If there is discrepancy in upper and lower extremities blood pressure, you have possibly a patient who has diagnosis of coarctation aorta. If it is not there, the blood pressure is same in both upper limbs and lower limbs or within the normal physiological variations, you have to do a urine analysis and also a renal function test. If urine analysis is showing most of the more of pus cells and organisms, it is possibly an infective etiology like pyelonephritis, reflux nephritis, or recurrent urinary tract infection, or any other renal anomaly like a VUR, vesico-urethral reflux. If it is a predominant red blood cells like hematuria is the predominant presentation in urine analysis, then probably you're looking at renal vein thrombosis if the child is young. It could be a tumor. It could be a simple self-limiting post-infectious glomerulonephritis. It could be a chronic glomerulonephritis like in lupus. Or if the child has peculiar rash which has presented only on buttocks and lower limbs, probably it is Henoch-Schwann purpura. So depending on a small first finding of high blood pressure with no upper limb, lower limb variation, with a simple test like urine routine and a KFT, which will tell you whether the renal function is normal or not, you can reach the diagnosis of primary hypertension. If everything else is normal and the child has only high blood pressure, or it could be a renal vascular cause or endocrine cause, where everything else is normal, but you have to keep searching till you have searched in all systems. If everything is normal, then by default your child has an essential hypertension. Next slide, please. So management. Now, once you have diagnosed your child who has hypertension, as the first dictum I said, if the child has come with symptoms or a very severe hypertension, or there is presence of end organ damage, then you have to treat immediately. Now, in children with elevated blood pressure who non-pharmacologic therapy, example diet and exercises, is initiated to reduce the blood pressure. See, we had 3 grades: elevated BP, stage 1 hypertension, stage 2 hypertension. So in elevated, so who are above 90th centile but below 95th centile, then we first start with non-pharmacologic therapy. But if the child has hypertension but there is no end organ issue, then you have to treat first with non-pharmacologic therapy, and if that the child is not responding, then maybe pharmacologic therapy. But if the child has stage 2 hypertension, then you have to treat with both upfront. So patient with stage 2 hypertension, sometimes or more, as it is called as malignant hypertension, who present with headache or altered sensorium or other neurologic finding like stroke or press, as some speaker was talking about in adults. So children also get press, or sometimes the children present with acute left ventricular failure because the heart is unable to pump against a very tight blood vessels or aorta. That is the because of the loss of elasticity that happens in acutely hypertensive child, and then suddenly child lands in hypertension, and then suddenly lands in acute left ventricular failure and pulmonary edema. Now, if diagnosed, these are very gratifying to treat, but they have to be treated in ICU, and this is beyond the scope of this talk. So we will just talk about children who have elevated BP, stage 1 or stage 2 hypertension. Next slide, please.
Ma'am, it will be very kind to wind up in few minutes.
Two slides maybe.
Okay, madam.
Next slide, please. So if the child has secondary hypertension, we have to treat underlying cause. If suppose the kidney disease is there, then both the child will need both non-pharmacologic and pharmacologic therapy for blood pressure and also for his kidney issue, and same with the diabetes. Next slide, please. Next slide. Next slide. Slide after this. So we have to target the blood pressure management approach is that we have to first decide how much the blood pressure reduction is required. So for so the target, since there are no studies on this and how much is good enough, so we have to follow 2017 AAP guideline, which says that the systolic and diastolic blood pressure should be below 90th centile or below 130/80 in adolescents or 13-year-old or more children. Okay. Next slide, please. So I would like to insist on non-pharmacologic therapy, or rather non-pharmacologic prevention of hypertension in children. See, you can't ask children to lose weight. You can't ask children to not eat fats. You can't, but you can moderate their diets. See, myelination is going on, so fat-free diet or something like a keto diet cannot be advised to children. So it has to be a moderate reduction in calorie, moderate reduction in salt intake, regular exercise, restriction of sedentary activities. I'm sure all of you have seen children with tabs, mobiles, which has not put them into couches, chairs, beds, and move them away from playgrounds, physical activity, and this is what is causing the biggest problem today. So regular exercise, and adults have to do a modeling. We call it social modeling, that if you exercise, your children will exercise. If you eat healthy, your children will eat healthy. If families are eating chips, kurkure, and with a very high salt and sitting on couch watching movies, so this is not how you, and then after some time when the child becomes obese, you tell the child, ab ye mat khao, ab wo mat khao, but he has seen everybody in the family do that. So the good social modeling is very, very essential. And just like charity begins at home, similarly, a non-hypertensive lifestyle begins at home. So dietary modifications are required in children with hypertension. The DASH diet, as was discussed. So high intake of potassium, lot of fruits and fresh fruits, vegetables, lot of salads. Snacks should be fruits and low-fat dairy products. Ghee, makhan has to be avoided. So non-pharmacological measures to reduce cardiovascular disease risk factors are very, very important. Lipidemia, chronic syndrome in this includes and so on and so on. Next slide, please.
Yes, ma'am. Please wait. Some people have got unmuted. Okay.
Yeah. Yes.
Yes, ma'am. Yes, ma'am. Okay, ma'am, you can continue.
Right. So teens these days, I have seen teens these days drinking cokes, shakes, alcohol, and what not. I mean, children between 14 to 18 years of age have developed habits from where we don't know, but then yes, with media, with social media, with media, movies, videos, all wrong kind of propagation is being made. All these caffeinated drinks, energy drinks are propagated, And another place where it is propagated is the gym, where they ask you to take high protein diet, high protein shakes and whatnot. So all they have not been studied, and it is strictly recommended not to let your children get into these kind of habits of drinking uh, caffeine induced products like cold drinks and coffee of various types. It is really not recommended. I'm sure there will be studies coming up in soon which will show how harmful these things are. Next slide. Next slide, please. So pharmacologic therapy will be needed in children with stage 1, in which dietary and say, avoiding sedentary lifestyle, prevention of weight loss is not working. So the target, as we have already discussed, will have to be achieved by starting the lowest effective dose, and then progressing to increase the dose and adding another drug if required. But first and foremost will have to be compliance, which has to come from the parent as well as, see, as soon as we tell any diagnosis like hypertension or diabetes in children, the parents first thing they'll do is leave allopathy and try to move to some other pathy. So I believe that counseling needs to be done, that you try everything else, but please stick to this diet restriction and pharmacologic therapy while you try and work for your child. So I have started doing that. So as soon as we give a grave diagnosis, people will just leave. So first thing I counsel that this whatever your condition is will require chronic therapy, but your child will be better. If you want to use other therapy, please continue this therapy. Do not stop medication. I've had type 1 diabetics coming with hyperglycemia, DKA, after stopping insulin just because somebody told them कि छोटे बच्चों को diabetes हो ही नहीं सकता, छोटे बच्चों को BP हो ही नहीं सकता. So all this goes on in society. So you have to counsel practically. Next slide, please. Next slide, please. So there are various drugs which are, as already discussed in previous lectures. So first line antihypertensives are ACE inhibitors. We do not diuretic. They add to hypokalemia, glucose intolerance, weight gain, especially in children. So ACE inhibitors and angiotensin receptors blockers or calcium channels blockers are our primary drugs we start in to children with hypertension. Next slide, please. Underlying cause, you need to take the change. Next, please.
Madam, please wait, madam.
Please unmute your mic.
कर दिया मैं. Yes, ma'am, you can continue.
So next slide.
Yeah. Okay.
Yes. Yeah. Previous.
Okay.
So you can see this UNICEF data, which is showing that 1 in 10 obese children globally will be from India by 2030. 2030 is not very far, and we have to be aware of this, of the risk. And these are our children. These are children in our home, our relatives. So we have to monitor diets, activity of our children, and only then, so hypertension, secondary hypertension will remain. And it because there is an underlying cause. But this obesity pandemic is going to bring in a new hypertension pandemic in this country, and which can be prevented if all of us are aware of what food we are eating, what food our children need to eat. Our grandparents in homes need to be just let down a bit, not khilao kheer, puri, halwa to our children. And promote healthy lifestyle, less screen time. There are so many guidelines on screen time for children. We have to propagate it. It is imperative that we do it. Otherwise, we'll have a obesity pandemic and therefore a hypertension pandemic. Next slide, please. So we are just coming out of one COVID pandemic, I hope, I pray that we do not land in another, that is the obesity pandemic. Thank you. Next slide. Last slide. Thank you so much.
Thank you very much, madam. Thank you. Madam, as you are a distant speaker, our director, Dr. Shafi sir, would like to present you the memento that will reach to you in a few days.
Thank you. Thank you so much, Shafi. Thank you so much.
Thank you. Welcome. You are most welcome.
Thank you, madam. Now I call upon our sorry. नहीं मैडम को अपन किया था. Now I would like to call upon our next speaker who will be talking on lifestyle modification, the most important part in hypertension, Dr. Mansi Padhyagurj. She is a professor and head of Department of Community Medicine in SMBT College, Nasik. Madam has done her MBBS in distinction in FMT. She has pursued her MD with a first rank from LT-MMC Sion College. She is diploma in public health and she is UGC and also done UGC and NET qualified for her lecturership. Madam is having a huge experience of teaching, almost of around 18 years. She has 26 publication in her name and ICMR 2 projects and UNICEF 1 project. Madam is a resource person for research methodology workshop and medical education unit workshop. Madam is having a huge list of special achievements that she has scored 96% in ICMR, scientific writing in healthcare research, and many much. She is a member of IAPSM and Indian Medical Association. With this, I would like to call upon Dr. Mansi Madam to kindly share her screen and start with her presentation.
Hello, good afternoon. Thank you,
Yes,
Dr.
good afternoon, madam.
Yeah, and thank you very much, Dr. Shafi, for inviting me for this August gathering, a talk to this August gathering. I'll just try sharing my screen. Let's see how it goes.
Okay, madam. Yes, madam, we can see your PPT.
Yep.
You can move to the slideshow. Yeah, you're
This is
all
the
set to
slideshow
go,
now?
madam.
Right.
Madam,
Okay.
you're all set to go. Madam, just please a humble request to concise the topic.
Yes, yes, very much, very much.
Yes.
Because as the topic given to me is extremely general topic, and
Yes.
I suppose since morning everyone has been talking a part of it. So
Yes.
I don't think more elaboration will be needed on this.
Yes,
So
yes.
I have been told by Dr. Shafi to talk on diet and lifestyle modification and hypertension.
Madam, just one interruption. After your talk, we will take the screenshots. So we are waiting for delegates who have not joined yet to join. Okay, so we will wait for your talk. Okay. Thank you, madam. You can continue.
Yep, thanks. Now, as you see, I am from the Department of Community Medicine, and in community medicine, our primary concern is to tell medical stuff to people who cannot understand English, first of all. People who we have to speak in their local language and see to it that they understand complex things, and especially primarily which is related to prevention. So with that objective, I assume that all of the people over here, all of you who have gathered over here, are practicing medicine in some format. So I'm going to talk to you as if how should you approach your patient with all the things that you have learned today and all the things which you already know. How should we approach people and tell them this and get it into practice? So for that matter, you can start it with practicing for your own. So just see if you can apply whatever I talk to your own, and see if you can advise this to patient in the format in which I tell you. That is my basic purpose of this session. The purpose of this session is hardly any dissemination of knowledge, because I think since morning it's been done to a great extent. So now I will be concentrating how you will disseminate this knowledge to your patients in a language and a pattern and a format in which they understand. So with that, I'll start. All of us are working professionals, and this is something which all of us have been struggling. Work life balance are very keywords nowadays, and everybody talks about them. How do we get that, and what exactly does that mean, is something which I'm going to talk now. Now, we have coined at SMBT, we had this session on wellness, and we have coined this very simple term. Let's not go into any jargonish thing and talk, things which are not understood by laymen. Let's talk about something which people will understand. So, wellness is a concept. Wellness is a choice of lifestyle, and it is marked by a balance of mind, body, and spirit. Now you'll say at one point I'm talking about simple language, but this sentence is so profound. Balance of mind, body, and spirit is a very profound sentence. So let's see how we can talk about it. One thing which I want you all to understand, that this is a choice. So you can make this choice. You are in a position to choose this. You are at the role of decision maker in your own wellness. I'll give a half a second to all of you. This is a very simple chart which you can use in your OPDs, especially when you are treating patients with hypertension, or like in the previous session we saw pediatric hypertension. So people you need to screen and start early diagnosis and treatment at the primary and secondary level of prevention when you want to work. You can give this simple chart to your patients and tell them to make a web of this sorts. Now here 1 is the best number and 10 is the least mark. So you might have one individual who says that, okay, at the intellectual level, say you have got a very intellectual person who is working in IT sector. So he might say intellectually you have to come to the center. Center is the best mark. So he will say I am at the level of 2. I'm doing very, very well intellectually using all my academic strength every day. However, the person might say I am very poor socially because I'm so busy, I hardly get any time. So on this level of social well-being, I become just 8. Now at the same time, the person might say, okay, my emotional quotient is not that bad, and so emotionally I might say I'm level at 5. Exercises I hardly get any time, however I still find around 2 times a week to do, so I'll say I'm 6. I'm very, very poor on sleep because of my late working hours, and I'm working with people in the US at their work days, working timing, and so my sleep patterns are extremely poor. Nutrition, somehow I am managing to survive to have good nutrition. So this is a pattern which has come out from this particular person. You can give this type of a graph, which can be called as a simple thing called web of wellness, and tell them to jot them down yourself. So now you know which areas are weak. See, if you attain all these areas at one go, you are going to be well. Wellness is what? Wellness is just using your intellectual capacity, be good socially, have a good emotional quotient, exercise, sleep, and take care of your nutrition. That is wellness in a nutshell. So you will get an idea where the patient stands. The patient gets an idea where he or she stands. And this is a very simple technique which might help you in the OPD. So basically, you have to tell your patient that the patient has to come to a balance between body and mind. When that is achieved, wellness is going to be achieved. Anything goes wrong, something goes wrong with your mind, it goes down. Something goes wrong with your body, the body graph goes down, and wellness will not be achieved. A complete balance is actually what we mean when we say wellness. So, we had, like I defined coined this term that when should I say that I'm all right? When should I say that I'm all well? I personally believe that I say that I am all well when I can get through my day with enough energy for work and enough energy for play after my work time. So I personally feel that we can define this simple thing to our patient that if you get on through your work in the best possible way, you are not getting overtly exhausted. You have enough energy to come home, work, play, take your students, take your children's studies, to spend time with your parents. Then I think you are supposed to be well. Now, what happens is wellness now has very weird type of sort of landmarks which is created by social media, and someone feels that having a six pack is well, a person who can run a marathon is well, but I really do not believe so. I believe wellness is when we can get through our work with enough energy for work and play. That should be defined as wellness. And this is what we should tell our patients. Nothing else matters other than you yourself feeling good about your own day. Now, exercises. So we sit in the OPD and we tell the patients, exercises chalu karo, just as if we are prescribing PCM to the patients. So this is actually never going to work out. They are never going to know what to do, or they might suddenly start doing something and fall more sick, injuring their own ligaments and bones in the process. So exercise can be explained to your patients in four type of exercises. The first is the cardio. Now, cardio is any exercise in which you listen to your heartbeats. So it could be just going up and down the stairs. It could be going out on a walk on the road or in the park. It could be just stepping up and stepping down on the stepper, which is at home, or using a treadmill, or skipping, or whatever that makes you feel. Listen to your own heart. That is, the heartbeat should not be because of fear. Obviously, it should be because of physical exercise, and that can be termed as cardio. Now, walking, running, jogging, stepping, climbing the stairs are the easiest, cheapest type of cardio that can be done. The only thing that you need is a good, comfortable pair of shoes. Even the ones which are really not very expensive branded one, but flat, soft ones fit the purpose. Second is strength training. Now, here is the big issue. This is something, as many studies indicate that Indians are very low on proteins. This is also something we do not look up to. We think strength training is for all the gym people, for the people who pick up weights and all that. And women, khas karke women, are very very reluctant. They feel okay, they will start developing muscles and then they will start looking manly. And this is not for me, this is for men. No. This is for everyone. Everyone should have strength in their muscles to carry their own body weight. We all have to grow old in such a way that we can pick up our own groceries. We do not worry about how to get the vegetable bag at home. We should be doing our own work on our own without any extraneous help till the day of our death. That should be our actual fitness. Having six pack as not a marathon should be our actual aim. And this has to be taught to the patient that weight is very important. Not just take 1 liter of them with the minor stones, then you need now, again and again telling this is because I deal with patients who are really financially they tell them something that they like a patient so that babies. The first thing she told me was हमारे घर में धूप ही नहीं आती because she was staying in a very intense strong slum area. She never got to saw sun outside her house. मैं कहाँ सुखाऊं? So I had to give her other alternative options. So I'm talking in with these type of people in mind who actually need help. Stretching is another very excellent exercise. Just stretch all your muscles uh, because that's going to give relief to all your aches and joint pains. And last and never the least is balancing. Everyone should indulge in some sort of balancing exercise. Simple balancing. I think if you Google just words, 10 number of n number of charts will come. So you have to just pick up the right one for yourself or for your patient. You should, if there is a physiotherapy department around, or you're in a position to explain them to this you have to be explaining with some IC material in hand. So balancing is extremely important because as our age grows, as we lose our strength, we also lose our capacity to balance. So this is the slide which I lingered upon the most because this is one very, very doable thing. And when you start talking about this rise from childhood, as Dr. Apte has mentioned, this will lead to a lot of prevention. Dr. Apte also mentioned that children are going to learn by observation. So you do this, your kids are going to do that. So for your healthy future and your next generation's healthy future, you have to do this. The simple things which you can talk to your patients in their OPDs. Suppose your patient is not at all interested in a structured activity like this, and khas karke this should be for small children where you are not in a position to tell them to pick up strength, like pick up weights and do stretching. They might just not indulge into it. Might not be even safe to tell them to do that. So sports is one of the best thing to do. Sports, cleaning the house, men and women alike should be taking part in doing this rigorous activity. It has got so many side effects of cleanliness also to it. So non-structured exercises are a big yes. Dancing is one very good exercise which you can tell to your kids. And these are all cardio activities. Sports, dancing, and intense cleaning can be very good cardio activities, good for your heart, and so many additional benefits. Now you must have realized that after you have a small walk, after you clean your house, you feel very happy. Obviously, you feel a bit tired, but then you feel very happy. And there's a basic science behind it, which I am very much aware that all of you are already knowing. It is release of happy hormones. And the happy hormones are dopamine, oxytocin, endorphins, and serotonin. Dopamine, the reward hormone, you feel good. Okay, fine. I did this. I walked for 20 minutes today. Good. Love hormone, you feel happy, good for your married life, good for you as a parent also, and a doctor too. Calmness, okay, you feel okay, things are in your control. Yes, things can happen, things are not haywire. And the power hormones, okay, I do have the capacity of doing this throughout the day, so that's nice. So this you should be explaining to your patients that once you do exercises, this is what is going to happen to your body. Next aspect of wellness or lifestyle modification is nutrition. Now, nutrition has got so many theories behind it. So you have got people telling you eat only twice a day. Then people will tell you eat after every 2 hours. So then somebody will come and tell you, no, okay, just cut off all the carbs. Don't give any heed to this balanced diet chart which has been going on for generations, where they tell you to eat the base of the triangle should be of carbs. Just don't do that. Just eat a lot of proteins and your fat will all be lost. So please do not promote this type of nutrition and things for yourself as well as your family and for your patients. This particular nutrition triangle is one of the golden triangles and should be followed to the hilt. The proportions which they have given are time tested, used by our ancestors, and they have survived for a very, very long time. So I think we should be following that. In addition to that, what we should be following is mindful eating cycle. Now, mindfulness is something which I'm going to talk later on. So let's see why you're eating, when you're eating, what you're eating, how standing, sitting in tension, in relaxed mood, how much sitting with a big gallon of popcorn in front of the TV, is this so? Where you are eating, on the couch, on the dining table, where everything is going to matter. So develop good practices, have common food area, let everybody sit over there, finish off your meals in some 20-30 minutes. Do not go on eating again and again and again. Again, energy dense foods, if you follow this, this is going to be taken care of. And please do not go for any type of fads. Diet fads are extremely difficult to control. They lose. We have had so many Miss Indias. Like there have been people who will be off milk and milk products and poultry for a long time, and then they will have this all sort of calcium deficiencies and osteoporosis before they even turn 30. We have got n number of people who are dying in gyms because of doing unregulated exercises. Eating protein bars is something which again the previous speaker has mentioned. So we have to be very, very careful as to what we put in our mouth. And remember, whatever has been going on for ages, whatever our generations of grandparents have done and lived till the age of 80 and 90 is something which should be followed. That's very, very logical to do. Now, sleep. In that web, we had seen one aspect was sleep. Now, what happens is we are really, really underestimating the power of sleep. We should be getting sleep, and these are all the gadgets which have helped us to feel that sleep is no way important in life. And when sleep will cure half your issues, it will make you healthy. And this has to be emphasized when you talk to your patients, when you manage or prevent their hypertension. So, create a healthy work life balance, spend meaningful time with your family and friends alongside work priorities. This is again a very, very underrated thing. I assume that spending time with family and spending time with friends is our tonic to us. It gives us new life, it gives us vigor, it gives us purpose, it gives us so much of happiness. So, this should never, never be underestimated. And this has to be a culture which has to be started in your children by you. Now, current stressors, all we have got so many students in our colleges who are having student debts. I can just imagine their predicament, like how they must be, how they struggle, how they run around for their scholarships. So this starts from very early stage in life nowadays, especially in medicine career. So this is one thing. Another thing is this: we just had Mr. Mark Zuckerberg apologizing to parents in last 2 days, saying that whatever my Facebook and Twitter and what else he owns has done to your children is bad, and none of you should be suffering from this in life. He made a public apology, and the U.S. law Senate members were grilling him like there is no end. Like I was like surprised the way he was grilled. Such a rich man, such a powerful man, but then he had to answer for whatever the social media has done to the current generation. Now, I would also say I would grill Mark Zuckerberg on whatever the social media has done to my elder generation also, because I have got children who have better control on the mobiles and this thing, and I have got senior citizens who are totally addicted to this. So no one of us is. So and this causes a lot of stress because there are always an image that you want to project. There is always something who makes you very nervous, and then this addiction and pollution. I will not go into details of that, but these are destroyers of entire families, and they are destroyers of civilization. So this has to be explained. Pollution is something which I really don't know how we as citizens are going to handle this. Cities are becoming more and more polluted. Like it's very easy to say start using the local transport, public transport, but then not very easy to do at many of the levels. But Yes, these are rising concerns. So whatever we can control, we should be controlling. Then many of the things are just not in our hands to control anything. When we were cavemen, there was this fight or flight reaction. All these cavemen, when the tiger came, they had this either you fight it or flight it or you run away. What happened is the tigers went away in the jungles or got restricted because of us. We have become like now we do not face tigers. Obviously, when we encroach in jungle areas and build our houses, we do see them frequently. But we have still not. We are still struggling with this fight and flight. So whenever we are in that fight and flight, so exam to be given in the morning becomes like a tiger for us. So we feel as if it's a tiger, it's going to eat us up. We have got n number of quota students hanging themselves in and day out. Last few months have been very, very bad for our country's youth, the way they are hanging themselves. So this and what happens is whenever you are in this fight or flight, for example, taking this session, now I'm very nervous. Okay, I'm late. I have to sit over here. Okay. I have to prepare Dr. Shafi away. Otherwise, call me and tell me why are you not in time. So we have to realize that these are not tigers. They are not going to kill us. I might just say sorry to Dr. Shafi and be there and start my session anyways. So we have to recognize for what we have to be take stress. What should stress us? And all these things happen in our body when we get stressed. Thickening of the blood happens, and that is one of the most important precursors of your hypertension. And this is how stress affects us. Emotional wellness, trail of thought, you try to be in the present tense. Now, what happens is if your child doesn't come in time from school, then you are worried, oh my god, कहाँ है अभी तक बस में बैठी होगी कि नहीं पता नहीं कोई I hope she has not met any idiotic people on the way. Oh my god, I hope her cycle has not met with an accident. And then ting tong, and the child comes and the child says the sir took extra class today. So it was as simple as that. But then this entire train of thought which started, that cycle का accident हो गया बदमाश मिल हो गया रोड पे उसको, it just doesn't stop. So we have to train ourselves and our patients to get rid of this train of thought. Live in now. Tomorrow is yet to come. Yesterday is already gone. So why bother? Just live in the present. Just at the moment is something that you have to talk to your patients and practice yourself. So mindfulness is something which is going to help you. Be in the present. Do not think of future to a great extent. Do not think of past to a great extent. Live now. Enjoy your life now. My god, this is the biggest stressor of the current generation, I suppose. Update and update continuously, right from your phone to your laptop. Every gadget that you have held in your hand is going to be updated. Every software gets updated, and you have to, and you are over here today also for a session of update only. So update involve its intellectual wellness, involves your ability and use in the knowledge. So as it is a necessity of life in future, why not enjoy it? Be over there, do it. So update is absolutely essential. If we do not update, we might be in a stress of different sorts. So again, we have to decide how much do we need, how much should I, every Sunday should I go on attending a webinar? When am I going to spend time with my child? If I do not attend webinars, what's going to happen to my current knowledge? So we have to ourselves have our balance into all this. And then yes, there is, as I said, there is nothing like having a good half an hour with your child. Say even watching Shinchan or Doraemon will do, and spending some time with your friends, gossiping about your old days, some time with your mother, just listening to her talking about her old days. And this has to be there. We have to include everyone: short, tall, fair, dark, religion, caste, creed, disability. Everyone should be a part of our life, and we should respect everyone's presence. So that is a social wellness thing that we need to talk to our patient. So all of you just think of one activity that you love the most. For some, it might be singing. For some, it might be painting. For some, it might be just watching a series of television. So such an activity gives you a perfect balance of body and mind. When you're not thinking of your future, you're not thinking of your past. When you do that activity, could be cooking, could be cleaning for someone, could be just folding clothes, could be anything. But One activity you have to find out for yourself, which you will do every day, during which you will be completely in your present tense. That will give you a perfect balance of your body and mind. Will not think about your past nor your future. Live behind all your worries and just be involved in that activity. One such activity per day is absolutely essential. So, just to summarize everything, let's talk about something which we can do really do every day. Maintain a gratitude diary. Thank the superpower to whom you pray for everything good that has happened today. Obviously, everything good might not have happened that day. So pray for a better tomorrow. Do one act of kindness, just bringing a glass of water to your mother, whom you know now she's going to get up and drink water. Picking up a pen and giving to your colleague. One act, one countable act. Keep a diary of that. Post lunch, post dinner walk every day. पोस्ट लंच तो कोई कॉलेज ना नहीं बोलेगा, कोई हॉस्पिटल ना नहीं बोलेगा, 10 मिनट अगर कोई बंदा चला कॉरिडोर्स में तो माइंडफुलनेस, स्टार्ट माइंडफुलनेस. चलो फर्स्ट सिप ऑफ वाटर, पहला निवाला जो खाते हो, पहला सिप जो पानी का पीते हो, उसमें पूरे कंसंट्रेशन के साथ पी के देखो. प्रोफेशनल स्किल, जैसे आप अभी अपने आप को अपडेट कर रहे हो थ्रू दिस सेशन, गेट वन स्किल फॉर योरसेल्फ. Smile at everyone, wish everyone whom you know. Obviously random smiling will make you feel like you bad, but wish people, smile at them. Just a simple act of acknowledgement of meeting after 12 hours. This is one thing which I really believe into it, that dear God, grant me ability to accept things that I cannot change, courage to change things that I can, and wisdom to understand the difference in the two. The best thing that we can do for our own wellness and maintain our hypertension. So contribute to healthy environment, engage in physical activity, good nutrition, healthy work, mindfulness, and wellness for the community. A greater good is going to help you to a great extent, and your patients. So thank you very much.
Thank you very much. Thank you very much, madam. Since last 5 minutes, I've been trying to tell you, okay, madam, please wind up. But you are so enthusiastically and so beautifully speaking, said I could not interrupt in between.
That's very kind of you. Thank
yes,
you.
thank you.
You could
thank
have
you
still, because no speaker should overshoot timing is something.
No, madam. No, madam. You were very enthusiastic and very beautifully. Dr. Shafi sir would like to present the memento to you, so that you are a distant speaker, and that will reach you in 2 to 3 days.
Thank you, sir. Thank you so much. Thank you, Shafi.
Thank you very much, madam. Thank you very much.
Madam, can you end your screen sharing so that we can continue with the session?
Sure.
Okay. Yeah. Okay. So we will be taking screenshot for the attendance. So kindly open your cameras. Okay. And as madam said that we all have to keep on smiling. So many smiling faces.
Just
Okay, thank you everyone. I have taken the, now moving towards our last session, and very important. We have learned up till now what we should do, what are the treatment modalities, and what should be done, the lifestyle modification, but how to prevent. So coming to, let me share my screen. Coming to our next very dynamic speaker. Yeah, Dr. Priya Prabhu or Dr. Priya Deshpande, madam. She is presently Associate Professor of PSM in Government Medical College, Miraj. Madam is having major achievements as project coordinator and master trainer in WHO pilot project for India, HCP preparedness for VAW in GMC Miraj. She is actively involvement in subject module creation for PSM. She is extensive scientific content creator, over 700 plus articles, 330 plus videos, 30 plus online and offline talks for the healthcare awareness. Madam is also having a blog of www.askdrpriya.in. She is having a book on drop of nurture, and she is co-author in that book. Madam is being honored and awards that Madam has received is of Lokmat Sakhi Samman Pushkar for health sector 2022, CEHAT Research Fellowship 2022, Dr. PSN Reddy Oration in State IAPMC, PSM Conference 2022. She is executive member in Maharashtra State IAPSM for 2015 and 2018. She was executive member, and Saroj Jha Award for Gender 2009 in National IAPMC. With this, Madam has got 22 paper publications in national and international journals. With this, Madam, I request you to kindly share your screen and proceed with your presentation. All to you, Madam.
Thank you so much. I hope I'm audible.
Yes, Madam, you are audible.
Okay. First of all, I think I should thank you, Dr. Shafi sir, for making me a part of this wonderful activity. And I must say that all the were very much interested, and everyone was really enthusiastic. And I really felt nice because many of the speakers have given practical advices also. So let's begin today's session, last session. So prevention and control of hypertension. And I just want to wonder whether it is possible. Because we have seen that there are many modifiable and non-modifiable risk factors. And age is one of it. So I feel that we should really need to work hard about it. And I know that majority of you are happy to see me just because I am the last speaker, and all of us have been here online for whole of the day. And I am also that majority of the points that I was going to tell, they have already been covered. So my job now is very simple. I will just go through my slides and it will be like a revision for us. And let's see if I can give you at least one or two points which are different or quite useful for you. Just like previous speaker said that this is going to be very useful for you for dealing with your patients, because I know we have a mixed crowd and majority of you are practitioners. So again, I have kept the points which will be applicable for your practice. So before we begin, I hope you know your numbers. By numbers, I mean, when have you last checked your BP? Usually what happens is we check it once we cross 30s or 40s. Before that, very rarely we get a chance to check our blood pressure. And I think today, all of us have understood that BP could start even in childhood. So every one of you, as well as every member of your family, should get their BP checked at least for the first time. And based on the readings, the next further actions can be decided. And why this is important? Because I am a public health person or preventive person. And I always tell my students that what you learn in preventive medicine is not only about practice or not only about your patients. Please, whatever I'm going to tell you, keep on noting the things for that, because you can use them in practice as well as for yourself or for your family. So, is prevention possible was my question. And if you have understood the concept of prevention completely, then your answer will be yes. Because prevention does not only mean
that it will be prevention of the occurrence of the disease. We all know that various levels of preventions are there, like primordial, primary, secondary, and tertiary. And as per that, primordial prevention activities you can apply to all of your patients, or specifically to the relatives, family members of the patients who you are treating. Then primary prevention will be for those in whom you have identified the risk factors and they have little bit more risk of having hypertension. And various secondary and tertiary activities like screening, treatment, and prevention of complications will be for all patients with or without complications. So let's begin with the preventive actions first, which are the major actions. And like I said, nearly everything has been already discussed. You are free to have screenshots because I have kept my PPT majoritarily pictorial, so that you will have something with you which you can refer back and compare or share with your patients for easy understanding. Now, DASH diet, I have used this infographic so that you will have a visual impression about how much fruits you are supposed to eat as compared to the grains. Grains should be full whole grains, right? And this is the amount of quantity of fruits. Usually we eat fruit as 1 or 2 pieces, but these are servings, 4 to 5 servings, right? Similarly, we have to cut short the dairy, and whatever dairy products we are having, they have to be low fat. So we have to control fat. And about proteins, madam has also discussed. See, the different infographic will tell you what things to eat and what things not to eat. So about some points in DASH diet we'll see in detail. But before that, I have included this slide which will tell you the fruits which are rich in sodium. We all know that we have to curtail our intake of sodium. And this example where food which has high sodium is shown, it is important. You will see that majority of this food is healthy food. Then what to do about it? If your BP is normal, you need not worry. But if a person of hypertension has to choose the food for the day, for example, sweet potatoes is a food which is used in fasting. So a hypertensive patient should restrict or avoid eating sweet potatoes, or have small portion of it, right? So in this way, this information will help you. But what is a better information? Food that is low in sodium, which the person can have as much as the even hypertensive person can have. So asparagus, strawberries, grapefruit, and shrimps, these fruits can be eaten because they have low sodium content. Immediately, when we have to increase our potassium content in DASH diet, these are the examples of food which are rich in potassium. Banana, coconut water, that everyone knows. Spinach is also there. Even potatoes have lots of potassium. And avocado, which is available in nearly every places. And mushrooms or cucumbers. These are the things which we can choose to increase our potassium intake. Now, second important point is cutting down the salt. We always advise the patient to cut down the salt, but having food which has very less salt, it becomes unpalatable. So the better practice is that avoiding all the foods where salt is high. Again, we give common advice like papads and pickles, which we usually remember. But as you can see, the WHO infographic, where they have advised to avoid majoritarily processed food, and then adding salt to food, and most importantly, reading the labels. Now, we don't have this habit of reading the labels, and once you will start reading it, you will be quite surprised about it. So if we read the labels, we will know that bread or various sauce are very high in sodium. And usually we give children sandwiches or sauce to eat with chapatis and all those things. So fries and canned food, everything is high in sodium. So we have to also notice the hidden items or unknown items which are high in sodium. Now here, when we are discussing behavioral change in patients, it will be little bit easier if they have such type of infographics with them. Now, this is a very good infographic which will help them to understand in which zone they are as per their weight. And if they will, on their own, they will understand if they are in a red zone, then proactively they will want to bring their weight to the lower side, at least to yellow side or to green side. So you yourself also can see whether in which zone you are at present. And I hope that this may have some effect on your wish to start exercising, about which madam has described various types of exercises and all. One more thing that you can do is have BMI calculators which are available, and immediately you can show your patient how to calculate BMI. And one more thing is, when a patient walks in your OPD, just notice his abdominal obesity. So that is the obesity which will lead to more risk as compared to overall obesity, or which is just subcutaneous, right? So these small observations will help you identify a person in whom you want to assess the risk. Now, about exercise, keeping active is important. And if you have listened to madam's session, she has given you many examples in which one can remain active. So usually what we advise is advising 30 minutes exercise for at least 5 days a week. So that has come from a advice or a observation, evidence that at least 150 minutes a week exercise, aerobic exercise is needed, in which heart rate increases. And now it has been added that muscle strengthening activities should be done at least for 2 days. So whole week is covered now. For 5 days, half a hour activity of aerobic exercise and at least 2 days of muscle strengthening exercises, right? And apart from that, a person can choose from various ways, and resistance exercise which builds the muscles, as well as stretching exercises and balancing exercises, because one has to avoid the falls especially in old age. Now, minding the alcohol quantity. If you have listened to the previous sessions, sir has mentioned about a J curve where very less quantity is shown to be beneficial, but it could be a statistical fallacy also. But remember, you should never advise a patient to take alcohol in small quantities, because no level of alcohol is safe, because every intake of alcohol increases the risk of cancers. So you cannot decide that it could be beneficial for one disease and harmful for other disease. So if a person can stop alcohol, well and good. If he cannot stop, then we have to advise to reduce to 1 drink per day for women, and at least minimum 2 drinks for men per day, not more than that. And if possible, stopping is the best example. And you can tell them it is based on the content of the alcohol. So stronger the liquor, lesser the quantity should be. And you can guide them towards various psychiatric institutions or centers where de-addiction is being done, because leaving addictions is very difficult, which is evident from this PPT, this slide. This is about tobacco, and we all know that quitting tobacco is very difficult. And those who are from metro cities, they are aware that in metro cities, females are also having smoking with increasing proportion. So here in this corner, they have shown a graph where smokers who attempted in the past year and smokers who were successful in the past year. As you can see, even though around 66% have attempted, only around 10% were successful. So it's very difficult to stop. So the best way to stop is before one starts. It is said that if you directly start smoking, then you will suffer and it's very hard to quit. But if you have first remove your desire for smoking, find out what is the reason you want to smoke, and then it might be possible to quit. So as a physician, simple things that you can do is systematically identify all tobacco users at every visit, then strongly urge all smokers to quit. You can have risk calculators to show them just by quitting smoking how much risk they are reducing. and then it will help you to identify the smokers who are willing to quit, and they will need support. They will do attempts, they may fail, but your positive support will help them to stop smoking and aid the patient in quitting by having a quit plan or having pharmacological therapies or supplementary material and all, and schedule follow up and keep in touch. And even if they fail, do not scold, just support them and praise their attempts. One more thing, that electric cigarettes that are very popular in youngsters nowadays, and they are as harmful as or more harmful than the regular smokings. So while taking history, people may say, I don't smoke BDs or cigarettes. You have to specifically ask about vaping or electric cigarettes to the patients and tell them that it is equally harmful. I think the importance of stress cannot be emphasized enough, and people have seen that as they grow in the ladder of their career, their stress increases, and because the stress increases, they land up in various episodes or diseases like hypertension. So here I have again shared you a colored diagram where activities like feelings, thoughts and thinking, physical signs and behaviors and examples are given, and this is the color coding or color triage is there. So red is the highest stress and examples are given, and all of us know that doctors have maximum stress because of various reasons. Stress could be because of family or patients or hospitals or financial or pressures from the society and so many things. So please also heal yourself, and you can use this for identifying the patient's stress, and accordingly here INH has given this way how to reduce the stress. In that, master stress is the acronym, and you can just see that these are very simple activities like healthy eating or avoiding social isolation. We have mobiles in our hand, we have accounts in social media, but it's we have seen that we have become alone, the human contact is missing. So proactively having human contact, avoiding social isolation is very important for reducing the stress. Stay informed, but avoid being over informed or being stressed because of that. Talk with people, be mindful, relax, play, exercise. Journaling is very helpful. When in stress, deep breathing helps. Sleep is important. Gratitude practice is very important, and contact with nature is important, as well as seeking support whenever needed from friends, family, and whenever needed, seeking from the professionals. Doctors are the worst patients, and we avoid seeking help from the professionals, psychologist or psychiatrist, even if we are suffering. So please avoid that, because the effects of hypertension and the complications are not comparable to a simple act of reducing the stress in time. And just learning by some techniques, we can reduce the stress. Even WHO has this online platform, which is WHO Stress Management. You can find it on WHO website, or some reels are there or links are there, bit.ly, and the word will give you the link. It is I think chat bot in WhatsApp or Messenger, and by this chat bot you can have the skills to control the stress, and they have beautifully given you it is a very detailed chatbot, and you can again refer this to your patients also. Okay, so this was about the primary hypertension and the preventive activities, major preventive activities. But also know that secondary hypertension is also a major component. So as doctors, it is our duty to try to avoid the person's risk for secondary hypertension. So as a doctor, whenever you are prescribing drugs like NSAIDs or COPs, just have a thought that what is the risk score of that person for hypertension and prescribe accordingly. Screen for kidney diseases. Obstructive sleep apnea has already been mentioned and discussed, and it is really important because reducing in oxygen level will lead heart to pump more and increase the pressure. So it's a very simple way in which you can screen and correct it. Many ENT people will have some corrective surgeries also for this. So recreational drug use, which is increasing in younger generation, so it will lead to a epidemic in future years. Renal vascular diseases and tobacco use goes hand in hand. Thyroid diseases are sometimes missed out, so having thyroid profile will also help. And lipid dysfunction, we have to correct that so that to avoid the further complications. So don't forget these things. Then we come to the next part, that is what we can do after diagnosis in prevention. Drug adherence is the most important thing. We all have read about the rule of halves, and in I think second session we have also seen that many people are undertreated. So drugs means the irony about hypertension is that it is a quite simple disease. We know everything about the disease, we have the drugs, but the only problem is that patients are not taking the drugs. Again, one of the previous speakers have mentioned about if influenced by the other pathies. So you have to discuss with the patient, ensure that the patient is taking the drugs or following your advice. So talking with hypertensive patient, discussing their problems and trying to find out the solutions is very important. Government has come up with various hypertension protocols, and in that monthly follow-ups in the initial days, starting with one drug, increasing the dose and then adding second drug. In that way, very systematically they have given the information, and if it is not solved, then discussing with the patient whether adherence is good or not, it is there. So here are few tips in which you can improve compliance of any of your patients, not only hypertensive patient. The first one is therapeutic patient education, where you discuss with or ensure that they have understood and solve their queries or answer their questions or doubts. Simplified treatment regimens, where either once a daily or combined agent, combined tablets are given, and you help them to remember how to remember to take the drugs, because taking drugs is not easy. All of us have missed antibiotics one or the other times. So lifelong treatments are very difficult. So support patients in that. Minimize the cost as much as possible. Then help the patients to have reminder programs or reminder plans or apps, or nowadays some such type of drug containers are there which will help them to understand whether they have taken drugs or not. Then early follow-ups or short-term treatment goals, or showing them that see your hypertension now has reduced because of the treatment, and praising their efforts, all will go. And maximize the placebo effects and minimize the nocebo effects, because patient already has some beliefs about side effects and they will feel that they are having the side effects. So you have to discuss all those. Regular follow-up importance cannot be emphasized, because in hypertension, because it is always changing, there might be chance that once stress reduces, once their weight reduces, once they start exercising, they modify the modifiable risk factors, there is a chance that their BP will go down with your dose. So you have to always see whether control is correct or not, or whether it is leading to lower blood pressure. So in that way, monitoring blood pressure is very important in each visits. As interns, what we have done is we have just written 120/80 for nearly every patient. But as practitioners, you should actually note, and again, I think one of the speakers have given you practical ideas about which BP machine to use and how to note and all those things. So regular screening about all possible complications, all the investigations, and again, timely referrals if you have any doubts, and collaborating with your colleagues is very important. Patients should be told about the warning signs, because those are the people who will neglect their warning signs. So they should know the warning signs like shortness of breath or severe headache, chest pain, blurry vision, dizziness, nosebleeds, or heart palpitations. So all these may indicate either BP is high or some complication is occurring, and they should know what to do, how to reach hospital at the fastest. Or sometimes like chest pain, they should know what to do, have some aspirin immediately, or some simple advice like this. I cannot again stress the importance of self-care. JNC 7 has recommended that people should engage in the 6 self-care activities. So hypertension management is incomplete if you do not take the patient on board, and not only the patient but even the family on board, because diet changes and all these things are not possible without the support of the family. So adherence of to the antihypertensive medication is the patient's duty. Following the DASH diet, engaging in activities, physical activities, stopping or reducing tobacco exposure, weight management, and reducing the alcohol consumption. And these are the same activities which will lead to prevention of hypertension also. So you can discuss these things with your kids, with your youngsters, with young people, and even with older people, so that they will follow these things to prevent hypertension as well as for control hypertension. Now, what is government doing in all these things? So in short, we will just have an idea what is happening. We all know that for prevention, we can have population-based strategy or high-risk-based strategy. Government has a national health program, and now the program is, now the name has been changed, but the program is there since 2010, National Program for Control of Prevention of Non-Communicable Diseases. So we have clubbed majority non-communicable diseases together. Since 2017, a population-based screening was going on for 5 conditions: hypertension, diabetes, CA breast, CA cervix, and CA oral cavity. So these 5 conditions were being screened because it's very easy to screen, and the data was available with the ASHA workers and all, which patient have diabetes in their community and all. Government has started having CHOs, that is community-based officers, as sub-center, so that rural people will have some medical care immediately by a trained person who could be a doctor from other pathy or a trained nurse with additional training. We all are having now ABHA, Ayushman Bharat health accounts, where all our health records will be kept together, so that even if a person visits some other hospital in an emergency, all his previous records, all his history will be correctly available if it is there in Ayushman Bharat health account. So linkage is possible. The government has also included other NCDs, priority NCDs like COPD, asthma, CKD, which again leads to hypertension, and NAFLD, which again is a major health problem but neglected, which is non-alcoholic failure of liver, right? Then CBAC is community-based assessment checklist, which gives uniformity to the assessment of the risk of a person. I am going to show you that so that you can use it in your clinics. And various BCC wellness activities are going on, like Fit India and Eat Right movements. And most importantly, we have had India Hypertension Control Initiative, which linked all the information and provided uniform treatment options for the hypertensive patients, and it's already going on by the government. So this is the CBAC that I mentioned, that is community-based assessment card, in which these 6 points are noted, and this is very easy. Immediately you can do. You can do an assessment for yourself also. And if you see that once you cross 50 years of age, and if you are having a sedentary lifestyle as a doctor, because many doctors have sedentary lifestyle because of lack of time or lack of opportunities or busyness in the work, then immediately you are at 3. And if you have a family history, then you already have crossed 4. So we have to focus on the 4 preventable activities or modifiable factors, that is tobacco, alcohol, weight, and that is mainly waist measure. For hypertension, more the risk, more proactive control is needed. And lastly, what is the future?
It will be very kind to conclude.
Yeah.
It will be very kind to conclude, madam, in some
Yeah,
minutes.
this is last.
Okay,
The future,
okay.
what is the future?